Good morning, everybody. So, attendees obviously are not able to talk to us. They don't have a mic. We are not able to see them, but they are able to see us. So, we'll be starting our meeting in next couple of minutes' time. Thank you for bearing with us. Professor Dame and Watkins at the moment attendees are joining us. Thank you for being a panelist with us. We're waiting for Professor Robinson also to join, just in case if he's a little bit late, so I will offer you to come first then. No pressures. You're mute at the moment.
Sorry, so you want me to do my talk now? Or?
Yeah, we'll wait. I still need to do an introduction to the meeting.
Oh, right.
So
Okay.
we'll wait for Professor Robinson to join, just in case if he's running a little late, so then I will ask you kindly.
Oh, yeah, no, that's fine. Whatever.
Okay, good morning, everybody. We'll start our meeting in a formal fashion now. I'm Dr. Ali. I'm a stroke physician and divisional clinical director in medicine in Northern Lincolnshire and Gould NHS Trust. First of all, thank you for registering yourself to be a part of this stroke masterclass. We are running this stroke masterclass for last 13 to 14 years now. It is on an annual basis. We used to do it on a face-to-face because of the COVID and COVID crisis. We are doing it first time virtually. So bear with me and with my panelist colleagues and co-host because obviously they can be technical age. We are not into IT and we don't have any IT help. We are managing ourselves. And just to give you background about this meeting is, this meeting is being done in Northern Lincolnshire and Gould NHS Trust for 13, 14 years now, because obviously we are living in little periphery and we wanted to have our own masterclass so that we can have us invite speakers and we can have our own education and improve our knowledge and skills. So I'm thankful to all the speakers all over the last 13, 14 years to be part of this stroke masterclass. Special thanks today to RMU alumni. RMU alumni is Rawalpindi Medical University from Pakistan. And alumni is the doctors which are from RMU alumni in UK. They are supporting this event and I'm thankful to them that they are providing the Zoom platform so that we can conduct this meeting on a virtual basis. So another sponsorship grant is being given by Medtronics. Medtronics is helping us in educational events so that we can run these educational events free of cost. or to a minimum cost. So thank you to Medtronics also for sponsoring this masterclass today. The attendees at the moment, 300 attendees has registered, and they are joining us at the moment. They are all over the world. Many are obviously locally from UK, and then other countries which are participating is Pakistan, UAE, Saudi Arab, Malaysia, and Ireland. So, so good morning to all people in United Kingdom. Assalamu alaikum to people in Saudi Arab, Pakistan, Malaysia, and UAE. And good afternoon to all of you, because obviously the time difference is there. And we have got a panelist. We have got a long list of talks today, and 6 CPDs points has been approved by Royal College of Physicians, UK. And I'm hoping that would be an exciting day for all of you. So question and answers point of view, if anybody has got a question and answer, please write it in the question and answer box. It is on the bottom of your screen. And I will be able to ask the speaker these questions on your behalf. Because the attendance is 300, it will be difficult if I open up the mic for everybody. It will cause more of issue then. So I would like to say that our first speaker, without any delay, is Professor Robinson. And Dr. Professor Robinson is kindly uh, um, giving us a talk on very important topic. First of all, I would like to introduce him. He is the Deputy Head of College of Life Sciences, Professor of Stroke Medicine, University of Leicester, and NIHR Senior Investigator. He is the past President of British Association of a Stroke Physician. He is the Chairman of European Stroke Organization also. So the topic today is very important to me. I normally choose topics which is close to me because these are important for the stroke physicians. So today's topic is the new antithrombotic agents. Are they better for secondary stroke prevention? So over to Professor Robinson. Kindly take over now.
Thanks very much. Hopefully everybody can hear me, and thank you for the kind invitation. And I will try the technology of sharing my screen and making sure I share the right bit. And hopefully everybody can see those slides. Without further ado, and conscious that you're very keen that we leave time for questions, I'll proceed. So those are my declarations of interest, and in particular those apply to material I'm going to be covering within this talk. Important topic, and so tricky to know exactly where to start. So I thought I would really focus on the most recent American guidelines looking at early management of patients with stroke, and in particular cover aspects that they offer guidelines with respect to hyperacute secondary prevention, and in particular the role of dual antiplatelet therapy and the potential role of ticagrelor and novel agents, and in particular factor 11A inhibition, as well as talking about secondary prevention and the information that we have on triple antiplatelet therapy. And then in the context of patients with atrial fibrillation, the timing of anticoagulation as their preferred antithrombotic therapy. And clearly for some of those objectives are also be wearing my NIHR hat and talking about ongoing trials that we hope will provide an answer to some of those questions. And indeed, there's still an opportunity to participate in those trials. So why, when I've been asked to talk about secondary prevention, do we look at hyperacute and the emergency period? And I think this editorial by Peter Rothwell at the tail end of last year in the New England Journal of Medicine probably highlights the importance of thinking about secondary prevention with antithrombotic therapy early. And to quote, without urgent treatment, the risk of major stroke in the week after TIA or minor stroke can be as high as 10%. Some studies have shown that immediate medical treatment with antiplatelet agents and statins as well as blood pressure control, reduces that risk by 70 to 80%, with the benefit attributable mainly to aspirin. Nonetheless, there's a residual 7-day risk of recurrent stroke that's around 2 to 3%. And the question he poses is, given the effectiveness of aspirin, might more intensive antiplatelet treatment with another drug or with dual antiplatelet therapy reduce this residual risk? So the current American guidelines, the relevant sections are in section 3.9, bullet point 2 and bullet point 4. Minor non-cardioembolic ischemic stroke, defined as an NIH score of 3 or less, in patients not treated with intravenous thrombolytic, dual antiplatelet therapy, and they recommend aspirin and clopidogrel, started within 24 hours of symptom onset and continued for 21 days. And they cite that as strong and recommended, with evidence that's high based on one RCT or meta-analysis. They also start to comment on ticagrelor and say that that's currently not recommended over aspirin for treatment of patients with minor acute stroke, on the basis that there's no benefit. And that's on the basis of moderate level of evidence based on one well-designed randomized study. But clearly there has been some further publication since that point. So dual antiplatelet therapy, based the American guidelines principally on 2 trials, the CHANCE trial published in 2013 and the POINT trial published in 2018. And just comparing those trials, so CHANCE had a 24-hour window, POINT had a 12-hour window. They both recruited patients with minor acute ischemic stroke, defined by an NIH of 3 or less, or high-risk TIA, defined by an ABCD2 score of more than 4. Good numbers, nearly 2,500 in each arm for both trials. And in terms of CHANCE, loading dose of clopidogrel was 300, followed by 75 for 90 days, in combination with aspirin 75 for 21 days. The comparator arm was 90 days of 75 milligrams aspirin. For POINT, the loading dose was 600 milligrams of clopidogrel, continuing a 75 milligram dose for 90 days. The aspirin dose varied between 50 and 325 and was given jointly for the entire 90 days. The comparator was aspirin monotherapy. Just some key baseline characteristics, just so you can compare those with the types of patients that you may be seeing and maybe implementing this evidence in. So mean age, mid-60s, about a third to just under a half female. CHANCE, the mean time of randomization was 13 hours, in POINT around 7 hours. About a third of the patient, so a quarter of the patients in CHANCE were TIA, nearly half the patients in POINT were TIA. ABDC2 score in CHANCE 4, in POINT 5, and the median NIHS was given in POINT and was 2 in both arms. In terms of efficacy, for CHANCE, it was all stroke. For POINT, it was ischemic stroke MI and vascular death. And both, as you can see, showed a significant reduction in the dual antiplatelet arm, 8.2% compared to 11.7% in CHANCE, 5% compared to 6.5% in POINT. The safety outcomes, moderate and severe bleeding in CHANCE, major hemorrhage in POINT, no significant differences in CHANCE. It was significantly higher at 0.9% in POINT. And as I'll come to later, just to point out that CHANCE looking at all stroke, clearly ischemic stroke in POINT, there was a significant reduction in the ischemic stroke secondary outcome with dual antiplatelet therapy in both trials. I'm just going to touch on the FASTER trial, and the reason for that is I'm going to present a meta-analysis from the BMJ, and that also included data from the FASTER trial, so a much older trial from 2007, undertaken by the Oxford group, 392 patients, again with TIA or minor ischemic stroke up to an NIH of 5, within 24 hours of symptom, and with a 90-day outcome. And those patients all received aspirin. In addition, they could receive clopidogrel, loading of 300, maintenance of 75, or placebo, or statin at 40 milligrams, simvastatin 40 milligrams, or placebo. And if you look at total stroke in the combination arm, 7.1%. When you look at the antiplatelet side, 10.8% in the aspirin monotherapy, so a non-significant risk reduction with combination therapy, not at the expense of an increased risk of hemorrhage, with very small numbers of hemorrhage, intracranial hemorrhage seen. So these were brought together in a meta-analysis in the BMJ in 2018, which looked at outcome within 90 days, dual antiplatelet therapy, quoting events per 1,000, single antiplatelet therapy, events per 1,000, and a conclusion with the quality of evidence, and suggesting that dual compared to single antiplatelet therapy produced 19 per 1,000 fewer non-fatal recurrent strokes, 14 per 1,000 fewer with functional disability at 90 days, and 13 per 1,000 fewer with a poor quality of life at 90 days, at the expense of 2 per 1,000 fewer moderate or major bleeds at 90 days in the single antiplatelet arm, and 7 fewer minor bleeds. The other thing that they looked at is duration of therapy, and coming to this American recommendation for 21 days as opposed to 90 days, given, as you will recall, the trials looked at different durations of dual antiplatelet therapy. And overall, there was no important difference in ischemic stroke if you gave dual antiplatelet therapy for 21 days or 90 days. But there were fewer per 1,000, 3 per 1,000 major bleeds if you restricted the dual antiplatelet therapy to just those first 21 days, and hence the current recommendation in the guideline. So what about alternative therapy? So ticagrelor was first looked at within the context of the Socrates trial, published in 2016. Non-severe ischemic stroke, definition NIH of 5 or less, high-risk TIA, ABCD2 of 4 or more, within 24 hours, not treated with intravenous thrombolysis or mechanical thrombectomy, over 5,000 in each arm, randomized to a 180 loading dose of ticagrelor and then 90 BD, or 300 of aspirin with 100 maintenance dose for 90 days, and really no significant differences in outcomes. Most recently, and this was the editorial by Peter accompanying this trial's publication within the New England Journal, and the Thales trial, mild to moderate ischemic stroke, again, an NIH of 5 or less. Or TIA within 24 hours, again, not treated with intravenous thrombolytic or mechanical thrombectomy. And here they're looking at combination therapy again. So the combination arm, a loading dose of 180 ticagrelor, 90 BD, maintenance for 30 days, plus a loading dose of aspirin, 300 to 325, and then a maintenance dose of 75 to 100 for 30 days, compared to placebo, plus the similar doses of aspirin monotherapy. And again, just to kind of let you compare these with populations that you see, a mean age of 65, just over a third were female, and just over a third were recruited within 12 hours. About 10% had TIA, the median AB, so the percent with ABCD2 of less than 5 was 1, so most of these were high risk, and 60% had an NIH of 3 or less, and the remainder had an NIH of 4 or 5. So again, comparing outcomes, and the primary efficacy outcome was stroke or death, and that was reduced significantly at 5.5% compared to 6.6% within the dual arm. at the expense of a significantly higher, though still relatively low rate of severe bleeding at 0.5 versus 0.1%. And again, if you look at the secondary outcomes for ischemic stroke, this again was significantly lower at 5% versus 6.3% in the dual antiplatelet arm, with overall no significant difference in the overall levels of disability. So going back to Professor Rothwell's editorial and his current interpretation of the data, which I suspect is better than most people's, given his extensive knowledge of the antithrombotic literature. And favouring combination clopidogrel and aspirin in high-risk patients, on the basis that relative reductions in recurrent ischemic stroke, and hence presenting the secondary as well as primary outcome data, might marginally favour clopidogrel and aspirin based on chance and point, rather than ticagrelor and aspirin based on Thales. The relative increased risk of major bleeding, though low, was greater with ticagrelor and aspirin than it was for clopidogrel and aspirin, particularly for intracranial hemorrhage. And the lower overall risk of disabling or fatal stroke with clopidogrel and aspirin as dual therapy rather than aspirin alone, but not ticagrelor and aspirin than aspirin alone, suggested at the current time, though ticagrelor is clearly of interest, the dual antiplatelet therapy favoured would be clopidogrel and aspirin in the context of definition of minor ischemic stroke and high-risk TIA. Fortunately, more data is probably shortly on the way. So the CHANCE-2 trial is subject to continuing to be able to recruit and to target. Will have its last planned patient follow-up in September 2021. And this end date's not been updated on clinical trials based on the difficulty in recruiting to trials over the last year for obvious reasons. It's quite specifically looking at those with a certain loss of function carrier status, again within 24 hours of TIA or minor stroke. The intervention here is in the intervention arm, dual therapy with a loading dose for 1 day, then dual for 21 days before reverting to ticagrelor monotherapy. And in the comparator arm, the dual therapy is clopidogrel and aspirin, loaded, continued for 21 days before reverting to clopidogrel monotherapy. And the outcome of interest is new ischemic or hemorrhagic stroke within 3 months. So as I say, those data are awaited with interest, and clearly, particularly in combination with the Thales data, may provide more evidence of alternative agents that could be used in the context of dual antiplatelet therapy. Okay, then moving to secondary prevention, and the other key recommendation from the American guidelines. So again, non-cardioembolic ischemic stroke, triple antiplatelet therapy, aspirin, clopidogrel, diapridamole for secondary stroke prevention is harmful and should not be administered. So causes harm based on one well-designed randomized study, and that was the study of Philip Barth, the TARDIS trial, presented in 2018. Ischemic stroke or TIA within 48 hours, treated with triple versus guideline therapy for 30 days. So the triple therapy was loading aspirin, loading clopidogrel, followed by continuing dose, and then diapridamole. The guideline in about just under half was aspirin and diapridamole, and just over a half was clopidogrel monotherapy. Again, high 60s, just over a third female, slightly later to randomization, mean of 29 hours, just over a quarter TIA, median ABCD2 was 5, median NIH just under 3. And the reason this was stopped prematurely by its DSMB, and also informed that American guideline was that there was no significant difference in ordinal stroke or TIA as the primary outcome, but a highly significant increase in hazards of 2.5-fold and with bleeding in that triple therapy arm. And that was a combination of fatal, major, moderate and mild bleeding, with no bleeding in 80% of the intensive arm and no bleeding in 91% of the guideline arm. Okay, so thinking about other novel therapies, rather than with ticagrelor or repurposing therapy that our cardiology colleagues have been using for some time. So two trials on the NIHR portfolio at the moment for stroke related to factor 11A inhibition. So activation of factor 11 occurs during the amplification phase after formation of small amounts of thrombin by contact activation, and is felt to drive thrombin generation and therefore promote thrombosis. But it doesn't seem to have a major role in hemostasis. And therefore, the view is that there may be a benefit in terms of antithrombotic effect without an increase in bleeding. And so data to support that comes from animal studies in that knockout mice are protected from thrombosis, that reducing factor 11 shows strong antithrombotic effects without increase in bleeding time, even when you add in dual antiplatelet therapy. In the clinical environment, those individuals that are factor 11 deficient seem to have a reduced instance of venous thromboembolism and stroke, and only occasional hemorrhage, and some early clinical studies within an orthopedic population. And so just to explore those in a little bit more detail. So this graph is those who have normal levels of factor 11 versus those who have factor 11 deficiency at mild to severe levels. And you can see that they, over an observational follow-up up to 14 years, have a lower rate of cardiovascular events as defined by MI, stroke or TIA. And in those patients who have factor 11 deficiency and ischemic stroke, whether with AF or without AF, those rates are much lower in those who are factor 11 deficient. And then in terms of proof of concept, probably just looking at these two areas here. So firstly, at this higher dose of factor 11A inhibition compared to enoxaparamine within an orthopedic population preventing VTE after total knee replacement, there's a significant reduction in the percentage of patients with venous thromboembolism, and that is not at the expense of major bleeding, with significantly lower rates of major bleeding compared to enoxaparamine. So that brings us to the Pacific program. So my conflict of interest here is I'm the national lead for the Pacific Stroke program in the UK. It's a program actually that is looking at use of factor 11 inhibition in an AF population, in a stroke population, and an acute heart attack population, comparing different doses of the compound 2,4, quadruple 3,4, by comparison with other therapy. And in the context of stroke, we now deal with that in more detail. So randomized placebo-controlled double-blind parallel group dose-finding phase 2 study, international in its breadth, and looking for acute non-cardioembolic ischemic stroke. The inclusion criteria, 45 years or more, non-cardioembolic ischemic stroke with signs and symptoms lasting for more than 24 hours, or evidence of acute brain infarction on CT or MRI, and the intention to treat with antiplatelet therapy during the course of the study. And brain imaging has also ruled out hemorrhagic stroke or other pathology. There are two parts to this. We're anticipating changing from Part A to Part B sometime in early to mid-March. Part A is including patients with stroke up to an NIH of 7 or less. Part B, including those up to an NIH of 15 or less, and will allow the inclusion of patients treated with intravenous thrombolysis or mechanical thrombectomy at least after 24 hours after that intervention. All patients need to be randomized within 48 hours of onset of symptoms, and they require an MRI before randomization or within 72 hours, as well as, of course, informed consent. So building up the study, as I say, two parts, Part A and Part B. Essentially, the randomization will be to one of 3 doses of active compound or placebo, in addition to antiplatelet therapy, whether that's single or dual, depending on the patient's NIHSS and the local clinical practice. Visits across a year, with some of those including, at least for Part A, follow-up MRI. The objectives of the study, so to assess dose response of 3 different doses in reducing symptomatic ischemic stroke and covert brain infarct detected by MRI, and hence the MRI follow-up, as well as other endpoints in those with acute non-cardioembolic ischemic stroke treated with antiplatelet therapy, and the safety objective to evaluate instance of bleeding and to see clearly if there's any difference between this agent on top of antiplatelet therapy versus antiplatelet therapy alone. The other trial ongoing is Axiomatic SSP, and Jessie Dawson is the UK lead for this. And my understanding, this isn't currently looking for new centres. I should say that for Pacific Stroke, we're not looking for new centres, but assuming that that goes to a phase 3, and assuming the UK continues to meet its current recruitment targets, then I suspect that we will be invited to participate in the phase 3 trial, and clearly we'll be looking at many more centres. Axiomatic, again, this factor 11A inhibitor, 2,350 patients, planned last follow-up in March 2022, and placebo was 7 dosing schedules versus aspirin and clopidogrel, and looking at new ischemic stroke or new covert infarction on MRI within 90 days. Okay, so on to anticoagulation as a component of antithrombotic therapy, and again back to the guidelines, and really just to highlight the kind of key questions. So for most patients in the setting of AF, reasonable to initiate oral anticoagulation between day 4 and 14 after onset of neurological symptoms. A moderate recommendation based on non-randomized evidence. And what I'm going to be highlighting is the ongoing trials in the UK, where there is still opportunity to participate and to kind of address this really important question for all of us. So I think we're all very familiar with the role of non-vitamin K antagonists for stroke prevention in AF, with these large trials of large number of patients, with the exception of one double-blind, double-dummy design, with BD or OD dosing, mean age of 70 and above, with follow-up mainly up to 2 years. Looking at the CHADS-2 score in those studies, vary between 2.1 and 3.5, with the variation between 19% and 55% entering because of prior stroke or TIA. In terms then of a pooled meta-analysis, including all these studies published in 2014, non-significant reduction in ischemic stroke compared to warfarin, significant reduction in intracerebral hemorrhage compared to warfarin, non-significant reduction in MI compared to warfarin, and a significant reduction in all-cause mortality. With respect to intracranial hemorrhage, as we know, a significant reduction in intracranial hemorrhage rates compared to warfarin, and a significant increase in GI bleed reading rates compared to warfarin. And so the current consensus based on the European Society of Cardiology guidelines, looking at this TIA ischemic stroke population where intracerebral bleeding has been excluded, is the 1-3-6 12-day rule, as we're probably all familiar with. And for TIAs, start pretty much immediately. For mild stroke, defined by an NIH of less than 8 at 3 days. For moderate stroke, defined by an NIH of 8 to 15 at 6 days. And there is a suggestion about evaluating for hemorrhagic transformation. And similarly, severe stroke, NIH of more than 16 at 12 days. Again, there's a suggestion of an evaluation of hemorrhagic transformation. But clearly, this remains an unresolved clinical dilemma, and I'm grateful to my colleague David Werring, who I know is talking later on in this event around stroke and COVID, but he's very kindly lent me these slides so that I can, on his behalf, promote his really important trial in this area, Optimas. And so we have this dilemma between wanting to reduce the risk of early recurrence of ischemic stroke, particularly in an atrial fibrillation population, but the risk potentially of intracerebral hemorrhage and or hemorrhagic transformation of infarct, dependent on how early we introduce anticoagulation. So the Optimas trial aims to determine the optimal timing of anticoagulation after acute ischemic stroke in patients with AF by comparing early initiation of any DOAC at a dose licensed for stroke prevention in AF within 4 days, so 96 hours, versus standard initiation of any DOAC at a dose licensed for stroke prevention in AF no sooner than day 7 and no later than day 14, with an outcome of interest of 90-day symptomatic intracerebral hemorrhage, recurrent ischemic stroke, and systemic embolization. On the left hand of this slide, you can see there's a large number of active sites within the UK. And on the right-hand side, you can see that he already has plans for further site initiation, especially in Scotland. Nonetheless, David's very interested in further sites. Here we have what was the trajectory for recruitment. This is the current recruitment rate as anticipated, and in common with a lot of the stroke portfolio, there was a real slowdown in recruitment during COVID, and it has started to pick up again. And I have to say, David has and his team have been one team that really have been able to continue to support their sites during COVID and continue to be able to recruit and set sites up, including actually during the latest wave. But nonetheless, very keen to hear from people who may be interested, and that's the email address ctu.optimas@ucl.ac.uk for those who want to contact David. So the other ongoing study, and again, I'm grateful to Jessie Dawson and my colleague in Glasgow for these slides. Jessie is running the ELAN trial, and this is part of a collaboration across Europe, and this is the UK part of it. The aim here to determine the net benefit of early versus late initiation of DOACs in patients with acute ischemic stroke related to AF. Population, he's defining 3 types: minor, less than a 1.5 centimeter lesion on imaging; moderate related to branch vessel disease, major related to large vessel disease with AF, and comparing early initiation, which is within 48 hours for minor and moderate stroke, 6 days plus 1 day for major stroke, versus late initiation, which is 3 days for minor stroke, 6 days for moderate stroke, 12 days for major stroke, so in line with the ESC guidelines, and looking at 30-day major bleeding, recurrent ischemic stroke, systemic embolization, and vascular death rates. This is just the schema in terms of times for randomization post onset, 30 and 90-day follow-up, and essentially early versus late at minor, and then early versus late for moderate and major. So 68 sites participating at the moment in 11 countries, and currently recruited 959 of 2,000, so just about halfway. That is the trajectory of this trial. In the UK, there is 334 patients, just behind Switzerland, albeit the UK started about 10 months after Switzerland, with a recruitment rate of just under 11.5 participants per month. Jesse's not currently looking for more sites for that trial, and the plan will be that we'd support Optimas as a network for those who continue to be interested, and this is an important research question. So in summary, Chair, in minor non-cardioembolic ischemic stroke, NIH of less than or equal to 3, patients not treated with intravenous thrombolysis, dual antiplatelet therapy with aspirin and clopidogrel, started within 24 hours, continued for 21 days, is effective in reducing recurrent ischemic stroke. I hope I've shown that ongoing trials will address alternative dual antiplatelet strategies, and in particular that with ticagrelor, and we await the results of CHANCE 2, and also novel agents, and in particular factor 11A inhibitors. And we wait the completion of phase 2 studies, Pacific Stroke and Axiomatic, with the hope that there will be phase 3 studies to follow on. In the context of AF, whilst the guidelines at the moment suggest anticoagulation between 4 and 14 days, from the American point of view, with this 1, 3, 6, 12-day rule from the ESC point of view, clearly there's significant interest in all that we can do to reduce the burden of recurrent major and fatal stroke in this high-risk population. And we hope that 2 trials that the UK has a major role in, Optimas and Elan, will provide some evidence to inform our everyday clinical practice. Thank you very much, and happy to take questions.
Thank you very much, Professor Robinson. Such a comprehensive talk which you have given on update on antithrombotic. So now we are open to questions. I've got a few questions. First question was given by Peter Anderton. He is a consultant stroke physician. He said, we have been discussing recently is whether to give antiplatelets to patients with prior stroke who are on long-term VTE prophylaxis, for example, low dose apixaban after 6 months of high dose. What is your view?
Okay, so just so I'm clear, people are already on long-term venothromboembolic prophylaxis, okay? And then you're questioning, do you want to give antiplatelet therapy on top of that?
Yep.
And so essentially, and this is those with prior stroke, so this is purely secondary prevention. This isn't talking about whether you'd on top of that want to give acute antiplatelet therapy because they've come in with a new stroke.
Yep.
Yeah, okay, so I presume it's always weighing up benefits and risks in this situation. You would be talking about giving both anticoagulation and antiplatelet treatment. Of course, we know that we do that in some people who have underlying AF and they've had, an acute coronary intervention, for example. And we do have patients who are on, therapeutic doses of DOACs, as well as, not just single, but dual and sometimes triple antiplatelet therapy. So I think it very much depends on what the overall balance of benefit and risk is at an individual patient level, I think, rather than a global response to that.
Thank you. Thank you. Other question is, similar question is somebody who had an MI, and question is done by Dr. Abbas. Somebody is taking ticagrelor and aspirin after MI and has a TIA or stroke. How to go about antiplatelets then? To continue with that, or to add clopidogrel?
Yeah, no, that's a fair question. That's a fair question. So I would normally, my normal practice is to talk to my cardiology colleagues about that. I probably think that now we are getting some data on ticagrelor and aspirin in combination in acute stroke as well as acute MI. I'm becoming more comfortable about keeping them on ticagrelor and aspirin, rather than changing them to clopidogrel and aspirin.
Thank you. And then there is a question is from Dr. Salman. Brilliant presentation. Will difficult to control blood pressure of few microbleeds or MRI deter you from using dual antiplatelets?
Yeah, okay, again a good question. I presume, we see this more, don't we, in terms of patients who we're seeing in TIA clinic who we have an MRI on, so we actually start to see these microbleeds. Again, so my understanding of the literature, based on not many of the studies that we're basing the guidelines on, had MRI, is that again, overall, we want to do our very best to reduce risk in what is a high-risk population, and therefore you want a strategy that aims to control blood pressure. And if they fulfill the reason for dual antiplatelet therapy, and if they only have few microbleeds, again, I would give them dual antiplatelet therapy.
Other question is by Josh Berman. Patient who is already taking ticagrelor for ACS, what's the safety of intravenous thrombolysis?
Good question. And I would have to, if I had this clinically, I would probably talk to my colleagues and do a literature search, actually.
Okay. Yeah. So obviously there are two choices from my point of view. If I face this sort of problem, might be thinking about thrombectomy. If it is
thrombectomy. Yeah,
that one. Other thing is obviously weighing risk and benefits. Patient had a thrombosis, not for thrombectomy. Might be I will take aggressive approach of thrombolysis personally. But
yeah, I think it's one you would perhaps talk to somebody. You're right. We have an opportunity for thrombectomy. The problem is at the moment ours is a kind of extended as Monday to Friday service. We don't have the luxury yet of a 24/7 service, but we have a very responsive thrombectomy team in Nottingham.
Okay, so we have got other 1 minute to ask question.
Yeah.
Manur, monotherapy, which one is preferable, aspirin or clopidogrel?
I tend to use clopidogrel.
Yeah. Another is Isra Montesser. Is prophylaxis in AF patients secondary prevention? Do you recommend warfarin or DOACs? And what basis should we go with each? So I think this is straightforward using DOACs nowadays.
Yeah, I think that would be, and that conforms with the the NICE single technology assessment. You look at the patient and you discuss the risks, on an individual patient basis, what would be the preferred anticoagulant, but it's likely to be a DOAC and not warfarin. Agreed.
Quick question again is, are there any recommendations regarding patients who present with cardioembolic stroke due to AF, who also turned out to have a probable cerebral amyloid angiopathy on MRI?
Yeah, so you have the advantage of having Professor Werring speaking to you later, who is, I think, one of the world's leading authorities on microbleeds and anticoagulation. So I would recommend you ask him that question. because then you will get actually the person who has done the studies and knows the evidence and gives you the right answer.
Okay, I've got a question from okay, so I will say I will close this topic now and we'll go to the next. Thank you very much, Dr. Robinson, for giving your time. And to, obviously, it is not like an interactive session face to face, but I think it is much valuable at this time of crisis. Thank you.
Thank you so much for the invitation, and I look forward to hearing the rest of your meeting too. Bye-bye.
Thanks very much, Dr. Robinson. Okay, we now swiftly move to our next speaker. And the topic is how stroke nurses can influence stroke outcomes. And who can be a better speaker for this? We have got a Professor Dame Caroline Watkins. She is a Stroke and Older People Care Faculty Director of Research and Innovation, University of Central Lancashire. And she is one of the rare breed stroke nurse consultant professors. And there are only 2 in the country. Apparently, both are in Lancashire. So up to you, Dame.
Okay. So good morning. Thank you very much for asking me to join this very prestigious lineup. I'm very honoured. And yes, it would be lovely to talk to people in person, but it is great that we can still get in touch in this way. And it's great that Dr. Ali and his colleagues have organised today. So what I'm going to talk about, I suppose, is nurses' contribution to acute stroke care. And there have been lots of improvements in stroke care after, over the last couple of decades. But I think there's been renewed enthusiasm in the last couple of years with the introduction of the Getting It Right First Time, the new national stroke plan, the introduction of the integrated stroke delivery networks, and all the people that are, really pushing that agenda. And so hopefully the whole of the stroke pathway will be improved. And although I am going to focus on acute stroke care today, it doesn't mean to say that I don't think that the rest of the pathway is important. So one of the things that happens is we have acute stroke care that needs to reduce the impact of the initial event to prevent secondary brain injury and then prevent complications. And sometimes it feels like it's the first one that captures everyone's attention. And nurses do have a very important role to play there with their specialist skills. And in Cumbria and Lancashire, where I work, a lot of the stroke specialist nurses have done the NetSmart programme, which means that they can take the place of stroke physicians on the telemedicine rota. But I'm going to focus on the latter 2 today, because I think that these things have the greatest potential to impact on the outcome of all stroke patients. So Sandy Middleton produced this slide, and it was to try and show the relative benefits of all the potential acute stroke interventions. And this isn't an exhaustive list, obviously. It shows the proportion of people that are likely to benefit from those particular interventions. And on the right-hand side, it shows the number of people needed to treat to prevent people from death and disability. What I suppose it doesn't show is the proportion of people that can actually be given those interventions, and the two don't really match. So for me, the latter two have the benefit to the potential benefit for all stroke patients, and so that is a very important focus. We need to give good stroke unit care to all patients that come in, not just those that have had thrombolysis or thrombectomy. And this, I've just highlighted here a couple of the multidisciplinary team interventions, which can have significant benefits. So Sandy Middleton's fever sugar swallowing protocol is a great example of where MDT care can have huge benefits. So I'll be talking about preventing secondary brain injury and preventing complications. And although these things aren't rocket science, they are very important. And they're also able to be done in stroke units in high income countries, just as they are able to be done in stroke units in low and middle income countries as well, with the right training and support. So the whole emphasis here is about spotting problems, and not just spotting them, but actually doing something about them. And as far as possible, that doing something should be evidence-based, and we should do it for all of the patients and all of the time. So our guidelines that we have tell us what we should be doing. And we need to be clear about what's in there, and I guess also what isn't. We also have the stroke-specific education framework, which was developed after the last stroke strategy in 2007. And it's a way of ensuring that staff have the right knowledge and skills, and that people managing those staff know how they can be developed to have the right level of knowledge and skills dependent on their role on the stroke pathway. And also that course providers can think very carefully about the content and can communicate people about the content and the level of information in their courses, so that people can understand whether it's worth releasing their time from the clinical setting to go on training. At the moment, this is the colour scheme, but the stroke-specific education framework has been adopted by the NHS and HEE to underpin the National Stroke Plan, and so its colour scheme will be changing soon, and we'll be sending round information about that. So the stroke-specific education framework covers the whole of the stroke pathway, described in 16 different elements of care, and they go all the way through from prevention to long-term care. And in the past, all of the elements in there have been stroke-specific. But from feedback that we've had, people have suggested that what they would like to do is to be able to understand not just their stroke-specific knowledge and skills, but their elements of professional practice. So those are some things that are being developed now as part of the national consultation, and they'll cover education, clinical practice, research, and leadership and management. So those 4 elements will be added and allow people to have a comprehensive record of not just their stroke specialist skills, but their professional practice skills as well. So element 9 in the stroke-specific education framework covers acute stroke care. And so these are some of the knowledge items that are in those in that element. And these are some of the things that I'm going to mainly focus on today. But there are also lots of other things that are in there, but it's just impossible to cover all these things in a short space of time. And as I said before, the principles are about spotting things, thinking about what might have caused it, and taking timely corrective action. But we can only do that if we're actually looking at people. And part of the benefits potentially of Sandy Middleton's fever sugar swallowing protocol is that nurses were going to the bedside of patients more often than they perhaps would normally have done, and not only attended to the fever sugar swallowing things, but also spotted other things at the same time. And we know that lots of patients come in with a reduced level of consciousness, and that sometimes makes it difficult to assess change. We also know that people use the Glasgow Coma Scale, which, while it is useful for understanding loss of consciousness, it isn't very helpful in understanding whether your stroke patient in front of you is changing in terms of either deteriorating or getting better. And so we're better using something that has individual items that can be sensitive to change in stroke patients, such as speech and limb weakness and those things. And so using perhaps the NIHSS and using the individual items scores, not just the total, could allow us to spot change if it's done frequently and in a standardized way. And then we can truly think that change has happened in those individual items. And then we can think if there's either a neurological or a physiological cause. So we know that there is some evidence that continuous versus intermittent monitoring may have some benefits, although obviously not everything can be continuously monitored. We know that 40% of patients go worse after they come into our care, and that is called stroke deterioration. But if that deterioration persists, we call it stroke progression. And some of those causes of stroke progression are from things that we really at this time can do nothing about. But there are some things that we can do something about. So we know that people with AF are more likely to suffer a stroke progression. And we also know that older patients with AF do worse. We know that people with bradycardias and tachycardias are more likely to suffer a stroke progression. And similarly, older patients suffer more from these changes in their heart rate. So we need to keep an eye on patients, both rate and rhythm. And we need to see if there is AF, and then put things in place in the short and long term. And we need to also make sure that we are checking for AF correctly. So not just relying on what's coming out of a machine. We also know that temperatures make a difference to outcome, and lots of stroke patients have hypothermia. We know that it increases secondary brain injury, and people are more likely to die and have a worse outcome. We know that even small increases in body temperature can have an effect on outcome, and they certainly have a huge effect on stroke progression. We know that cooling people dramatically doesn't really help. So we need to keep an eye on body temperature. And we need to spot if people's temperature is slightly raised or very raised, and consider whether people have some sort of UTI or a chest infection. And for temperatures over 37.5, we should be giving regular paracetamol. And for those over 38, we should do all the things that we would do in any patient and explore for infection. We also know that oxygen levels after stroke can be very variable, and that hypoxia can increase the risk of early deterioration and be associated with it, and can decrease people's chances of a good outcome. We also know from Christine Roth's work that stroke patients are more likely to suffer oxygen desaturations than other stroke patients, and particularly at night. And we don't really know about the implications for the time spent with desaturations, but we do know that lots of patients have quite prolonged desaturations. So in order to try and see if we could intervene in this, Christine did her SOS study and showed that routinely giving everyone supplemental oxygen didn't benefit outcome. But we do know that we should try and maintain people's oxygen saturation 95 and above, because below that it falls quite rapidly, that it's oxygen desaturation is a marker for pulmonary embolus and pneumonia. And respiratory rate is a very important indicator of both deterioration in lung function, but also deterioration generally. And it's often not given the prominence it deserves or the attention it deserves in our observation schedule. So we should be really aware of respiratory rate and changes in respiratory rate and abnormal breathing patterns. In the QASC study, obviously fever was being monitored regularly. They also monitored blood sugar and had interventions, whether it was low or high. And they also used the water swallow screening test to spot for dysphagia. And the justification was that all these things were known to have an effect on outcome. And there are lots and lots of other supportive care things that we need to do in stroke care. One of the most important things that we found out, I think, is Martin Dennis's study that looked at the effects of TED stockings, whether knee length or thigh length, and showed that not only were they not of benefit, but actually that they were detrimental in many patients, and that we shouldn't be using them. And then he went also on to show that intermittent pneumatic compression stockings were a very important intervention that had the potential not to just prevent DVT, but also improve survival. So I guess we could also think that early mobilization was something that might prevent DVT, and that it would also have a benefit on lots of other things. But what Julie Bernhardt's study showed, surprisingly, was because they were attempting to get people mobilized very early after stroke. And when they found out that the control group seemed to have done better than the intervention group, there were some concerns. And what you can see from the network meta-analysis that's been done is that people who got up very early ended up, they were more likely to be dead or disabled at 3 months. But those that got up much later than 24 hours also were more likely to be dead or disabled at 3 months. But those where there was, they just got up around 24 hours, seemed to have a balance of benefits and disbenefits. And the effect was similar for death as well as death and dependency. So the suggestion currently, and obviously avert dose is currently ongoing, that actually because of this potential problem, that actually it would be better perhaps if those people with difficulty moving and who are medically stable should get up somewhere between 24 and 48 hours. But we don't know a definitive answer to all that yet. So lots of our patients have swallowing problems. About half of the patients as they come in through the door, and about half of those still have a problem a week later. And those problems with dysphagia cause all sorts of impacts on both death and disability. So we really need to do something about it. The guidelines and the interprofessional dysphagia framework can tell us a bit about what we should be doing. So we should be using a validated screening tool, and it should be performed by somebody who knows what they're doing. And it should be done as early as possible and before anybody has anything orally. We need to keep people both well nourished and hydrated, and therefore we need to think about alternative ways of giving them fluids. And they should be, if people think they're going to have long-term feeding problems, then perhaps giving a nasogastric tube is appropriate. But we should also think about getting specialist assessment that allows modified consistency foods, and so that people can eat and drink from as early as possible. We know that delays in swallow screening mean that it's more likely that people get pneumonia. So we need to do swallow screening as early as possible. The interprofessional dysphagia framework explains about the knowledge and skills that people should have and how teams of staff can work together to deliver a comprehensive dysphagia assessment and management service. Sometimes we think that it's easy to spot swallowing problems, and it is in some patients, but sometimes people have silent aspiration, and therefore we should always do a standardized assessment in everyone. And to some extent, dysphagia isn't always just about swallowing things. In a way, there's a lot of things that are affected which interfere with ultimately swallowing. And some of those things are about whether you can chew, whether you are in the right position, whether your brain is telling you to swallow. So there's lots of things to take into account, and nurses and the rest of the team need to understand all of them. So people need to be equipped with all the right things and the right environment in order to be able to eat and drink safely. We know from some more of Martin Dennis's work that giving nutritional supplements to everybody isn't a benefit, but that doesn't mean to say that individual patients may require supplements, and if they require them, then we should make sure that they get them. We also know that what we don't know is about nasogastric tube feeding, may be of benefit, may reduce death. And if we're going to do it, we should start doing it early and not leave it till too late. We don't know the best way to keep people hydrated, so we need more research in that area. So in terms of key messages then, we need to be looking at people and doing standardized, reliable, valid assessments of people, and not only assessing people, but putting management pathways and treatment pathways in place. Otherwise, we won't improve outcome. We need to spot things in a timely fashion and also act in a timely fashion. And we still need more evidence for the things that we do, because a lot of the things currently seem obvious that we should do them, but we can't necessarily back up what we do with good evidence. So what makes a difference to these things getting done? Is it the numbers of stroke specialist nurses? Well, we did some work with the National Stroke Nursing Forum and looked at all the things that people were supposed to do to every single patient that came through the door. Just basic stuff, and on a frequency that people felt was sensible, you know, hourly in the first place, 4 hourly, a bit later. And we got them to estimate the time that it took to do all of these basic tasks. And they were quite conservative in their estimates, I think. And I suspect that by the time you've gone to somebody, you've explained what you're going to do, you've got them in a position to do it, you've sorted out perhaps other things that are going on, it probably takes an awful lot longer than you think to do many things. But like I say, they were being conservative. But even in being conservative, it would seem with the current recommendations of nurse staffing that it would be impossible to do all of the things all of the time in every patient in your shift. So you would never achieve it. And that's if you were always able to do things alone. So if it just took one person to do that particular thing. So if it takes more than one person to change their bed, sit them out, help them to mobilize, give them a bath or a shower, do other things, then in actual fact, there's absolutely no way that the current recommendations of staffing levels could ever allow you to achieve this business of giving good acute stroke care to all of the people, all of the time. So hopefully with the new recommendations through the National Stroke Plan, that there is some chance that nurses could feel like they've done everything they should have done for every single patient, all of the time. And the other thing is that the other recommendation is that all of the multidisciplinary team should be equipped with a minimum level of skills in order to be able to all contribute to this multidisciplinary stroke care. Thank you very much.
Thank you, Professor Caroline, for your talk, and very comprehensive. Obviously, it is in 30 to 40 minutes to cover everything from nursing aspect to how to prevent stroke and how to deal with a stroke is difficult, but you've done very well. So before anybody asks question, just a question to you is obviously from a couple of people are asking, can anything be done by paramedics before coming to the hospital?
Well, yes, I think there are lots of things that can be done by paramedics. And as you know, the paramedic contribution to stroke care got into the guidelines because of a thing that that my team set up because we had included paramedics in some multidisciplinary team training. So I think, yes, I mean, they can be monitoring people, so they can be positioning people, they can be checking people's oxygen saturation and giving them supplemental oxygen. They can be getting a great deal of history. They could use the same neurological assessment as the staff do in the hospital, so that the staff in the hospital can understand when the patient gets there if the patient has actually gone better or worse since they got into the ambulance. And those things are vitally important. The more we have differences in those things, then the less likely we are to spot change. And spotting change in stroke patients is one of the most important things that we can do, because it is the clue to whether there's something potentially going wrong that we should do more detailed assessment.
Thank you. Another question is by one of the acute care physician has asked, Dr. Abdul Gabbar has asked, most factors leading to secondary stroke progressions are the same as factors involved in worsening traumatic brain injury. His question is, does positioning stroke patient is in a way to reduce intracranial pressure have any positive effect on the outcomes?
Well, I guess I should declare being a co-applicant on the head positioning in acute stroke study. And it would seem that for the type of patients that were included in head post, whether you lay people flat or whether you sat them up, didn't seem to have an effect on outcome. So I think that's a key message, and a lot of patients can benefit from the head post results, because in a way we're encouraging them to position themselves in a way that may not be the most comfortable for them, and it would seem that perhaps they can choose.
Thank you. I completely agreed, Dan, what you have suggested. Other thing, the most commonest complication is aspiration pneumonia in a stroke patients. And we do come across patient initial swallow screen is passed, but later on might be collapsing of the collaterals, causing more extension of the stroke or causing a dysphagia. So how you can prevent these aspiration pneumonias, because this is one of the things, comorbidities or increasing the length of stay in the hospital by developing aspiration pneumonia. What you will recommend to the nurses?
Okay, so I mean, I suspect that you can't prevent all aspiration pneumonias, but what you can do is make it less likely. So I think that nurses and all members of the multidisciplinary team being aware that doing a swallow screen once is not enough, and you always need to pay attention to people swallowing, because when the people swallowing will change, not just with severity of stroke, but just with how tired they are and what have you. So you need to keep an eye out. So if you go to somebody, you've done the swallow screen, they seem to be okay, but the next day when you just in the bay with them and they are eating or drinking and they may cough or something, then you should pay attention to that. It didn't matter that they passed the swallow screen at another time. And also people have delayed coughs as well. So they might have drank something while you were there and been perfectly okay, but as you reach the door of the room, you hear a cough behind you, then you should pay particular attention to that. So I think swallowing assessment is not a do once. We have to pay attention to it all the time. And then we need to make sure that we do it properly, because people sometimes only give people a couple of teaspoonfuls of water when they're doing swallow screening, and that isn't enough. We also then need to make sure that we give them the right consistency of food and fluids, and then that takes more detailed assessment. And we need to understand that if you use something like Thick and Easy, which we often do in high income countries because we can afford to spend it on that stuff, then sometimes the consistency that you make things, it doesn't stay like that. So it goes thicker afterwards, and that may make it more difficult. And the other thing is, in the acute phase, it's quite important to think of perhaps giving some sort of supplemental fluids, because it's actually quite difficult for people to swallow, and so to actually take in sufficient fluid is quite difficult. It's important that when people are swallowing things, that they're swallowing things that are nutritious if they're putting the effort in. So we need to make sure that people have got the right assessments, that we're assessing them all the time, that we're giving them the right things, and then we're doing the best we can to make it less likely that they get aspiration pneumonia.
Okay, there's a couple of questions. Why don't other hospitals do dysphagia trained nursing assessment? We carry this out at York. More of a statement.
Yeah.
Why don't other hospitals do dysphagia trained nursing assessment? We do.
They do, yeah. I think a lot of people now are doing dysphagia screening training.
Yeah.
And a lot of the dysphagia screening is based on a water swallow. I think we can potentially do more, but I think there is more research that needs to be done in that area. So currently we're working with stroke units in India, where they don't have the same access to swallowing assessment, and they don't often have speech and language therapists. So in a way, their swallow screening has to go on to be more like an assessment, because otherwise the patients would not be getting things to eat or drink. And a lot of them already are going home with nasogastric tubes in. So I think there's things that we can learn from this work that we're doing in India for the UK, so that more of the multidisciplinary team are able to do more than swallow screening, and to move people more quickly onto food and fluids that's of suitable consistency for them.
And the next question is from Dr. Anderton. Professor Watkins, you rightly highlight the importance of avoiding hypoxia. What about the harms of oxygen? You suggested maintaining saturation greater than 95%, but there was some strong evidence to suggest accepting saturation greater than 92% to avoid the excess mortality with high oxygen. Because in some literature, obviously, suggesting just to maintain it more than 92 rather than 95.
Yeah, I think there's a huge debate about the actual 92, 93, 94, 95. I think we need more research probably that needs to be done in that area. And I think it will also be different for individual patients who really have the potential to disbenefit from having very high oxygen saturation levels. So yes, I think we need more research on that.
Okay, so thank you. And somebody has mentioned it there, that does prop-up position help prevent aspiration pneumonia?
Yes, I would say that positioning can make it less likely, but you need to think about what the best position is for that patient. And I think you need a proper swallowing assessment to understand that, because sometimes people's head position can affect whether they can swallow or not. So in a way, we need to be tailoring our positioning of patients to their ability to swallow in particular positions.
Okay. Then there's a question from Dr. Koch. How would you manage dysphagia patient on RT feeding after discharge? I don't know what does RT mean, R and T capital. Might be
Riles
might
tube,
be
is it?
Riles tube.
Riles tube, yeah. Riles tube feeding after discharge. Well, I mean, I would start from a position of trying to have as few people going home with Riles tubes as you possibly can. I think that's where we should be. That should be really a last resort. It's not ideal. It's difficult to know if the Riles tube is still properly positioned, and the management of it is quite a nightmare, I think, if people are going home. I mean, obviously, if they're going to a nursing home, it might be a different situation. But I think we need to leave as few people as possible with that option going forwards for long-term feeding.
Okay, so I agree with you completely about the Royals tube. I'm not in a favor of sending people NG tube home or care homes, because there are more chances of aspiration, dislodging, and causing aspiration. So might be if you're thinking of feeding, then a PEG tube is better if you're thinking that is appropriate. If patient want to go on artificial feeding, we normally don't send people on Royals tube from hospital. So one more question I can take it. Sorry, Dame, is it possible, are you able to see the question and answer on your screen? So might be we can, if you can kindly answer those questions, if you have time for 5-10 minutes. Because of the time, I would like to, and thank you very much for presenting to our stroke masterclass and giving us a time. Much obliged.
Oh, thank you very much for asking me. So what you're asking me to do is try and reply in the text.
Yeah, whatever
to the
appropriate
sure.
do it. So that would be great. It would be good. At least audience would be satisfied, because we couldn't ask the previous speaker. So, but we now onward would be asking our speakers to kindly stay behind for 10-15 minutes just to see if they can answer those questions, if they can. Thank you.
Okay.
Thank you.
All right. Thank you very much. Thank you very much for asking me. Thank you.
Okay, now we smoothly run to our next speaker, and the next speaker is Dr. Paul Maliakal. Is a friend, colleague, and our tertiary neuroradiologist, interventional radiologist, and helping the stroke masterclass. I think since we have started it, I think he has missed one only because of his family circumstances, but he is very supportive. And he is a consultant neuroradiologist in Hull Royal Infirmary. And thank you, Paul, for presenting yourself. And the topic for you today is thrombectomy in acute stroke update. Where are we and what next? Up to you, Paul. Thank you.
Thank you, Asem, and thank you again for inviting me to this stroke masterclass. I really enjoy coming and giving a talk, and this time in virtual world rather than personally. So I'll try and share my screen here. Can you see my screen now?
Yeah, we can.
You can now, okay. So as you asked, I've kind of modified my usual talk to bring in more of what we plan for the future in our region. I think this is very relevant to us and to the rest of the country, because very many hospitals are in the same sort of position that we are in with stroke thrombectomy. These are my disclosures with NICE and TIG and British Institute of Standards Institute, etc. I think I would like to start with looking at the journeys of a couple of patients. And I hope you can hear me all right. Asem, can you just confirm that?
Yes, we can hear you, Paul.
And see my slides. Okay, good. The first one is a 74-year-old lady who came in. And if you notice, she only got to the hospital a couple of hours after the onset of her symptoms. But within 20 minutes of arrival in the hospital, we've been able to do CT and CTA and especially a triple phase CTA, which I'll come to in a bit. And this is what we see. We see that there is a hyperdense thrombus in the M1, and that's actually confirmed on the reconstructions of the fast-pass CTA. The fast-pass CTA also gives us information about the access route with the carotid artery. Over here, you can see that. So we know that there are no occlusions, no nasty surprises like dissections or anything else, or nasty plaques that stop us from progressing. Then we move on to the next phase of the triple phase, which is the second scans at 4 seconds and at 10 seconds. And these acquisitions are then reconstructed in much thicker slices, because then you can see the arteries much better on the thick slices. If you look at the very thin slices, you may not appreciate this as well. So here you can see that this is the first pass. So contrast is passing through the arteries for the first time. You can see the level of occlusion there. You can see a few arteries beyond that complete occlusion, which is very encouraging, because 4 seconds later, they're beginning to fill up. And 10 seconds later, you can see that many of them are filling. In fact, all of them are filling up. This tells us that there is an excellent collateral circulation. So we know that this patient, if you were to take out that clot, will do extremely well. And therefore, 10 minutes later, she was in the angio suite. You can see the guide catheter over here. Very nasty and tortuous access, but despite that, we've been able to compass the clot. Here you can see this is the distal marker of a stent retriever. Other markers, everything at about 1 centimeter. So this is 30 millimeters long, and you can see that with retrieving the thrombus, you can see re-establishment of the circulation. And as expected, the patient did very well and was discharged very soon. Looking at the second patient, this is a very fit and well man, a cyclist, on his 50th birthday. And he, unfortunately, presents with a very dense hemiplegia. And you can see that there is hyperdense clot in the M1. You can see it here too, that's pretty dense. We move on to the CTA, and here you can see that the M1 is completely occluded, and you can see it here too. And when you look at this collateral circulation on the triple phase, you can see that although a little artery is visible on the first pass, at 10 seconds, there's hardly any filling, and that is a bad sign. There are, many of you probably know that there are two groups of patients when it comes to stroke. One, the slow progressors, and then the fast progressors. And this gentleman, unfortunately, belongs to the fast progressor group because of the lack of collateral circulation. But because, he was young, we attempted to take the clot out. Here you can see that the carotid angio, the abrupt termination of the truncation of the artery because of the clot. Here we have a stent retriever. This is not a solitaire, it's a slightly different one. You can see that after one of the thrombectomy approaches, you can see that the vessel is opened up, but with significant narrowing in the M1 segment. Now, this M1 segment narrowing, as you can see here, did not actually last, it re-occluded very quickly. And unfortunately, despite 4 different attempts, I was unable to make sure that this remained open. And therefore, at the end of the procedure, we had run out of time, and we ended up with, as we started, with no real perfusion achieved. And you know that all patients who have a failed thrombectomy tend to do terribly badly. And here's the example. He has occlusion of the M1 segment, and the pressure and possibly some embolic material has also led to occlusion of the P1 segment, and therefore a very malignant appearance of stroke. He underwent a decompressive craniectomy and survived, but with a lot of damage. Now, we all know that we want all our patients, if possible, to be like the first patient's journey. But unfortunately, some of them end up with not so good outcome, and we need to progress our services and our techniques and everything we do to make sure that most patients fall into the first patients category. Now, it's always good to look at where we came from. And if you were to look at the last 25 years of various trials in stroke, which I'm sure my other colleagues will talk about, all the way from 1995 to the present day, there has been very many achievements, but a quarter of a century is a long time for things that have happened. And I'll come to that when I compare where stroke is in comparison with percutaneous coronary intervention. Now, my career as a junior doctor so far, I'm sorry, and as a consultant, has kind of coincided with this timeline, 95 onwards. So as a junior doctor in 95 in medicine, doing my MRCP, the best thing we could do for stroke patients was to give them aspirin. And that was it. And it kept on changing. By the time I became, a young interventionist, we had some options. And you can see that, we were doing back in 2008 a number of thrombectomies, but in a very selected patient group and on a very ad hoc basis. Later on, when you look at these barren years, this is where there wasn't much evidence actually, because the various trials were not actually demonstrating a significant benefit, partly because they were badly constructed, partly because the selection criteria were not good, and partly because of lack of techniques and devices. But since 2015, Mr. Clean trial being published, you can see that there has been a steady growth. But unfortunately, that growth is not good enough, as I'll come to a bit later. So just to revisit what we used to do in the past, this is a young lady who came in with bilateral vertebral artery dissections. You can see that the caliber of the artery is very irregular, and unfortunately on the left side as well. And this sometimes happens to very slim people if they hyperextend their necks, etc. And unfortunately for her, that dissection threw clots into the basilar, and you can see the typical hyperdense basilar sign over here. On angiogram, you can see the vertebral artery coming up on the right side and abruptly truncating with the big clot. Now at that time, we didn't have stent retrievers, and I had aneurysm stents, but we never used them as stent retrievers. So intra-arterial thrombolysis using TPA. These are little injections of TPA given at 1 milligrams, 2 milligrams, 3 milligrams. And you can see that that big clot over here, it's just partially recanalizing. Not good enough to allow any sort of penetration beyond. You can see just the outline of a sausage-like clot. So the next thing in my armory was to use intra-arterial balloons that I usually at that time would have used to remodel aneurysm necks during coiling of aneurysms. And you can see that that's positioned across the clot. After a couple of inflations, you can see that the size of the thrombus is now less, it's being squeezed. And a bit later, you can see that the artery is being recanalized because I'm moving the clot. And at the end of the procedure, you can see that the artery has recanalized. And this lady survived, and after a very troublesome few months of rehabilitation, got back to a reasonable standard of functionality. And then came the variety of thrombectomy devices. So this is the Mercer device, which is the little corkscrew spiral, and balloons that would be inflated proximally and suction applied to try and suck the clot back in. But they weren't terribly impressive, and after a while I gave up on them. And then came the suction devices from Penumbra, and you can see that these catheters, which are very soft and are capable of getting quite high up, close to the clot, are able to suck them back. And aspiration was good, and it still remains a good part of our thrombectomy technique. These devices did manage to catch some clot at times, but they were never very good at reperfusion as we can achieve on a present day. Now, looking at present day, we have the advantage of very advanced imaging tools, which my colleague and friend, Dr. Goddard, will talk about a bit later. We have modern devices, stents that are modified and designed to try and capture more clot, and we have refined our techniques to a great extent. So, multi-phase CTA, I'll leave that for Tony to talk about. These are the collateral scores. Once again, Tony will elaborate on them, and he will elaborate about artificial intelligence. So especially with perfusion scans and providers such as Rapid and VIS and Brainomics, I'm sure he'll talk about in detail. So I'll just come back to the devices that we use currently. So we have the stents over here. These are very similar in design to the aneurysm bridging stents, which would stay in the artery. If there's an aneurysm here with a wide neck, these will stay in the artery, prevent the coils from coming back into the vessel. But serendipitously, one of my interventional colleagues many years ago found that in a desperate situation, when he was trying to remove a clot, he actually used a stent just to try and disrupt the clot, and found that when he took the stent out, most of the clot came back with it. And since then, many people started using them, and the techniques got, much more refined. And then the addition of suction applied in the intermediate catheter, we found that, we can get rid of the vast majority of clots. Now the recanalization rates are in the 90%. Okay. So what do we use? We usually use a triaxial system. So these are called the guide catheters. They are often 8 French size, and they go from the groin all the way up to the carotid artery. And then within that, we have an intermediate catheter, which is a smaller caliber catheter, but flexible enough and supportive enough to go into the mid-cerebral artery or anterior cerebral artery. Okay, and then through that, we have the microcatheters. These are the ones, with the help of a guide wire, will go past the clot, and then we take the guide wire out, and then we put the retriever device through it. Okay, once the retriever device is placed across the thrombus, we connect suction to the end of the intermediate catheter. Some people utilize catheters with balloons at the tip so they can flow arrest, and we don't particularly find that useful, especially because we have a suction working in the intermediate level. Okay, so these are tips for interventionists, but I'm sure you probably will. I understand that most of you are neurologists, but nevertheless, you will also be able to get some idea of how careful we are not to cause any harm when we do these procedures. Example, most thrombectomies are done, all of them are done as emergencies, and but we may ensure that all the systems that we use are free of air bubbles, because they are the enemy. Extremely difficult to take them out of an intracranial circulation. We have very specific combinations, maximizing stability within the arterial system and also maximizing our ability to retrieve this clot. Sometimes we employ the bare metal technique, i.e. we take out the microcatheter, so the suction, the suction catheter has more diameter free to suck back. Okay. So briefly, these will demonstrate how we do the thrombectomy procedure. So here we have the puncture in the common femoral artery. Some people prefer to use the transradial approach, but I'm not being very familiar with this, but I know that several of my colleagues are doing them. The main catheter goes up into the carotid artery, and then through that we have the intermediate catheter coming up to this point, microcatheter going beyond it, the stent being deployed, and then the stent and the intermediate catheter are all pulled back at the same time, and we achieve pretty good recanalization with this particular technique. So let's look through a few cases. I mean, these are not the run-of-the-mill cases. You know, it is, when you look at the very first case, it is quite easy to believe that they are, you know, straightforward procedures and easy to perform, but many of them are not. Because you look at this particular patient who was transferred from Grimsby, I think. He came in with a very strange history. So he was having his breakfast or taking a drink in the morning, and he started sneezing, and soon afterwards he felt a pain in the neck, especially the right side, and then he had a sudden onset hemiplegia. Not a usual presentation of ischemic stroke, but when you look at the CT angiogram performed at Grimsby, you can see the normal left carotid artery here, but instead of the right carotid artery, you see a burst artery here. So there's a dissection. And up here, you can see that the M1 segment is missing. And up here, you can see that there's a clot in the pericallosal artery. That would all explain his stroke symptoms. Looking at the CTA done in Grimsby, this is looking from the front here. You can see the normal left carotid artery, but this is the ruptured right internal carotid artery in the cervical segment. And the reason why this gentleman had this particular rupture is all to do with the styloid process on the right side. So on the left side, here we have a prominent styloid process, but not touching the carotid artery. But on the right side, it's slightly asymmetrically larger, and therefore it touches the carotid artery. And that is most likely reason for the carotid being ruptured during his bout of sneezing. Now, this we call Eagle syndrome. It is a rare cause of stroke, but I've never seen it that spectacular. So we do the angiogram, and you can see the main catheter over here. We can see the point of rupture with the pseudoaneurysm and the missing M1 segment. So at this point, the important thing is to get the clot out. So we go up there, we pull the clot out, and also from the pericallosal artery. And then on our way, this is the different type of stent over here called the Trevo. On our way back, we stent the rupture. So you can see that this is a rupture here, pseudoaneurysm. The stent is being deployed. So this is not a stent that would take into the intracranial circulation, but we use in the carotid circulation. It's called a fluency. And immediately you can see that the aneurysm that was present here is no longer visualized. And we also give him aspirin IV. We have IV formulations to help us with interventional work. And he made a fantastic recovery. And I saw a picture of Dr. Ali and this gentleman on Grimsby Live, and I took this out to show in this meeting. So he's done extremely well. Now look at another example. Once again, this is not a straightforward one, and this happened in the hospital setup. This is a 45-year-old lady, unfortunate to have parotid cancer, and underwent multiple operations in the neck. You can see the surgical clips over here. During such an operation, the plastic surgeon unfortunately nicked the internal carotid artery, but he managed to repair it himself. He put stitches on and kind of re-anastomosed the artery. But unfortunately, the next day, it occluded and led to a big stroke. And you can see that on the Brainomix E-aspects picture. You can see that a few regions are involved. So during the angiography, we found the occluded left internal carotid artery, and we put a wall stent across it. Now, as soon as a wall stent, this is something that has to be inflated with a balloon. But as soon as that was done, you can see that there is a blush of contrast here. And in the next second, you can see that there's a big puddle of contrast here. And at this point, blood is seeping out of the surgical wound. And my intervention colleagues are trying to stem it with external compression. So basically almost strangling the patient. But thanks to my very fantastic colleagues in vascular intervention, we managed to place the covered stent over here and stop this this particular extravasation of blood. Then once that was done, we went up, we pulled the clot out. You can see that it's been recanalized and with a very good effect. On the follow-up, you can see that unfortunately we could not salvage because that was, well, the core infarct, but the rest of the brain was salvaged. She made a fantastic recovery. You can see that on the initial follow-ups, the stent is patent, but later you can see the stent spontaneously occluded. But thankfully, she has a good collateral circulation and therefore she remained asymptomatic. Another lady, this time a young 36-year-old, 8 weeks pregnant, unfortunately had an acute presentation with M1 thrombus here, very symptomatic with dysphasia and hemiparesis. You can see that there is early infarction in the insula. She was transferred after having given intravenous thrombolysis. So when she arrived, she was missing the M2 segments. These are very quickly recanalized, and she once again had a fantastic outcome. Now, when we looked at the literature, there's hardly anything out there for thrombectomy in pregnant patients. So we decided to pool our experience. I mean, my colleagues from Sheffield, Dr. Se and Sanjoy Nagraja, myself and Dr. Nayak from Stoke-on-Trent, we all had one patient each with a similar sort of experience. And we pulled our data to have a look at, how much radiation the fetus got during such a procedure. And thankfully, the estimated doses, unfortunately, there's no direct measurements. The estimated doses from our respective medical physics departments using the data of the whole procedure and CT scan, etc., suggests that it is probably less than what you would get from a whole body CT. So it's an acceptable outcome, and in fact, a very good outcome for this lady and the baby. Now, looking at evidence for thrombectomy, now these are the seminal trials. So Mr. Clean being the first one, which is followed by all these other trials that convincingly showed that LV occlusion has a better outcome with thrombectomy rather than with thrombolysis. So we know that, only about 30% of large vessels, reopen with thrombolysis. But unfortunately, the evidence for thrombectomy didn't come through because of many RCTs that actually did not show us what we were expecting to see. So obviously, with the major trials, it changed, but it was 6 years ago, and yet we've not been able to fully put it into practice. But the results are very encouraging. So you can see that it's close to 90%. So this is recanalization rates, much higher than IV thrombolysis alone. Okay, and the improvement in modified Rankin score is also fairly impressive. Now, this is a whole list if anyone wanted to look at them in detail. All the various trials that was going on. Some of them were actually stopped early because they weren't required to show that thrombectomy was an effective thing. Now, the one that everyone looks at is the data collaboration called the Hermes collaboration, which is highly effective reperfusion evaluated in multiple endovascular stroke trials, led by Professor Goyle from Calgary, demonstrated that when you look at all the data from all the relevant trials, we find how impressive thrombectomy is as a procedure. The number needed to treat is 2.6, and that is a remarkable outcome for any medical procedure in efficacy. But when you look at the data of Hermes collaboration and do subset analysis, you also find that even patients with M2 segment occlusions tend to benefit because all the initial trials were large arteries, M1, ICA, M1, proximal M2. But you know that there is significant benefit even for these subset of patients. A few words about the trials about patients who present late to the system. This is obviously a thrombolysis trial, but Dawn and Diffuse 3 are thrombectomy trials, which respectively looked at patients from 6 to 16 hours and 24 hours, up to 24 hours. And they all found that a subset of patients with salvageable penumbra identified on perfusion imaging did very well. And that could be up to 25% of patients presenting late. So that does increase the numbers eligible for treatment. And in the UK, we estimate that I'll probably add another 500 patients to the eligibility criteria. So just to compare where thrombectomy stands when compared with percutaneous coronary intervention, we're looking at 1 in 2.6 benefiting. Here, those numbers are vastly higher on this side. So it's an even when compared with PCI, it's a vastly effective procedure. So if that's the case, my question, and I've really thought about this over the last few years, is if it's such a great procedure, why is it that our thrombectomy services are lagging behind by at least 20 years, if not more? And that may be to do with decision-making in the NHS. So there's a great paper on what I found on Googling that it's about decision-making. So a few years ago, when we were doing the ad hoc services, we were at this stage 4, individual clinical decisions. We thought, well, this patient may benefit from thrombectomy, let's go and do it. And here, the last bits of 2008, 2009, etc., we had, as a team, we had taken decisions to treat these patients, and therefore we had good outcomes. But it's only 10 years after that, we are in this stage where there's commissioning. So 2018, thrombectomy was commissioned and service reorganization. But I guess we need to be right up in the level 1 for anything to improve. So, if you want to take things forward, we need decisions at this level. Okay. So what's the current state of affairs nationally and locally? So as many of you know, there are 2 ways or 2 models that can be used. One is the mothership model, where all patients from the time of their phone call and ambulance transfer, they come straight to the thrombectomy center and they undergo investigations and treatment at the same center. And this is the hub and spoke model, where from the time, if the patient does not live in the catchment area of a thrombectomy center, then they're taken to the respective nearby or nearest HASU. They undergo the various investigations over there. If deemed to have an LVO and a decision taken that they'll benefit, then they're transferred over to the thrombectomy center where they undergo treatment. So looking at it in a bit detail, if you have the ambulance transferred to the thrombectomy center, okay, but majority of patients, which I'll show on the national graphs, come through this pathway. So once they arrive at the spoke center, there is a door in, door out. That includes arrival. We have imaging, the decision to transfer, and the patient being transferred out of the door. So this currently runs very high, unacceptably high. We're looking at something like 2 hours. Conveyance between the spoke center to the hub, once again, running unacceptably high. So together, this could add potentially a 3-hour delay to the patient getting to the angio suite. So we need to think hard and fast about how to circumvent this. Unfortunately, every bit of delay, every 30 minutes of delay leads to 10% reduction in the probability of a good outcome. So we need to work hard on this. This is a good paper to look at. This is from Zhang et al. From St. George's Hospital. Gives a good read. So what's our current state? So at Hull University Hospitals, we currently provide services between 8 and 5. So that roughly, looking at this graph for patients presenting at the ED, we know that 60% of patients are covered. Unfortunately, you can see that these peaks carry on into the evening. So unless we provide a service up to 8 o'clock at night, we are not going to capture this significant group of people. But if you were to provide a 12-hour service, we would capture about 80 to 85% of patients. And we know from Dawn and Diffuse trials that even in the group of patients that come after the service hours provision, 25% may benefit if you were to admit them first thing in the morning. So these are slides from the thrombectomy implementation group. Okay, we can see that the door in, door out times are very, very variable, from being very short over here, okay, to very long over here. So we're looking at, including conveyance, we're looking at almost 4.5, 5 hours. And that's a very, it's not an acceptable time at all. Now, looking at the provision of services, the UK in deep purple is at the lowest end of provision compared to our neighbors in France, Germany, in Switzerland, who do extremely well providing thrombectomy services to 5% of their eligible population. Okay, but we have a long way to go. And looking at our centers, so this is a heat map of patients, how far patients are from a thrombectomy center. Look here, when you look at the Lake District, the top end of Lake District, or to East Anglia, or to East Kent, or to the peninsula, we see that there are lots of areas where patients will take a very long time to get to a center that would provide them thrombectomy. So that needs to be addressed. Now, locally, we have problems. We have some, not so homogeneous referral patterns, which we need to address here. This is the thrombectomy center, that's York, that's NLAG. Why is that important? Because of that delay built into transfers, we can see that patients who are transferred do have a worse outcome when compared to patients who actually present directly to the mothership. So, a hard thing to achieve, if you were to improve chances for them. Very significant variations, in the number of procedures done. Once again, that needs to be optimized. But once they get to the hospital, they tend to have a reasonable outcome. Okay, but there is still room for improvement over there. COVID has had an impact. We have, we found that the number of patients presenting with stroke came down quite a lot. But when they presented with COVID and stroke, they had much worse outcomes. In fact, the rates of reocclusion, even when we completely opened up the arteries to TT3, were pretty high. We had 3 patients with terrible outcomes. What does the future hold? So we have an oversight group called the Thrombectomy Oversight Group, which then looks at or oversees the Thrombectomy Implementation Group, which is a national body which has been recently set up. We've had only 3 meetings, and then each of the regions, 7 regions, will have their own thrombectomy implementation groups that will comprise of the interventional lead, the stroke lead, and the stroke group managers, health group managers. Okay, the objectives are quite comprehensive. Long-term potentiation of any sort of plans we have, whether it be extending the hours to 8 till 8 or 24/7. We need more access to capital, which hopefully will come through from the TIG. We need to look at all the different barriers and circumvent those. We need to provide good data, and very importantly, we need to think about the workforce, because currently we have a big shortage of interventionists. So in the UK, we have 85 intervention neuroradiologists, and that's nowhere near enough number of people to provide it. And even if a center was to employ 6 interventionists, during the daytime, they wouldn't have enough work to do in aneurysms or any other neuroradiology work. So therefore, they could be de-skilled. Okay. So what's the alternative? The alternative is to train up somebody else. Okay. I'll come to that in a second, but this is the National Optimal Stroke Imaging Pathway, which is available online, and the take-home points for anyone working in a center that refers to another center for thrombectomy is that CT head and CT should be performed at the same time. Because if you have to send a patient away, then bring them back to the CT, it all delays things considerably. Okay, and every step we need to try and minimize to get the patient to thrombectomy as quickly as possible. I'm running out of time, so I'll just skip to an important aspect of what's to come. Here we have, what's the future hold for us? Because we work very closely with Leeds and Sheffield, we are working on a pathway to collaborate with each other and provide services both locally and on a rota basis. It would be extremely difficult for any center with very limited number of MT practitioners to provide a 7-day-a-week service. So therefore, our plan is to collaborate at the weekends on a 1 in 3 rota, but provide services locally Monday to Friday. The other thing that I need to just briefly mention is the shortage of MT practitioners. This is now being discussed at the thrombectomy implementation group. We've thought about who the best people are to train other than interventional radiologists, considered cardiologists, but they have although they have a great catheter skills, they are not radiologists. They don't share the same curriculum as vascular radiologists would have done, and therefore diagnostic neuroradiology is not a strong point for them. Similarly, we need a great deal of training to credential anyone from a non-radiology background, but GMC is looking at that. This option is supported by the BSNR, UKNG, and BSIR, and that's what we are pressing ahead with. We did a survey looking at how many of the vascular radiologists are interested. We know that 62% responded that they were keen on doing it, and many of them are youngsters. So this is the route that we're taking, and it is supported by the British Society of Neuroradiologists and the British Society of Interventionists. This is a reply from Rob Lenthal, my colleague from Nottingham. So we do believe that they are the right group to train. It took us from 2016 2 years to train our first interventionist. Many of you may know Dr. Raghuram, well-known interventionist. We currently have 3 others training, and hopefully within a couple of years, we will have them all trained up. So these are the various things that we look at. If anyone needs to know our pathways of training, please get in touch with me. I can forward them to you. These are the kind of various objectives that we need to fulfill before these practitioners are signed off. Okay, so a lot of work happening. We provide various training options. So this is a simulation day where we use mannequins to simulate the journey of a patient and do thrombectomy on phantoms. The same phantom is used to do thrombectomy simulations. That's Dr. Adnan Faisal there. This is my colleague Aubrey. This is my colleague Raj. We also have hands-on training. That's what we do for all our current vascular radiologists. We have other training, for example, the interventional neuroradiology course, which I run every year or 2. There's a regional thrombectomy meeting. There's the Hull Stroke School. And then we also, these are the phantoms. So you can see that the clots are being pulled out from the phantom, silicone phantoms. Okay, so I think I'm out of time now. So I'll just finish by showing these 2 slides. It's about why do we have to work so hard? And I'll tell you why. It's for patients like this. This 14-year-old came to me a number of years ago. Collapsed GCS very low. You can see that there's a hyperdense thrombus and also a spot of calcium in the basal artery. CTA confirms that this is completely occluded, and I was called by one of the very astute radiology registrars. Now, in this age group, it's a difficult problem because the pediatricians are not keen on stroke because they don't usually handle it, and the adult stroke team not keen on handling children, and therefore this poor child was caught between in no man's land, so to say. But we had to take a decision, so we took him to theatre very quickly. You can see that his arteries are occluded at this point, nothing going beyond at this time. He's been intubated because his GC is very low. And after a couple of attempts, we opened up the artery. You can see that that is a calcified focus, which I suspect was the main reason why he had a stroke. And this child did extremely well. This is him, Connor Lins, who was a rugby fan, and Hull KR, the local rugby team, made him an honorary member for 12 months. He has been extremely good at promoting stroke awareness and raising funds for stroke charities, etc. So these are the kind of situations that make you remember why you, or remind yourself as to why you do this job. So just to summarize, it is just about the most effective medical procedure there is and the most satisfying outcomes. Okay, it will become like PCI, but I don't know how many years it's going to take. And it's a great opportunity for all of us to work together so that we can effect this great outcome for our patients. Okay, thank you very much.
Thank you, Paul, for giving a comprehensive talk on thrombectomy and what we are doing in our region. I'm sure the similar sort of issues are in the other regions also. And the question I think you have already answered in a way. Dr. Kamath is one of the stroke skilled consultant working with us, is asked in a basilar artery stroke. So what's the timing from that point of view, posterior circulation stroke, time frame from your point? Or you have already alluded 24 hours anyhow.
Indeed. I mean, I think basilar strokes are very different, as we all know. We would, depending on the patient situation, I would perhaps even consider treating up to 24 hours. But it's a very patient-specific thing.
Yeah. For the region, if you because obviously quite a lot of regional doctors are here for this talk. So question to you is, if somebody coming in after hours, might be in the middle of the night, and we're thinking it is a posterior circulation stroke, can we, obviously we know the service is up to 3 p.m. for the peripheral hospital. Can we keep those patients, work it up and discuss it with you first thing in the morning then? If you think that would be reasonable?
I would imagine so, yes, indeed. But currently we are in the process of getting rapid artificial imaging installed. We're just testing the server now, and hopefully we'll be able to extend the same for NLAG and for York to have rapid imaging installed in those centers as well. So that would make your life a lot easier, when that comes through.
So keeping into the time, Paul, I just want to ask one more question, and then if you can kindly later on stay and answer, because obviously on your screen you would be able to see there are quite a few questions for you. One question is from, if a patient is 55 years, female, hypertension and diabetes, have PCI on table at cath lab, patient had a left MCA, M1 distal clot, NIHSS 16, what will the further management plan and risk of complication? Look like patient is having a PCI, having a stroke with a M1 distal clot with NIHSS of 16.
Once the patient is stabilized from the cardiac aspects, we'd be very happy to pull the clot out just like we do for any other thrombectomy patient.
Yeah.
But she has to be stable from the cardiac perspective. Because
unfortunately, we don't want a cardiac arrest in your lab.
In different hospitals. Well, we've had plenty, believe me. It happens in aneurysm patients.
True.
So it's not new to us. Yeah.
So there was another question, Michael Keeling. So when can we stop lysis and infusion prior to transfer? I will say to stop straight away if the ambulance arrived, to take the patient to a tertiary to stop the infusion straight away.
Absolutely. Do not delay transfer for that. I mean, as you would see, those DIDO times are rather unacceptable. We need to try and minimize it to less than an hour. It is a big ask, but that's the only way we can improve outcomes for patients.
Thank you, Paul, for your excellent talk again and helping us. So we obviously we ran our time a little bit, but we'll have a break of I will say 10 minutes from here now, and so that people can have a comfort break sitting since morning in front of the computer. So Paul, if you can kindly answer those questions, that would be great.
I will do. Thank you.
So, thank you, Paul, once again. Thank you very much.
My pleasure.
Bye-bye. Bye-bye. So to all the delegates now, we will give a 10-minute break. Sorry, we are lagging behind the time, but we'll catch it up. So 10 minutes break. So we'll be starting at 11:30 now. Other thing, quality of the video and the mic, already everybody is listening it quite nicely and seeing the speakers and slides. Only I think 3 or 4 people have got a mentioned poor quality, but looks like it would be on their end. So might be switching on, switching off the computer and making sure that if you are using a headphone, you can take it out. Might be utilize your a speaker from your laptop or desktop. That might resolve the issue. But from our side, I think the videos and the links are working quite appropriately. See you shortly now. So Tony, thank you very much. You are already here. So just bear with us because we are running a little bit late. So I will introduce
Can you hear me okay? I've got a sort of, it's a ceiling mic in the academy. Can you hear me all right?
Yeah, we can hear you. You can put your first slide there so that
We'll practice sharing the screen, shall I? And
yeah, you can share the screen.
okay. Can you see my
Yeah,
first slide?
if you, that's fine. If you can put it on, yeah, excellent. So you can keep it there. So we'll join you in next 8 minutes, 9 minutes time. Yeah.
Okay, thank you.
For the meeting today or stroke conference, I must say thank you to my postgraduate center managers Lynn Young and Sarah Bagley, who has done a lot of hard work behind it, coordinating with you and registering with you. And obviously, we'll be issuing you certificate once we will get the feedback from you. Feedback is important because this meeting is being approved by Royal College of Physicians. So always they would like to have a feedback, and we have to keep the record of these attendances for 5 years. This is a legality. So kindly return your feedbacks after the end of the meeting so that we can issue you the certificates. The question is being raised regarding a stroke physician to be trained for mechanical thrombectomy. I love that as a stroke trainees should learn this skill, because this is also a way forward, as Paul has mentioned. The vascular surgeons are involved into it, but I think the training of the stroke registrar would be also very good. Obviously not for everybody, people who are keen to do it, so that would be great opportunity. But at the moment, I don't think so there's any move from that point of view, that it's not been yet been decided. But it's important that we should learn as a stroke physician a CT angiogram. So the coming talk would be really important for all of us. So when to refer these patients appropriately to thrombectomy centers. So that is really important. Other thing I would like to tell the doctors which are overseas, if they want to get training in stroke medicine, there are opportunities in UK. There's a different program where we can train, or we can bring doctors from abroad as a medical training initiative, which is sponsored by Royal College of Physicians. So this is a good opportunity to people who want to do stroke. We do provide MTI training in our trust also, so please don't hesitate to contact if need be. And I'm sure later on the president of British Association of Stroke Physicians will be joining us, so we can look into how to formalize it a bit better in a way to train people from the other part of the world, because the stroke is still we are not able to achieve what we would like to achieve in UK or in the first world countries. But obviously we can understand that the stroke services would be far behind in the areas like Pakistan, India, Bangladesh, and UAE even. But obviously things are improving around the world. It's the global village now, in a way that knowledge sharing is important. So this will give you opportunity, the stroke masterclass, to look into it, how we can improve stroke services in the areas where we are working. The person which you are seeing with me live is Jen Young. She is our postgraduate manager, and she has helped us a lot during this meeting. So big thank you to Len, and virtual claps for you.
Thank you.
So without any delay, I would like to introduce my next speaker, who is known to me in a way that I've attended quite a few training sessions with Tony Goddard, who is a consultant and neuroradiologist in Leeds Royal Infirmary. And the topic which we are going to discuss in his talk would be imaging in stroke and case selection for mechanical thrombectomy. It is really important for, as a stroke physician, we need to understand when to refer these patients for thrombectomy to our neuroradiologist colleagues, either in Hull or Leeds. So, Tony, thank you very much for your time, which you are giving again, this time in a stroke masterclass. So up to you, Tony.
Thank you very much. Hopefully you can hear me. I've turned my camera off because I'm in the Leeds Radiology Academy by myself in a dark room, and it looks very sad. Paul has talked about the service delivery, and I guess in a way we're stepping back a little bit and talked about a bit about the pathophysiology of stroke, and it always helps to recap some of this to understand why time is such a strong factor in stroke, and why complex imaging pathways are required for accurate and patient selection. And as far as I know, it's a mixed audience today. This is old news to most people about what stroke is. It's a focal or diffuse neurological deficit lasting for more than 24 hours and caused by a focal or diffuse insult to the brain. Now, of course, this is historical because we're not waiting 24 hours to make the diagnosis. We're doing this in as short a time scale as possible. So I think the definitions are now a little bit more fluid. But stroke involves a blockage of blood vessels, which may be temporary or permanent, with damage to the brain as a result. So in imaging stroke, comprehensive imaging, we need to look at the end organ itself, the brain, of course, and also the blood vessels. It's important to look at the location and extent of infarction, to look at some clinical correlation. Clinical assessment of stroke is notoriously difficult, even in expert hands. It's important to look at the age of the infarction. For example, multiple infarcts of different ages and different territories might suggest a symbolic source from the heart. That helps us with etiology. Etiology gives us a hint towards direct intervention, which is what we're going to talk about. And there's also secondary prevention measures which may be required, such as carotid endarterectomy, antiplatelet medication, and those kind of things. And also there's plenty of research. There is plenty of stuff we still don't know about stroke, surprising things. There are some randomized trials now about intervention, for example, in patients of older age groups with more extensive early infarcts. There may be some benefit in patients who've got lower aspect scores. So there's plenty of work still to be done in understanding stroke. This is quite an important slide. The brain is quite a hungry organ. It uses 20% of total resting body oxygen and takes 15 to 20% of cardiac output. We have normative data for blood flow, particularly to grey matter from nuclear medicine studies. So we do have some interesting information we have, which helps us feed into some of the perfusion data later on. So basically, the brain is very intolerant to a lack of oxygen, even for a very short space of time. I don't expect you to remember this. And those of us done biochemistry, this will bring back horrendous flashbacks. But basically, what happens when the vessel is blocked is that the area beyond the blocked vessel becomes ischemic. It lacks oxygen, and in essence, you get an increase of water, calcium, and sodium into the cells, which then swell up and lead to cell death. Now, what the correlate on imaging is that you see reduced density on CT. Things start to look like CSF on CT. So anything that is of reduced density on CT, regardless of time from onset, is already irreversibly damaged. And that's an important consideration. If you're doing MR, and I will say that MRI hasn't really made any inroads into advanced imaging for stroke selection, for thrombectomy. They've tried it in Germany, and access in a timely fashion to MR is not great. And actually MRI is not a great environment for patients acutely unwell and confused. The whole sort of, pathophysiology, as far as we understand it, that is driving intervention is the concept of the ischemic core and the ischemic penumbra. And what we think happens, or we see happens, is that in the early stages of stroke, we see a clot that's drifted from, for example, the heart, it's lost at a bifurcation. You get an immediate central area of infarct, where the brain dies, excuse me, and is irreversibly damaged, but you have a large area of brain around this which is not getting enough blood, enough oxygen to perform normally, and contributes to the clinical stroke severity scale, but it will recover if the blood flow is restored. What happens to this ischemic core over time, though, is that it gradually expands. So in the early phase after stroke, we have a large amount of penumbra and a small core. If there is no recanalization, the infarct core will expand to such an extent that there is no longer any penumbra available to salvage. And also it's even worse than that. Actually, reperfusing very late can actually be harmful, because then you have a large area of ischemic brain, you have abnormal autoregulation, you've got abnormal blood-brain barrier, you may have anticoagulants or TPA on board. If you then open the blood vessel, you have a perfect storm and a perfect situation that may generate a large intracellular bleed. So these late patients, actually opening up the vessel may be counterproductive. And this basically shows this in graphic form: 100% chance of a good outcome versus 0% chance, plotted against time from onset, and the graph goes inexorably downwards, so that even if you open the vessel, if you're doing it at 400 minutes post onset, your chance of a good outcome then goes from 100% down to sort of 60% or worse. And if you don't open the vessel at this stage, then the outcomes are generally very poor. So there is a concept of futile recanalization, where the patient may not have been a good candidate from outset, or it's simply taken too long to open the vessel. That might be a transfer issue, it might be a technical issue, difficult access to get into the carotid. And now somebody with lots of time on their hands has worked this out. I show this slide quite a lot, and I think it's quite good to get this in your mindset when you're getting things moving with the anaesthetic team, etc. So for every minute of occlusion, you lose nearly 2 million neurons and 14 billion synapses, which of course you don't get back. So when your anaesthetist is asking for a central line and for urinary catheter and la-di-da-di-da, patient warming, flotrons, all of that stuff, we say, no, keep the patient still, thank you very much, and we'll try and get the vessel open, because that's going to do more to get the patient better. So CT is still the gatekeeper investigation, and the correlate, and this is not too basic, you can't overemphasize the importance of CT too much, because these patients are going to come through A&E with or without clinical signs of stroke. And the big correlate now for these patients who may benefit from stroke thrombectomy is the hyperdense middle cerebral artery and the dot sign, which I'll explain graphically in a different way why this is important. You have to be mindful that you can see it with atheroma calcification. The vessel you're looking at must be of higher density than the other vessels, because if the patient's a high hematocrit, polycythemia, certain medical conditions, all the vessels can look dense. And you must also ensure that you're balancing the density of the vessel against normal parenchyma. This is old hat, but it's not necessarily an indicator of infarction on its own, but does portend a poor prognosis if you don't get the vessel open. It can reverse after thrombolysis and thrombectomy, and don't forget, it can be seen in other vessels, and of course in the basilar artery, you see it in cross sections, the dot sign on several slices. So here's what we see. Generally speaking, the stroke physicians, the stroke nurses, A&E team, whoever's attending to the patient first, will probably have a feel that this is going to be a big stroke. We've got a long clot from the carotid termination. You can even see the bifurcation of MCA outlined. This is the origin of the left MCA, and the left MCA in the Sylvian fissure is not dense. And this is This is a left posterior cerebral artery. It's, you know, you can argue it doesn't really stand out, but this patient will not only have hemiparesis, but they will have what the stroke physician called cortical signs, eye deviation. They will probably note either a large bleed or a large stroke. So large vessel occlusions is defined as an occlusion of the proximal carotid, middle or anterior cerebral arteries, the vertebral or the basilar arteries, and it restricts the blood to a large part of the brain. There's another very good study, but on quite a small number of patients, and a graph which gets shown quite a lot in neurointerventional talks, is a plot of clot length versus chance of recanalization with TPA. So 100% versus 0. So very small clots, a millimeter long, you've got a high chance of recanalization. But look at this as a very abrupt drop off between 4, 5, and 6 millimeters when your chance of opening the vessel is limited. And that's because, you know, the delivery of the drug is impaired. Now here's a graphic, and again, this is a really nice important thing. It is possible to lose an internal carotid artery and not have any symptoms. If you've got progressive carotid artery stenosis at the origin, and this is slowly progressive, but your other carotid is normal, you can preserve your cross-flow across the anterior cerebral artery, so-called Willis, which is the most efficient pathway, but you can also establish what we call peel collaterals from the anterior to the middle cerebral artery. So you can actually lose a carotid and not have any symptoms at all because you've got multiple layers of cross-filling. So you can have this in a dissection situation. If, however, you have an embolus with a normal carotid bifurcation and the embolus lodges at the terminal carotid, this is a bad situation because you then can't utilize your cross-flow from the circle of Willis. You can utilize your peel collateral flow from anterior to posterior cerebral artery, and this, in a way, is what your perfusion imaging and your CTA is looking at, and why it's important for these patients to maintain blood pressure. This is providing some critical perfusion. But we see immediately we start to lose flow in the deeper areas of the left middle cerebral artery with perforated ischemic change, and a large area of cortical territory is also at risk. This is what we see with a hyperdense MC, hyperdense carotid termination. This is why it's of such clinical importance. As you go more distally, you may see branch vessel occlusions. Of course, there's a less extensive area of territory involved. We have better potential for collateral flow from both the middle and anterior cerebral arteries. We've got some cross-flow which may still come in. These patients are becoming an increasing target for thrombectomy if TPA is not available. So we will, for example, treat patients with M2 occlusion because on the left, particularly if it's a asymmetric bifurcation, M2 can still give you a clinically significant stroke. So we will take on these patients. But these patients will generally respond slightly better to TPA. This is just some correlation to suggest in some patients we don't necessarily get a long clot. We get a small clot here that's lost at the bifurcation. I think functionally these will still behave and present as a large MCA stroke, even though with a small clot. Here's another case on the right with a right MCA occlusion. And you have to check, is it dense or normal vessel, dense or normal parenchyma? There is no subarachnoid hemorrhage, although of course that has a different presentation. If you look at bone windows, it disappears. That will tell you it's not calcification, and it's the center or the entire vessel that's dense, and not the surrounding. It's most of our CTs now quite sophisticated, and I think attending to basics. This is a young patient, and I think even knowing this is quite a difficult case. This is a 5mm slice CT on standard window imaging. I think it'd be quite hard push to detect the left MCA stroke, but when you narrow the windowing down and you make the image, you know, tighter window width and window level, this is a much more pixelated, I guess in a way less smoothed out, less attractive image, but actually the conspicuity of the clot is actually increased. So this is what we do as radiologists, and I think Asim is right in terms of everyone who's dealing with acute stroke has the opportunity to pick things up, and I think stroke physicians, you know, should be getting involved in this kind of training and just to pick this up. Radiologists are not infallible, and sometimes these signs do get missed, unfortunately. Here's a basilar that looks quite dense compared to the other side, but actually if you look close up, it's the periphery of the basilar that's actually dense. Incidentally, this patient did not necessarily present with symptoms and signs of basilar occlusion. This is just an example. It can be quite subtle to pick up that the vessel is dense. And here's, I show this case quite a lot because there's quite a funny story attached to it. This is a young guy who's actually got long clot. I mean, it's horrible, long clot strung out from the carotid termination into the MCA and even out into the MCA bifurcations. Now, this time we didn't have perfusion imaging. And if you think back to the diagram about where your collateral flow is coming from, ACA, you've got clots all the way out to here. This patient's penumbra is being eaten away very, very quickly. He was running the Leeds half marathon and was about a mile from the finish and collapsed, and we got him in quickly. We did a very quick thrombectomy. The irony with this patient is that there were 3 members of our stroke team, 3 consultants also running the Leeds half marathon, but because they were unfit, they were miles behind and couldn't help him. But he actually didn't do particularly well, even though he had a very quick thrombectomy, because in some of these patients, even a short space of time is not enough. Now, here's another subtle case, but this is quite important to pick up. And if you're not sure about these patients, you might do a CTA, CT perfusion, but this is an extensive left-sided stroke, and there were 2 important factors here. There was a hyperdense MCA, but if I just point out here that this looks a little blacker than the rest of the brain, we're not seeing the cortex quite well, and also slightly more important, as you get older, unfortunately, from my age onwards, even younger, you lose brain tissue, so you become atrophied, and the atrophy is usually global. So we see that, the sulci become more prominent, but actually on this side, the sulci are less prominent. This is already a swollen brain, and this is quite important indication. This is telling us that the blood-brain barrier is already disrupted, which shows that there is possibly or likely irreversible extensive ischemic change in the entire left MCA territory. So this is a patient, although it's subtle change, we probably would decline or do a perfusion on just to confirm our suspicions. Now, the next step when you're suspecting a stroke, and we're at a junction point and we are starting to move towards this, is that if your patient has a clinically suspected large stroke, even if you don't see the hyperdense MCA, a lot of centers are now moving to CT angiography because not all occluded vessels are going to be dense. You might have trouble getting this through your radiology department, and even as a consultant interventional neuroradiologist of 20 years standing, it has been a little difficult to convince our team to do this. It's not a huge number of patients, but what we can get in addition to CT and CTA, we can pick up large vessel occlusion, we can assess the CTA aspects, we can look at collateral flow, and even without perfusion, we can get a picture potential of the ischemic penumbra looking at CT angiography. So for nice bedtime reading, if you can't get to sleep during these COVID times, you can read this. There's a clot burden score and collateral score. This is just a graphic, and I'll show you some worked examples because I appreciate that's a radiology talk. I've not seen much radiology. For collateral score of 0, we have nothing in the hemisphere whatsoever. I call it a barren hemisphere, nothing at all. And we have a normal, with a lot, these are all patients with large vessel occlusion, we have a normal score. I tend to say, is it normal? Is it awful? Or is it somewhere in between? I'm not a big fan of 6 or 7 different scoring systems because you're simply going to disagree. Is it normal? Is it barren? No blood? Somewhere in between. Let's see. So here's an example. Large vessel occlusion and very brisk collaterals, intermediate collaterals, and this is a right side occlusion. This is from example from the paper. We've got no arterial filling at all, and in these patients you actually have very little time. So this would be very important to look at if you're, for example, considering transferring a patient. So for these patients, we'd have a low threshold for re-imaging and probably already falling behind. So here's a case of a patient who actually had a stroke in the hospital. Right MCA occlusion, we can see the hyperdensity. Here's a CT angiogram, normal appearance on the left, but look at this, nothing at all. You might even just appreciate on CTA, this looks a little dusky here at all as well. So this is a patient with intermediate collaterals, and you actually get a paradoxical appearance on CTA. This is the left side of the occlusion, but if you look at this image, these are vessels beyond the left MCA occlusion, and the vessels on the left look more dilated on the right. And what we're looking at is autoregulation. The vessels can dilate in an attempt to reperfuse that part of the brain. So don't be put off by vessels looking slightly dilated. You can often track vessels back down to the occlusion. So this is still the occluded side. Okay, so this is a patient who's collapsed in hospital with pulmonary embolus just before the stroke. Time of onset 15 minutes, and we've seen this sequence of events, a PE followed by a large arterial stroke with a long clot here on the right. The patient was already in hospital, so the imaging was done quickly. Here's the CTA, here's the cutoff here. But look at this again. This is the left, all filling okay, but nothing here at all, and very poor collateral flow. But given the patient was in hospital, we took them to the angio suite. This should come up as a surprise later, but M1 occlusion and nothing filling the MCA. Very quick procedure time, 11 minutes, one of the quickest thrombectomies I've ever done. But look at this, 24-hour CT, looks awful. And I think in these cases, you've probably barely got an hour to get on with it when there is no collateral flow. So you can actually get quite important information from the CTA. Here's a patient with surprisingly good collaterals. It looks almost similar, identical to the previous one. There's a hyperdense vessel. It's even more proximal. This is the CTA. This is much more favorable. And I think if you were to do perfusion, and some people do argue, in my Aunt Gail in Canada is a good argument for this, and saying actually you don't need perfusion in a lot of cases. You can get information from the clinical information, what the CT head looks like, what the CTA looks like. So even though we haven't got a rollout of national CT perfusion, I still think you can make sensible, informed decisions about patient management based upon what we can achieve at any centre that receives stroke patients. This patient, good collaterals, we'll probably take them and get on with it. Quite often the angiogram looks awful compared to the CTA. There's nothing beyond here at all. Again, really good reperfusion, and look, we see a very good follow-up here, and it's down to the collaterals keeping that penumbra going. Small infarct centrally is not uncommon on the fault CT. This is quite a complex graph, but it can be summarized. It summarizes really what I say. If you have distal clots and good collaterals, your chance of a good outcome is 84% after vessel reopening, whether it's TPA or thrombectomy. Look down here, proximal clot, poor collaterals, you get an 8% chance of a good outcome when you open the vessel. Okay, so you have again, it's down to time, it's down to collaterals. So this is actually quite important. This just reiterates what I've said. So looking at a combination of clinical history, CT and CTA, we can make several important statements, which then take us on to the next sort of step in looking at stroke patients. The success of any therapy is dependent on salvaging all the ischemic penumbra. Okay. If you don't open the vessel, the ischemic penumbra will not be salvaged. So by whatever method, whether you do it with TPA or the newer drug, whose name I forget, which is a single shot, which seems to increase the chance of recanalization twofold in these patients, but you need to open the vessel by whatever means and do it soon. We know that thrombectomy opens vessels. And if you focus on the penumbra and the pathophysiology of what is going on with these patients, you can in fact uncouple outcomes from time and be less time dependent. So there was a question raised about basilar artery thrombosis. The same could be asked about stroke thrombectomy and time zones. So we can extend indication to thrombectomy to wake up stroke where we do not have a time frame if we have good collaterals and the penumbra, and these patients can do very well. The figure that that Paul mentioned about, the number needed to treat being 3, this actually applies to wake up stroke patients from the Dawn study. Very good patient, but small patient group. But it also means we can not raise false hope, and we can exclude early strokes who will not benefit based upon the imaging we have available. So the CT angiography does have excellent sensitivity and specificity, along with thin slice non-contrast CT for stroke caused by large vessel occlusion. More distal occlusions in CTA, which are becoming a target for thrombectomy, can be more difficult. CTA is able to accurately select patients who may benefit from mechanical thrombectomy by demonstrating large vessel occlusion with collateral flow, and it allows the treating interventionists to actually plan the case. So I've actually deleted some slides from here, but we're not doing a CTA just to show large vessel or not. Our policy or protocol is to do CTA from the arch up, because 15 to 20% of patients have carotid stenosis. Now, time doesn't allow me to sort of present some of those cases, but in Leeds, we will probably angioplasty or stent the carotid bifurcation. We will select our catheters based upon the appearance of the aortic arch. So the CTA is not only a shall we, shan't we investigation, it's also a how are we going to investigation. You can also look at the CT angiography source images. Now, again, time doesn't allow me to do this. If you look at the CTA, you tend to look at it on quite wide, high window widths, 500, 200. If you change the windowing to be more soft tissue, so less good for vessels, it actually improves, if you're not sure about what the brain parenchyma looks like, if you look at CT angiography source images on soft tissue windows, they look awful, very pixelated, but actually you can be more sensitive to picking up low density in the brain. In most centres, CTA doesn't have a role for routine imaging in stroke. It's time consuming. There will be reasons why you can't give CTA. But as mechanical thrombectomy becomes more widely available, I think there's going to be a push to provide this in non-neuroscience centres on a 24-hour basis. But its use for now should be restricted to patients who are likely or potentially going to need thrombectomy. Now, I'm going to talk about perfusion. We understand some of the pathophysiology. We've talked about penumbra and core. CT perfusion analyzes this using what's called contrast density curves. It's not new. It's been around for 20, 30 years. What is new is applicability in stroke, artificial intelligence, and the time to analyze it. When I did my training in Australia, we did perfusion imaging in CT, but it took an hour to process all the data. And there are different. We use Rapid, but this is hopefully not a commercially biased presentation. But I guess I do have to present the one I have experience with. There are 3 operators offering perfusion analysis, and they offer different things. They can automatically calculate aspect score, i.e. the amount of ischemic change aspects. You start with a score of 10, you take off a point for every area of ischemic brain. And now this is not necessarily important, but it did standardize some of the assessments for stroke trials. So it was used in the stroke trials about aspects less than 7. My criticism of aspects is that you have 3 areas here. You can lose 3 points just for having basoganglia ischemic change, but the patients can recover quite well by having basoganglia ischemia. So I think we need a more sophisticated way of selecting patients with aspects, because I think it would be unfair to say no to a patient if all they've got is central ischemic change involving the caudate head and lentiform nucleus. CTA analysis is also becoming part of the package for all of the stroke things. So Rapid Vis AI and Brainomics will also give you an indication of contrast density in the vessel, so they can pick up a large vessel occlusion. I think this is particularly good for other hospitals, also out of hours stuff to help diagnostic radiologists. AI is definitely making inroads into helping select patients where you may need to pay more attention. I won't need to go to the physiology, but the calculation of perfusion requires assessment of a normal vessel to measure contrast density. It also requires assessment of normal vein, so the patient needs to be still. I'll show the impact of a non-still patient, so the patient needs to be quite still. But you can also appreciate on this examination, you get an idea of the parenchyma density, and I'll come back to this in a minute. This is for the geeks amongst us. These are time density curves looking at contrast density. This is the arterial phase. You have an input, so you inject the contrast into an antecubital vein. It then takes about maybe 10-15 seconds to circulate and be picked up in the brain. Arterial density rises first and then comes down quicker. It doesn't go down to baseline because we have recirculation of contrast in the vessels. This is the venous outflow. So it's a bit higher, it's later, it's longer. So these are the kind of curves we look at for analysis of data. And this is what it's all about. This is the picture. And now you can have all the numbers that you like, but actually this is a really nice graphical representation of ischemic core versus ischemic penumbra in a patient potentially eligible for stroke. So the green stuff is the penumbra. And this is calculated as slow flow going into the brain beyond 6 seconds. The ischemic core is calculated slightly differently, and that is blood flow 30% less than contralateral brain or normal data. So the purple stuff is dead stuff. The green stuff is what you can salvage. If green is bigger than purple, tick, go for it. It can be a little more difficult than that. And you get these other numbers, like there's 14 times as much ischemic penumbra brain as ischemic tissue. So in this patient, if we can get them quickly, we would say absolutely yes, all systems go, get on with it. Within the perfusion data, and this is the penumbra, we get a mixture of blood velocities. Now I'm going to come back to this. This is quite important. So the red stuff is really, really slow blood. The stuff around the edges is slightly slower blood, but not quite as slow. What this is showing us, again, in a different way, is the peel collateralization. So areas around the edges of the infarct have better collateral flow. Okay, so these are the bits we're saving. So it's a heterogeneous picture in amongst this penumbra. Okay, I'll skip this, but this is what we get. This will make you cross-eyed, it'll make your eyeballs bleed. There's a lot of information here. Almost too much, but what we're really looking at is time data versus flow data, and whether there's a discrepancy between the two. So we can eyeball this and say, okay, slow flow here, but actually blood flow, sorry, slow blood and low blood flow, these areas look matched to me. So unambiguous result and how we can see. I've been muted. I think I'm hopefully unmuted. Asim, hopefully you can still hear me. So I'll carry on.
Yeah, we can hear you. Carry on. Yep.
Okay, you've had enough. Obviously, you're going to get me muted or you're getting hungry. So here's a case of a wake-up stroke for which perfusion has been demonstrated to be very, very good. We've got a hyperdense right MCA. Arguably, the brain looks normal. We can't have TPA. Here's the CTA confirming a large vessel occlusion, which we still need. And here's the perfusion data. Excuse me. Now we have ischemic core of 28 mils, which is actually quite small. The older the patient, the less tolerant they are to larger volumes of ischemic core. The number is massive. You know, it looks huge, it measures high, there's a huge volume of mismatch. So in this patient, we would say, yes, we will go right ahead. The arbiter, I think, is quite useful of whether we're making the right judgment call or not, is to look at the 24-hour CT, which really would match the core tissue if you can get the thrombectomy done quickly. This is slightly concerning. This is a more detailed look at what's happening in the penumbra, and it actually looks, all of it is red. So all of it is very, very slow. These are patients who are called rapid progressors because there's poor collateral flow. Okay, so these patients will get over quickly. If this is a patient coming from the hospital and it's an hour, we might have a low threshold for re-imaging these patients. So areas around the edge have more rapid flow because of better collateralization. This is more severe delay, but most of it is red. And if more than 50% of this ischemic penumbra is red, i.e. very slow flow, and there's a low hyperperfusion index, these will progress at least 10 mils per hour and probably faster than that. Okay. I won't mention that too much. This is also another map where we get very reduced perfusion in the anterior temporal pole, again for this same patient. This patient was in our hospital. We could proceed very, very quickly. This is another example of the automated perfusion software. The patient moved actually during the acquisition of data, because if you see a CT perfusion being performed, you have to rotate around the head 50 times and the patient's moved. This grey bar means these frames have been removed from the analysis. So here's the case, large vessel occlusion, looks terrible. This is the anterior cerebral artery trying to provide some collateral flow. You see it's coming over here, trying its best to perfuse the right hemisphere. Reperfusion here, all looks good. 24-hour CT actually matches quite nicely, if it will show us the perfusion data here, but we had to do it very quickly. Another example, 70-year-old male, previously fitting well with an initial MRS of less than 2. Again, a wake-up stroke with NHS of 20. Large vessel occlusion on the right. We do CTA of the neck as well. So this is just to show the bifurcation looks okay. This is a coronal reconstruction. The internal carotid artery is underfilling. We've got clot in the MCA and even a bit into the ICA. So don't forget, you know, the diagram I showed earlier. This is that situation. The perfusion is surprisingly good because I told you that. So this is a very early presenter. So we've got a large amount of penumbra and very little ischemic core. So the calculation of the ratio is infinite. We have quite good collateral flow here, quite surprisingly. And again, the angiogram looks awful compared to the CT angiogram. Here's a large vessel occlusion. And when we're doing these procedures, we're going into the void, you know, we can't see. So we bend our guide wires, so we go in softly and we get the clot out and reperfuse And again, this is a very nice example, but the perfusion predicted a good outcome for this patient. And it's clinically, very, very satisfying to see the 20 down to 3. Another case of a wake-up stroke, right side of weakness, facial droop, clinically left tax, NHS of 20, hyperdense MCA. Again, we'll do a CT. I think we're now convincing our staff now with these patients, with or without a hyperdense MCA, to get a CTA done, because we don't want to miss these cases. These patients, we know from the Dawn study, can do extremely well after thrombectomy. Vessel occlusion, this is the analysis on the CTA. This is the perfusion data. You're all shaking your hands. Get on with it, Dr. Goddard. Stop talking about it. Get the patient round to angio, because there's a large penumbra, very small core here, 10 mils. And look at the size. If this patient wasn't treated, we would know that this core would extend to this size, and this on the left side is really either non-survivable stroke or will keep the patient in hospital forever. So this is a definite go ahead, get on with it. Very favorable perfusion data insofar as it is quite heterogeneous. Some slow areas, but they're quite small. Okay. Again, left MCA occlusion, good recanalization, and a really good outcome at 24 hours. Now, I'll just come back to the aspects point I was making earlier. It is almost universal to see ischemic change in the basal ganglia at 24 hours. Caudate head, lentiform nucleus. But this patient was at presentation, this was scored patient aspects of 7. But actually, this patient is NHS of 4 and will probably still improve. So even with this ischemic change, the patient is clinically quite well. So I wouldn't exclude patients with ischemic change in this area on their initial aspects. This is just something we look at. And again, it's a number. People like statistics and neurophysiology. This is the hyperperfusion index. It basically just tells us the amount of very slow flow within the hemisphere to the slow that's slightly reduced. Okay, and if most of the flow is very slow, i.e. red, and that's more than 50%, then that predicts rapid infarct growth. I've quoted 10 mils an hour. It can be as high as 30 to 40 mils an hour. Okay. Here are some patients where we've had a penumbra done outside. On the right side, an elderly patient, and it is definitely true if your patient is over 80 or more, they will do less well with a smaller core. So if the core is about 80 or more in a patient of 80, we will probably not treat those patients because the outcome is very poor. There is some data on that. We get some discrepant results as well, so you still have to keep your clinical mind on. You still have to keep your radiology head. Don't just look at the AI. I think you still have to analyze and drill down and try to understand things. So we do have discrepant results on perfusion. We have things like, well, we can explain it on physiological grounds, movement, problems with injection, problems with transfer of data we've had, and then, I don't need to explain what these are. Some things we just don't quite understand. Now, one of the problems we've noticed is that if you don't have CT perfusion at your center, and we make a decision to transfer after a CTA, and we'll do a perfusion in Leeds, for example, an hour later, that can muddy the results. So here's a case of an 85-year-old CTA performed at TG8, left MCA, NHS 22. It was a marginal decision because of poor collateral. So it was a case of having a quick look on the arrival, repeat CT and CT perfusion. So the first thing that happens is the patient's already had the CTA. So this is now the CT in Leeds. And you can actually see something that's gone on here. This is a left-sided MCA stroke. And the first problem is it's actually put the wrong side for aspects. And the reason is when we jet X-ray dye, it leaks into ischemic brain. So actually, this is the ischemic caudate head, ischemic lentiform nucleus, a bit of ischemic cortex. This looks denser than the normal brain. The reason is abnormal blood-brain barrier contrast has leaked into this. So the first problem is it thinks this is normal or increased density, and it's picked out the normal side as abnormal. But what we can see here is that this is effectively sort of, an issue with the blood-brain barrier. This then interferes with the calculation of perfusion because this has already got contrast on board. So when we do the perfusion, the penumbra looks big, the core looks okay, but if you look at it, it hasn't included that bit that we know is already dead on the plain CT because it's taken up contrast, but it hasn't included that. So here we have it here again, and it only included this. So the other explanation sometimes is contrast leaking through here is early reperfusion of basal ganglia, and reperfusion is a feature of stroke. And also the contrast leaking into the brain can interfere with the calculation of perfusion. So beware reperfusion and dead brain. Here's another one. You can argue about the merits of the referral here. DGH, 85-year-old, early dementia, but independent ADL, activities of daily living. Again, arguably a marginal referral on the basis of MRS, but left tax, 22, M1 occlusion, long occlusion here. And we repeated the imaging. So stable NHS, we repeated the CT, which is now 4 hours from onset. It shows that the vessel is still dense. The NHS is now, so the aspect is now scoring 4. But the other thing to look at, I'll skip that, is actually this, which is the source data from the CT perfusion and CTA. And we can actually see that on the left side, we've actually lost density of the cortex. So this has already progressed to ischemia change. But why didn't the patient deteriorate? Well, because this was already affected by the penumbra, so that the patient is already clinically bad. What you're seeing is radiologic progression of the core expanding to become the same as the penumbra, so there's no longer any penumbra left to salvage. But the patient will remain stable, so the clinical assessment isn't quite enough. You have to have availability to assess the patient clinically. Here's a situation where we've got a right middle cerebral artery infarct, but we see the phenomenon I showed you before, where the vessels beyond that vessel occlusion have dilated. So the automated analysis has actually put contrast on the wrong vessel because there's less contrast here, because of contrast has flown in and it's washed away because there is normal flow. Here, there is stagnation of contrast and we have dilatation. So it's actually thought there's better contrast on this side than this side, and therefore says the normal side is affected because there's less contrast. But in actual fact, this is the abnormal side. There is now an additional thing to fix that, where it correlates the side of the hyperdense vessel with the increased contrast. This is the autoregulation, so you again have to be careful. And I'll just show this because I think the weakest element, in my view, of the perfusion software is actually in the most simple, basic assessment of CT, which is how much ischemia is there at outset. Now this is picked right side as ischemic core. And it says a 7. Now you can look at this and go, yeah, 3 there, 7. But if you actually look at the numbers, these are Hansford units, 29.8, 29.4. It's picked up 0.4 difference in Hansford units. And I don't think that's necessarily relevant. 1 to 2, this is a bit more convincing. There's a difference of 3. The human eye can't pick up a difference of between 5 and 6. So I think it's still useful, but you still have to eyeball the scans. So this patient might have been declined thrombectomy on the basis of calculated aspects of 7 or 6. Beware old infarcts when you're looking at stuff. What I'm telling you is we have amazing AI software which is there to help us, but I still think we have to use our clinical acumen and look at the data. Here's an old infarct on the left. Okay, the issue is a hyperdense right MCA, but actually it's put the aspects on the wrong side because it's picked up some low density here, which is already established. Again, you have to look at the source imaging. Movement gives plainly weird results. Right MCA occlusion. Look at this. This is all over the place. I would suggest this is like an Andy Warhol interpretation of a CT perfusion, and it's got like it kind of makes sense of this. And the reason is, if you look at the movement in the 3 axes, the movement has occurred quite early on. So the program has not been able to select the arterial input function of the artery. It can't even find an artery to calculate it because the patient's moves at the beginning of the contrast injection. And this can't really be corrected by removing slices. If the patient moves later, but they're still in the early slices, yes, you can pick the arterial input function, you can pick your venous outflow, and you can deal with it. This one is an unsalvageable situation. And I've had patients where, oh, should we repeat it? Should we repeat it? I go back to the source information, talk to the clinicians, and we've gone ahead on the basis of there's no point in repeating it because they're not going to be any better. Let's go ahead and here's the graph, and this shows you in graphic form, really, there's movement all the way through here. I'm nearly finished because we're a little bit behind. Sometimes it doesn't quite add up. Wake up stroke, 86, previously fit and well. These are selected. But by the way, wake up stroke is a great time to send people over to us because it's before the day started and before we're doing our elective or acute aneurysm patients. So it's quite a nice time to have a stroke. Left side of weakness, NHS at 18, hyperdense vessel here. Aspect says it's 8, maybe some ischemic change here, but this is the perfusion. And it's like, hang on a minute, the NHS is 18. This doesn't make any sense. There's very little penumbra here and no core. So we couldn't quite understand this. And the CTA showed, you know, a vessel occlusion, the brain looks okay. So we went ahead and treated the patient. And this is interesting. So this shows that not all M2 occlusions are the same. We'll see there was a bifurcation of the right MCA, but look at the size of this one. This is huge, and this is a very small secondary branch. So actually the MCA bifurcation can be quite asymmetric. This is almost an M1 occlusion. So we will certainly treat these patients because NHS 18 with no other treatment available will go ahead and we'll do a thrombectomy, and the patient went from 18 down to 0. So the perfusion in a way kind of confused us a bit, and we went back to the basic, you know, principles of normal brain, high stroke score, a target to treat, get on with it. And this is another patient where we've got a slightly unusual result with perfusion. Patient found on the floor, NHS of 12, so clearly acute stroke with no time of onset. The right carotid is occluded. We don't have any other history. So the CTA shows the internal carotid is occluded from the base, but there is some perfusion here, and there's no intracranial large vessel occlusion. Small aneurysm here. I've definitely come across, out of interest, an MCA aneurysm. You're going to find it in 1 to 2% of cases. Quite scary when you see it after your thrombectomy, when you pulled out the clot and you open the vessel and you go, oh, okay. We've not managed to rupture it so far, but it definitely has happened. But look at the perfusion. It looks completely weird. We've got very extensive, what we might take to be ischemia with very slow flow, but there's no ischemic core. Difficult to tell. So lowest NHS, no intravenous large vessel occlusion. We've probably got chronic right ICA occlusion. There's no ischemia. So the interpretation of this is that this is a chronic hyperperfusion with an episode of acute decompensation. So no target, although we have attempted to recanalize vessels in this situation, chronic occlusions, but it's very, very difficult. The perfusion data suggested a slow flow, but no core. So we didn't treat the patient. And the CT at 24 hours shows some progressive ischemic change. But this is an issue with it turned out to be a cardiac event, and the reason for showing you this is the input function from the CT perfusion, which actually shows very slow delivery of contrast to the intracranial circulation, and this is something we see with cardiac failure. So this was a cardiac event in the patient with chronic occlusion. So coming to the final few slides, we all like these plots, and they're quite difficult to interpret. But this basically shows us that when you use advanced imaging, this is perfusion, to select patients for thrombectomy, we improve the outcome. So, for example, no assessment of perfusion data, and you treat the patient, you increase the proportion of good outcomes from 7.8% in these combined studies to 15%. But if you use artificial intelligence, i.e. perfusion, you can increase the proportion of patients who will do well. Now, you may be selecting out some patients who you can't treat, but you're bringing patients in a later time frame who we know will benefit. So it seems to be patient selection, it magnifies the treatment benefits if you select patients. And if you look at the clinical trials which didn't use artificial intelligence versus the ones that did use perfusion imaging, different not all rapid, different ways of assessing perfusion, you improve the ratios. The ratios are still quite high here, but absolute numbers are improved here. So we're increasing the proportion of patients with good outcomes, so it amplifies the results. And the Dawn trial is where we are now. This randomized patients, 6 to 24 hours from last seen well, randomized best medical care versus perfusion imaging, stopped by the monitoring committee. Yeah, small numbers compared to cardiology trials, not huge numbers. MRS at 90 days in the control group was 13.1, but in the NG group, 48.6. A number needed to treat 2.8. This is like giving CPR to an out-of-hospital cardiac arrest and antibiotics for an exacerbation of COPD. You need to give warfarin to 30 patients with AF to prevent one stroke. So a very powerful intervention in this small selection of patients. It's time to sort of finish, but the wake-up stroke we've got, again, a nice case just to, I think we're finishing soon. NHS of 22, large vessel occlusion. some basoganglia ischemic change, aspects of 8, but most of this is penumbra. So this is actually wake-up stroke where we didn't have perfusion available. The brain looks okay. There's a carotid occlusion here. And this is why we do CTA of the neck up. We're quite aggressive. It's a bit controversial debate about how you manage this. We're quite aggressive. We will stent the carotid, give intravenous aspirin, take the guiding catheter through, and the second part of the procedure is the thrombectomy once you've stented the carotid. But some people go for thrombectomy first and then deal with the carotid afterwards because it may be quicker. NHS of 4 afterwards. So to summarize on perfusion, and this is a fluid state, and there are differences of opinion, differences in application. I think if you've got an early patient in 4 hours with a good brain, good collaterals, a target, and a high stroke score, likely penumbra, get on with it. Or if you're in a DGH, talk to your stroke centre. May be helpful. Wake-up stroke, otherwise known time of onset and good brain. But I would still say, if you've got a wake-up stroke and a good brain, and you don't have access to perfusion, still potentially a good candidate to discuss at the very least. Fluctuating neurology. We've seen patients who've had TPA that have picked up with a large vessel occlusion, and we've found they often dip again later on. Unclear diagnosis. I think if we're referring patients out of hours, I think it's very useful to have, particularly when we're adding an hour to treatment by transfer. Unproven interest, well, or academic interest, do it in everyone to learn more about it. It's a high radiation dose. It might be difficult to justify. It's not really applicable to the posterior circulation. There is a posterior aspects and score, but it doesn't really help because what you need to know is about what's happening in the pons rather than the cerebral hemispheres, and it doesn't give us information about the central posterior fossa structures and spasm for a neurosciences center. The future about AI is getting to your phone. So even when you're on a holiday, if you can go on holiday, you can be in a sunny thing, you're on the beach, you can look at your phone, you can get a call about a stroke in your local hospital, sip your cocktail, go back to sleep, or you can switch it off. But this improves outcomes. There is a possibility, as Paul alluded to in his lecture, this is expensive software. It is expensive, I think, for DGHs to invest in who are not treating strokes. It is unclear whether the cost of this will be included in HRG coding. And if you're doing a few strokes per year, it could cost you £1,000 per patient just to do the perfusion. I think there's a big case to sort of discuss here, but this is another talk and another discussion. I think NHS England central procurement is likely to be the way forward. So thank you very much for your attention. I think there's a few minutes left for questions.
Thank you, Tony, very much for your comprehensive talk on perfusion scan and CT angiogram, which has given an insight to all of us. So before I take questions from others, I just want to ask you, this rapid app or device is going to be given to our tertiary center. Obviously, they have got neuroradiologists. What about DGH, District General Hospital?
Oh, I think in a way the biggest benefit of DGH, the way we'd like for it to work in Leeds, and we're trying to get it rolled out, is, for example, our 3 main referring hubs, Bradford, Calderdale, Pinderfields. Pinderfields have got perfusion. There's an issue about applying it. Calderdale have got it, and Bradford hopefully are in discussions, but it is an expensive investment. I've been told from a reliable source that there'll be discussions in the summer about central procurement, but I think getting into the DGH I think is very, very useful. For example, you know, if it's having information, if it's a marginal decision, I think is quite helpful. I've gone to my DGHs and given teachings about perfusion, what it means, and also the caveats about perfusion. Having extra numbers and extra data doesn't always make the decision easier. So sometimes it refines the decision, but sometimes it's still quite difficult, and you might make a decision based upon what you'd want for your own family, or, you know, for yourself, God forbid. But yes, DGH is where I think it's very useful. I think every hospital that deals with acute stroke that may be referring patients should probably have it.
Thank you. So especially obviously the wake up stroke where the confusion is and time is gone, or you don't know the timing. So that would be very useful app to have. And the question from the audience is, one is Dr. Mahmood. He said, if the CTA doesn't show large vessel occlusion, but significant symptomatic side intracranial artery stenosis, Will you do anything acutely?
Okay, and I guess this is in the context of a clinically significant stroke. Yeah, we've had this situation, and we have done acute stenting, but I think our first discussion will be with the vascular surgeons, because that's the first port of call. This is out with trial data. I think we'll assess the brain, and why they had a large, vesicle, because the stroke. So the vascular surgeons would probably defer in the arteriectomy, but we would have a discussion with the surgeons, and we'll make a joint decision on that particular patient. There may be a reason why they can't have surgery, contralateral occlusion, in which case we would plan to do the patient perhaps on the next available list. But in these patients, we would say antiplatelet medication beforehand, and good care to maintaining blood pressure.
Good. And obviously, I agree with you that mainly it would be a preventive, obviously, to do carotid endarterectomy or stenting, depending upon the regional specialties advice. So question to you again, Tony, would be obviously thrombolysis centers are opened up now, but we are providing only 9 to 3 service at the moment in district hospital. So any chance once we would be doing 24/7 in the local Yorkshire and Humber area?
Very good question, very pertinent question. And like Paul, I think we're kind of like going around in circles a bit. Our immediate issue is radiographic staff and angiographic nurses. We have trouble retaining people because the on-call is brutal, because they cover, large trauma hospital, and we need a separate on-call cohort of nurses and radiographers. Sheffield are getting that. We're a bit stuck. We're linking Leeds Hull Sheffield is a good option, but our problem is support staff, because they're already giving up at least one weekend in 2 for on-call. And this is for vascular work and occasional aneurysms. So it's getting there, and it's not even about money. We had a recruitment drive. We had money from the trust, and we had like a come to angio day, and I think we've had 12 money for 12 jobs across the trust for radiographers and nurses to work in vascular radiology, and I think there were 3 or 4 applicants. We need to make it more attractive, but you need a critical mass of people to make the on-call acceptable. So that's, I think, our critical sort of our pinch point, really.
Thank you very much, Tony. Other thing is about the training of the CT angiogram. Obviously, we are doing a masterclass, which is we are only giving 1 hour for our colleagues to get to know, and some are trained with the help of you in the region also. So might be we have to organize more structured training for our radiologists plus stroke physician in the local area.
I absolutely agree. And CTA is not a part of, it's not yet integrated. CTA has done an awful lot for aneurysm work, stroke work, venous sinus thrombosis. And yes, I'm trying to get on, because I think the training, for example, we've got an amazing lab here, a MAC lab, where we can have cases. So that's something we need to do, is we've got amazing cases. We can provide, links and people over. So we just need to get on with it and provide practical hands-on training where give a history, you go through the images, and we talk about what we see. I'm pretty much self-trained. Nobody taught me. If I think I've missed something on the CTA, for example, I'll go back and look at it again. And often it's a perceptual issue, and we can go back. But I think there's plenty of work to be done there.
Thank you, Tony, for giving us a talk today and your precious time. And I'll be in touch with you, hopefully in near future, so that we can get a training in our hospital for our radiologists plus stroke physician and the registrars. Thank you.
Thank you very much.
Thank you. Okay, so we're catching up with the time, but the next topic is very important, and also a speaker which is very difficult to get hold is Professor Rustam Al-Shahi Salman, who is the president of Stroke Physician of UK. And obviously the question which some trainees has asked, whether the trainees can have a structured training in thrombectomy. Might be this is a person where we can address it, might be later on. After his talk, we can request Rustam to, if he can stay behind for 5-10 minutes, so that we can ask question through the chat box with it for the trainees, whether the CT angio training or some sort of a thrombectomy training can be done for the trainees. That is number one thing. And how to help the overseas doctor to get a fellowship program in UK, because obviously workforce is the issue in UK also, and underdeveloped. It is our obligation also to train doctors from third world or who are underdeveloped to how to improve the stroke services around the globe. So Professor Rustam Al-Shahi kindly, first of all, give us a talk on intracerebral hemorrhage and what's new. And no one can be a better speaker than you, because you are involved in all the research in the hemorrhagic stroke, and you are involved in the RUSH study now. So up to Rustam now. Thank you.
Thank you for your kind introduction, Dr. Ali. Just give me a thumbs up if you can hear me okay.
Yep,
we can. Okay, great, thank you. Well, it's nice to be speaking to everybody and an international audience as well, so very kind of you to ask me to speak. So as Dr. Ali said, I'm a researcher as well as a clinical stroke doctor. I have no relevant competing interests for this talk. I'm paid by the University of Edinburgh and the health service here. I don't do commercial health work, and any income I make from research goes to my institution to enable us to try to improve the outcome for people with stroke due to hemorrhage. So the title that Dr. Ali had given me for my talk was about hemorrhagic stroke, and I just wanted to clarify what type of stroke I will talk about. Of course, for the Global Burden of Disease study, which has been tremendously important in quantifying the burden of stroke in the world, 75% of which is in low middle income countries, they have traditionally grouped in their quantifications these two types of intracranial hemorrhage, lobar and deep intracerebral hemorrhage, as well as subarachnoid hemorrhage, into the term hemorrhagic stroke. So that's what I understand hemorrhagic stroke to mean. There are these other types of bleeding in the brain which may also cause strokes, and we'll often see in our clinical practice patients with gradually evolving hemiparesis due to subdural hemorrhage, but they're not traditionally regarded as stroke by these epidemiological studies, and extradural, which of course is mostly traumatic. But in this talk, I'm going to focus on intracerebral hemorrhage, which in the UK accounts for approximately 10% of all strokes, but in low middle income countries it may account for anything up to 50%. My focus today is going to be on intracerebral hemorrhage. So thinking about the underlying causes first of all, which is important, we see in the UK this breakdown of the subtypes of stroke that I just mentioned. And the intracerebral hemorrhage, which is the topic of the talk today, about 85% of it is attributable to small vessel diseases, whereas approximately 15%, as far as we know from the extent of investigation that is done looking for secondary causes in everyday clinical practice, may be due to conditions like intracranial aneurysms, tumours, AVMs, or cavernomas. But it seems that certainly in our population, the majority of cases are due to cerebral small vessel disease. So what I wanted to do to begin with, just talk about a couple of topics today that I've worked on recently. The first is this issue of investigation of underlying cause of intracerebral hemorrhage and how to go about that. And then secondly, to think whether, especially considering our international audience today, simple tests may identify the underlying cerebral small vessel disease, and then move on to talking about antiplatelet therapy after hemorrhage. So I'm going to focus on a couple of recent developments in my own research program, but I want to start broad. So here's a case of a man I saw relatively recently. He'd been to Copenhagen for the weekend with his wife to celebrate his 50th birthday, and rather than sitting down to a candlelit dinner, which most of us 50-year-old men would do with our wives perhaps for our birthdays, he decided to go on a roller coaster ride. And as soon as he got off the roller coaster, he was even more dizzy than your average 50-year-old man would be. was staggering around on his feet and remained ataxic, had a headache and vomited. And he was admitted to hospital there, where this unenhanced CT brain showed fresh intracerebral hemorrhage in the cerebellum, here as you can see, particularly affecting the vermis. And he had various subsequent investigations whilst in hospital there. So he had a time of flight magnetic resonance angiogram 5 days later, which did not show any neighbouring abnormal vasculature. So that was an MRA 5 days later. He then went on to have a CT angiogram, which in my everyday practice in the NHS would be the first test that we would be doing. But he went on to have a CT angiogram, and again, there was no saw me in clinic, and I to accept small vessel disease as an underlying explanation for his bleed, and that further a cerebral catheter angiogram. And this revealed a small arteriovenous malformation in the vermian area of the cerebellum, which he went on to have treated and occluded, and he's done well without recurrence ever since. So in a way, this is a case example that should make us all nervous. It shows you how hard we often need to try to find an underlying cause of hemorrhage that is not small vessel disease, but which has important prognostic and therapeutic implications for a patient's management. So this is the diagram study, which I think is a high quality diagnostic test accuracy study that's been done looking mainly at the yield of CT angiography within 7 days of an intracerebral hemorrhage, followed by MRI and MRA 4 to 8 weeks later, and then in some of those patients, DSA, digital subtraction angiography, later on. And this is looking at people other than those aged over 45 with hypertension and a deep supratentorial hemorrhage. So the assumption about those people, as you can see in the title of this slide, is that they are so overwhelmingly likely to have small vessel disease as an explanation for their hemorrhage that they would not merit further investigation. And there are rare examples of exceptions to that rule, so we do need to be very careful about these rules in practice, but it's not a bad rule of thumb. And what this diagram study, which was done in the Netherlands, showed that if you did CTA within 7 days of an intracerebral hemorrhage, you can see that it identified 47 people with a relevant underlying abnormality, but it identified some false positives, 12 false positives, people who appeared to have an abnormality on CTA, but in the end, after all investigations were done, they appeared not to. But importantly, there were 18 people who wound up having an underlying cause, a secondary cause in the end, but in whom the initial CT angiogram was negative. So the sensitivity of CTA alone within 7 days is 74%, specificity 91%. In the people who went on to have an MRI 4 to 8 weeks later, you can see there's a small change in some of these numbers, but the sensitivity is only improved to about 82%, and that'll be due to the detection of things like AVMs and in particular cavernomas that can only be reliably diagnosed on MRI. So this is still diagnostic test accuracy that we would like to improve on. So in just over half of those patients, they went on to have a catheter angiogram, by which time the vast majority of underlying abnormalities are identified, but there was one patient whose underlying secondary cause was actually missed by catheter angiography, even after this rigorous pursuit of an underlying cause. So for those of us who work in comprehensive stroke centres and areas of specialist neurological and neurosurgical practice, proceeding with this sort of plan of investigation is relatively easy. We work closely with our interventional neuroradiologists, but I think it's very easy in other hospitals where these tests aren't available to perhaps not undergo such rigorous testing or not dare to ask for these diagnostic tests. But I think this study clearly shows the benefit for our patients of considering this and talking to our colleagues in interventional neuroradiology, diagnostic radiology, about appropriate further investigation of patients with intracerebral hemorrhage where there may well be an underlying treatable abnormality. This has been nicely worked on by David Werring and colleagues with the people who conducted the diagram study, looking at the derivation of a prediction score for identifying an underlying abnormality, and then externally validating a prediction score. And in a review article that's just coming out in Practical Neurology soon, written by Ian McGurgan, this is a flowchart conceptualizing how we might take the knowledge from the diagram study and the prediction algorithm and apply it in our everyday practice. So if we start at the top with our patient with intracerebral hemorrhage, we'd assess their risk of a macrovascular cause like an AVM or an aneurysm. And if we consider the patient I presented to you, this 49-year-old man with a cerebellar hemorrhage, well, if we look at the left-hand category, he doesn't meet those criteria. He's not over 50 with a history of hypertension and a deep intracerebral hemorrhage and CT signs of small vessel disease like leukoariosis, lacunes and atrophy. Those are the three sorts of things we should be looking for on CT to rule in the presence of small vessel disease and consider that as an underlying cause. So in people like that, the risk of an underlying lesion is low, and we wouldn't routinely do further imaging. However, if you have an intermediate or a high risk, so for example, we've got my patient who's just under the age of 50. He didn't have a history of hypertension, he had a cerebellar location hemorrhage, and his brain imaging didn't show any signs of small vessel disease. We definitely want to take investigation further. So if you do a CTA as the first test and that's positive, then you saw that there were false positives as well as false negatives from that. But in those who are positive, they do need the abnormality confirmed with an intra-arterial digital subtraction angiogram, so patients should proceed to that on the right-hand side. But if the initial CTA is negative, then the next thing you might like to do is look to see if there is evidence of lacunes, atrophy, or leukoariosis, as I said. And if there is not, as in my patient, you would then want to proceed with a catheter angiogram, and that's obviously one of the many reasons why we did in his case. But if there is evidence of cerebral small vessel disease, that is the most likely underlying pathology with underlying the hemorrhage, especially so if somebody already has a background history of high blood pressure. And if they do, then that makes the likelihood of a catheter angiogram finding an underlying abnormality low, and we wouldn't normally go ahead and do that. But if there's no past history of hypertension, even though there's evidence of small vessel disease and somebody meets the intermediate or high risk criteria, then it would be reasonable to go ahead with a catheter angiogram. So I hope that's a useful rule of thumb for us in our everyday clinical practice to stratify our patients into those at low, intermediate or high risk of identifying an underlying secondary cause, and to manage them as best we can in collaboration with our radiology colleagues. So if we go back to the pie chart I showed you at the beginning, about 85% of cases of intracerebral hemorrhage are due to underlying small vessel diseases. And of course, deep in the brain, it's arteriolosclerosis and the various other pathological terms that are used for this sort of small vessel disease, lipohyalinosis and so on, in the perforating vessels that may cause deep thalamic basal ganglia bleeds. But in the cortical, lobar, superficial regions of the brain, of course, in those arteries, they may be affected by arteriolosclerosis, but uniquely there, they may also be affected by cerebral amyloid angiopathy. And as you'll know, cerebral amyloid angiopathy has been of great research and clinical interest in this area, not only with intracerebral hemorrhage, but also in the dementia field. Due to the perivascular deposition, as you can see here, of beta amyloid protein with a variety of different manifestations of this small vessel disease on MRI, some of which cross over with the deep perforating vasculopathy like white matter hyperintensities, but others like the distribution of cerebral microbleeds may be a clue to the underlying vasculopathy, especially if they are strictly lobar, strictly cortico-subcortical, as you see there. But what we see in many of the hospitals that we work in the UK, where even MRI is not always readily available, it's been easy to assume that lobar intracerebral hemorrhage means that the bleed is due to amyloid angiopathy. And I hear this frequently in clinical practice, not just here in Scotland, but elsewhere, that as soon as we see somebody with a lobar ICH, we are tempted to invoke cerebral amyloid angiopathy as the explanation, and that's certainly not always the case. And you can see here from these neuropathological case control studies that the extent of the association between CAA and lobar ICH is only modest, an odds ratio of about 2 or so. And that's not a really strong association, but it clearly is one. So we know that CAA may cause lobar ICH, but what we really need to do is use some of those MRI features, or perhaps others, to better identify people whose bleeds are most likely to be due to CAA. And of course, we know that apolipoprotein E genotypes are associated with CAA, and that may also be a clue to the underlying cause, although we don't use this in routine clinical practice. So where we can, we want to go ahead with doing MRI, and that's relatively easy. For me in my own clinical practice, either for research reasons or clinical reasons, to go ahead and find some of these nice clear imaging phenotypes like convexity subarachnoid hemorrhage, superficial siderosis, strictly lobar microbleeds in large perivascular spaces, and so on, that may demonstrate this rather distinctive imaging phenotype you see on the gradient echo sequence in figure G here of a lobar bleed most likely due to CAA. So this resulted in the modified Boston criteria incorporating superficial siderosis, and they appear to have, in the studies that have been done, reasonable sensitivity and specificity. But you can see here from my description of the methods of this study that the reference standard wasn't always standardized. There were various different approaches, some extensive, some limited, to obtaining pathological tissue to verify this. And the numbers in this study were relatively small. So ever since this time, there's been a big effort internationally in many places, including in Boston, to try and improve upon this and gather more information pathologically for us to really understand what the underlying causes of hemorrhage are. So given that you've asked me to talk, I'm just going to give you a perspective on my study that I've done, but trying to put it in context of everything else that's known already. So I was wondering if we might be able to diagnose CAA hemorrhage using widely available tests. And in my own population here, where we've looked at every single intracerebral hemorrhage since 2010, we can only do MRI on 16% of our patients. And that's with us having been provided with funding to do it. And that's because many patients are too unwell to get in the MRI scanner, or they've died, or they have contraindications like a pacemaker, or they're intolerant of lying flat or claustrophobic. So we can only do MRI in a select few of our patients with ICH. So I was wondering if CT and even a blood test could help us diagnose hemorrhage due to amyloid angiopathy. So this resulted in us deriving these diagnostic criteria for amyloid angiopathy, underlying lobar intracerebral hemorrhage, and we've been in the process of a painstaking effort to try and externally validate them, but this is only the derivation I'm presenting to you. And this was done in our population-based cohort, where we attempted to get a research autopsy of the brain in patients who died, most of them dying within a few weeks of the intracerebral hemorrhage, but some much later. So we're tending to look at a group of people who are undergoing autopsy relatively soon after the intracerebral hemorrhage. So the first thing to say from the case is if we look at the 48 non-lobar hemorrhages that were in this study, you can see here on the left-hand side that in the vast majority of them there was no evidence of CAA, and that they had moderate or severe small vessel disease of another type. There was a small number of people who did have CAA, but as you know, CAA is prevalent in older people's brains without causing dementia or lobar intracerebral hemorrhage, and that's about the frequency one would expect to see. But in the 62 patients with lobar intracerebral hemorrhage, who are the ones we focused on in trying to develop diagnostic criteria for underlying amyloid angiopathy, you can see that slightly more than half had moderate to severe CAA on the right, and just under half had pretty much no CAA at all. So this is one of the reasons for being cautious about assuming lobar hemorrhages are due to CAA. Just under half of them are not. And then when you drill down to who has actually CAA alone in the absence of other types of small vessel disease, perhaps attributable to hypertension and aging and so on, only 16% had CAA alone. And the remainder had CAA combined with other small vessel diseases. So probably the combination of those two small vessel diseases may explain hemorrhage in some of those cases, not just the CAA. So we therefore derived low, medium and high probability criteria for identifying amyloid angiopathy underlying these lobar intracerebral hemorrhages, and we chose 3 predictors in the end, and I won't go over the methodology of the study in the interests of time, but one of them was subarachnoid hemorrhage over the surface of the brain, the other was possession of an apolipoprotein E4 allele on a blood test, and the other was the appearance of finger-like projections of the blood on the CT scan, which may suggest amyloid, and this is something that's been reported in case series here and there in the past, but it was a feature that we rated, and it seemed to be associated with amyloid in the analyses of associations that we did deriving these criteria. So let's take somebody here who has an example of a scan with none of these 3 predictors. No subarachnoid extension, they didn't have an E4 allele, and this is a fairly well circumscribed hematoma with no finger-like projections. Then we have people who have one of those criteria. We didn't have anybody who had finger-like projections alone, but we had people who had either subarachnoid extension alone, as you can see in the second scan along, or somebody who didn't have finger-like projections or subarachnoid extension, but did have an apolipoprotein E4 allele. And these people seem to be at medium risk of CAA. And then here you've got the combinations of these 3 predictors, which are illustrated by these scans here, that seem to confer a much higher probability of CAA, and you can see on the right hand side some of these finger-like projections that I'm referring to. And the bottom line in this particular patient population was that the low diagnostic criteria, the low probability diagnostic criteria seem to have a pretty good sensitivity for ruling out CAA. The confidence intervals are wide, obviously 88 to 100%, because there are only 62 patients in this study, but it was pretty hard work even getting that number with research autopsy, as you can imagine. So it seemed like the absence of these criteria were quite good at ruling out CAA in this population, and that the rule-in criteria were fairly specific. And I think it's probably this specificity which in the follow-on studies that other people have done seems to be being replicated reasonably well, that the criteria seem fairly specific when you do have features like finger-like projections, subarachnoid hemorrhage, for identifying CAA. Here are some more examples of finger-like projections, and they're projections that are longer than they are wide from the lobar intracerebral hemorrhage. And if you're interested, these are the prediction model performance statistics, so an area under the curve of 0.92, which was quite good and reasonable calibration. But as I said, external validation is ongoing, and it's also of interest to look at people who've survived longer after their hemorrhage until they die, although of course the assessment of pathology then is quite difficult because of the progression of these underlying diseases between the hemorrhage and death. They seem to have good rate of agreement between neuroradiologists, and we're, I'm hoping, completing external validation of these criteria soon. And the other disadvantage, of course, is that ApoE testing isn't routinely available in clinical practice, but if it proves to be useful in this particular instance, then maybe it will be one day, we shall see. And finally, this is a website that you can visit with online training for rating these criteria, where you can get a certificate as well if you manage to progress through all of the test cases. So what I'll just move on to finally is the dilemma about antithrombotic drugs after intracerebral hemorrhage, and I'll just focus on antiplatelet therapy because, again, the request of Dr. Ali, I just focused on what's new in recent years in my research program. So here's a lady, this isn't obviously hers, just an illustration of a 77-year-old woman with a fairly typical past medical history who presents with a stroke, and she's already on aspirin at the time. And here's her diagnostic CT scan showing a deep intracerebral hemorrhage. And you can see here her 3-month MRI shows signs of cerebral small vessel disease, no underlying lesion, and not much in the way of cerebral microbleeds on the gradient echo sequence. So the dilemma for her is whether or not she should go back on her antiplatelet therapy whilst we've already been attending to the top priority for secondary prevention, which is satisfactory lowering of her blood pressure. And in the UK, we tend to do that to a target of under 130 millimetres of mercury systolic. So the other dilemma, of course, is whether we should be restarting her aspirin. She had a good reason for taking aspirin before the bleed, but should we omit the aspirin because she's just had an intracerebral hemorrhage, or should we acknowledge the fact that people with bleeding have quite widespread evidence of atherosclerotic vascular disease, a lot of the time in previous symptomatic manifestations of it. And we know from the Antithrombotic Trialist collaboration that antiplatelet therapy reduces the risk of major vascular events, despite, as you can see here, when used for secondary prevention, a non-significant increase in the risk of bleeding. Clearly, overall, in primary and secondary prevention trials using aspirin, there is a significant increase in the risk of bleeding, just a small one though. But in secondary prevention, even in all the many trials that were done the last time this meta-analysis was conducted, that effect was not statistically significant. So that's why we did the RESTART trial in the UK, and thanks to those of you from the UK who supported this trial. We couldn't have done it without engagement at 122 sites around the UK. And we aimed to recruit 720 participants, although we didn't get there. It was a very difficult trial to recruit to because people were generally afraid of giving antiplatelet therapy to people who'd had a brain hemorrhage. And we wanted to really just estimate the effects of antiplatelet therapy on a primary outcome of recurrent intracerebral hemorrhage. So we identified patients who previously had vaso-occlusive disease of some sort and had been on an antithrombotic drug. At the time they had an intracerebral hemorrhage. They survived for more than 24 hours. We tried to put as many as possible in the brain MRI scanner and simply randomised them to either start or avoid antiplatelet therapy. We consented 562 patients, and 537 of them were randomised almost equally to start or avoid antiplatelet therapy. And during follow-up, one patient withdrew and we didn't lose anybody to follow-up. So we had very complete follow-up, more than 99% completeness. These are the baseline characteristics where they show you more or less what you would expect of an intracerebral hemorrhage population. Although there was a preponderance of men, as is often the case in stroke trials, their median age was about right in sort of the mid-70s. Almost 2/3 of them had a lobar intracerebral hemorrhage location, which we were pleased about. These inbuilt fears that people have that all lobar hemorrhage is attributable to amyloid angiopathy, which, as you know, it is not. And these patients were randomised on average within 2 or 3 months of the onset of their hemorrhage. And in most cases, people were intending to give aspirin, but quite a large proportion of these patients also intended to have clopidogrel if randomised to start antiplatelet therapy. So the primary outcome in this trial was recurrent intracerebral hemorrhage. And of course, what we were expecting was that the people who started antiplatelet therapy would have a higher risk of bleeding. But what we were pleasantly surprised to find out was that the group in blue who started antiplatelet therapy had a risk of recurrent hemorrhage of approximately 4.5%, whereas interestingly those who avoided antiplatelet therapy had a risk of about 8.6%, so completely the opposite direction of effect that we were expecting. That was a non-significant reduction from antiplatelet therapy, but that was obviously very far removed from what we had expected, which was that the hazard ratio would be more like 1.67 as it was in the Antithrombotic Trialist collaboration. So 0.51 is really quite far in the opposite direction from that. So I think this is reassuring. We wanted to check that there was no confounding at play, so we tested different approaches to statistical analysis. We looked at adherence, which, as you can see, was pretty good. And we looked to see if there was a difference in blood pressure control between the two trial arms, and there wasn't. So we were fairly reassured that these effects seemed to be attributable to antiplatelet therapy. But this was just one trial done in the UK. we had a look at a variety of secondary outcomes, and amongst the ones we specified in the protocol was the same one that had been used by the Antithrombotic Trialist Collaboration in their meta-analysis. And you can see here that we found what one might expect antiplatelet therapy to do, which is reduce the risk of major vascular events. So that was just one of many secondary outcomes which needs to be replicated in a follow-on trial. I won't go into the subgroup analyses in detail, but these are the clinical subgroups. And the basic message from this, there are two basic messages. One is the 95% confidence intervals are wide, because unfortunately we didn't manage to randomise as many patients as we would have liked to. And secondly, that all of the point estimates in all of these subgroups are to the left-hand side of the line, which is where the overall effect was found in the trial, favouring non-significantly starting antiplatelet therapy. So I think subgroup findings appear to be consistent, although imprecise, and no statistically significant interactions. Again, I'm not going to show you the detail here, and this should be almost illegible for you, but we looked very carefully at CT imaging features on the left and MRI imaging features on the right. And again, you see similar findings here, that most of the point estimates are to the left-hand side of the line, consistent with the overall effect. And there were no statistically significant interactions here, although again, these subgroups were smaller than I would have liked, if only we'd managed to randomise more patients. But all is not lost. Hopefully we can build on these encouraging and surprising findings to do another trial, not only to confirm the effects that we've seen of antiplatelet therapy, but also look in more detail at subgroups and hopefully expand the trial to patients without previous vaso-occlusive disease. Because of the reassuring safety that we've seen in Restart, it would not be unreasonable to include people with intracerebral hemorrhage alone who have many vascular risk factors for occlusive vascular events and might benefit from antiplatelet therapy. So we really need to test all of those findings in further trials. We've just finished 2-year follow-up of the Restart trial, but I don't have the results yet, and we hope to present them later in the year to see if this effect becomes significant and lasts even longer during follow-up. So what we'd like to move on to do, but given COVID and various other things, it's been incredibly difficult to try to obtain funding for this, is move on to the Antiplatelet Secondary Prevention International randomised trial after intracerebral hemorrhage, aspiring to recruit not 537 hemorrhage survivors, but 4,148 to look at antiplatelet monotherapy in the same way, looking at all comers with intracerebral hemorrhage, about a third of them with prior vaso-occlusive disease, but about 2/3 without, to really see if we can reproduce the findings of the Restart trial and provide reassurance about the safety and hopefully benefit of antiplatelet therapy after ICH in the future. So, slightly tongue-in-cheek, I ask you whether the future of intracerebral hemorrhage could be as simple as making sure blood pressure is lowered well after hemorrhage, using CT in the majority of people to think about underlying cause, and maybe a tablet of aspirin, a bit like we've been doing with ischemic stroke for a long time beforehand. And finally, can't resist a quick advertising opportunity. As Dr. Ali said, I'm president of the British Association of Stroke Physicians. So for those of you who live and work in the UK, I just wanted to outline the benefits of membership, and that I would encourage you to join us so that we can continue to advance stroke medicine together. Thank you very much.
Thank you very much, Rustam, for such an excellent talk. And obviously, I've learned something new also about finger-like projection of cerebral angiopathy, which is causing a bleed. So, and obviously, I would encourage everybody who are part of dealing with stroke to be a member of a British Association of Stroke Physicians. So it is worth, and it's worth taking a membership. So I will open up the floor for questions. And the first question is from Dr. Rehan Jahanzeb. If a patient has been diagnosed with a CAA with minor bleed previously, now presenting with acute ischemic stroke within thrombolysis window, would you consider thrombolysis?
Yeah, thanks for the question. So that's presumably somebody, you say a minor bleed previously. Previously I take to mean not in the recent days, but probably months or years beforehand. And if that is the case, you've given me the easy answer to the question, that I know of no reason why that patient should not have thrombolysis. Obviously, the caveat is that in many of the alteplase randomized trials, patients with prior hemorrhage were excluded. So we do need to be careful about including people with previous bleeding. I think probably the biggest concern about amyloid nowadays comes from the identification of microbleeds at the time of MRI when we're making decisions about alteplase. And I think that the work that David Werring and others have done looking at what the risks of thrombolysis are in people with microbleeds seems to show that people with many microbleeds are at slightly higher risk of bleeding. But given the benefits of alteplase up front for ischemic stroke, even in those people it still seems reasonable for most of them, apart from people perhaps with huge numbers of microbleeds, to proceed with thrombolysis. But we do need to be very careful about thrombolysing people with recent intracerebral hemorrhage, and I think you need to be much more cautious about those.
Other thing from your talk, Rustam, today you said obviously CT angio can miss pathologies, MRA can miss pathologies, digital subtraction angiography is the best way forward. Obviously, working in a district hospital is very difficult to achieve. And many of these patients with suppose minor bleed or hypertensive bleed, or might be small bleeds, they are supposed to be on anticoagulation might be for PE, for any other reasons, or atrial fibrillation. So what do you think from that point of view? Do we need to do just a CT angiogram? My practice at the moment is I do CT angiogram and rule out any malformation and then consider starting anticoagulation if there's a strong indication for that. So will you recommend DSA in those sort of patients before starting anticoagulation?
And the anticoagulation is for
any other reason, metallic heart valve or PEs?
I mean, I think the indications for anticoagulation have varied, and the advice about that is rather specific to whether somebody's got a metallic valve, in which case you really do want to restart warfarin at some pretty soon after the hemorrhage, or whether somebody's got venous thromboembolism, when you might consider alternatives like vena caval filters. Or other cases with atrial fibrillation, where you might want to consider either randomization in one of the ongoing trials or left atrial appendage occlusion. I think it's a lecture in itself, that. But as far as your question about the conduct of angiography to identify an underlying lesion, I think I just advise you to follow that flowchart that I showed you earlier for all cases, because the reason for doing it is not just to reassure you that the patient is at only a modest increase of rebleeding. It's to reassure you, before you start anticoagulation, it's to identify an underlying cause that you might actually want to treat to reduce their future risks before you go on and anticoagulate them. So I simply advise you to think about presence of small vessel disease on imaging, location of the hemorrhage, past history of hypertension, to use the diagram approach, which you can find, to target investigation.
Yep, thank you. And then we have got a question, rather a case scenario given by Dr. Aziz. First of all, she said, thank you for webinar. There was a case, she said, elderly patient collapsed at home and was found to have had ischemic stroke. The patient was also diagnosed with AF at the same time. Warfarin was started, and after about 1 month, the patient presented with hemorrhagic stroke. The warfarin was stopped, but the risk of another ischemic stroke remained due to atrial fibrillation because the patient had a low mobility plus atrial fibrillation. Can I please ask, what's your opinion on such a case? Should this patient be on anticoagulant at all?
Okay, so this is somebody who had an ischemic stroke in atrial fibrillation. They were anticoagulated and they went on to have a hemorrhage. It's a situation that we do encounter in our everyday practice. I think there are various caveats. So you want to consider somebody's CHADS2 VASC score, but clearly somebody with ischemic stroke and AF already meets the CHADS2 VASC score criteria for us to consider anticoagulation. On the flip side, you want to consider things that might predict a higher risk of bleeding. So, for example, presence of microbleeds and superficial siderosis and the Boston criteria. But in general, we do not as yet have any published randomized evidence about the use of anticoagulation for AF in people with this combination of ischemic stroke and hemorrhage. There are many reassuring observational studies showing that in people like this who we do start on anticoagulation, they don't seem to have a much higher risk of bleeding than people who we avoid anticoagulation in. But those are observational studies, and we as doctors, we back winners, so they may be biased. So this year we will hear about 2 randomized control trials, one that I've been running in the UK called SOSTART and another one in the Netherlands called Apache AF that will report at the European Stroke Organisation conference, addressing this specific dilemma, randomly allocating people with AF after intracerebral hemorrhage to starting or avoiding anticoagulation. They've not been stopped by their data monitoring committees, and we'll just present the data that we have. And I hope that they will also be informative. But at the moment, my solution to this problem is to randomize the patients.
Fair enough, obviously. And I think similar question. Can you please give your advice on patients who have intracranial hemorrhage and AF who are on anticoagulants, especially apixaban?
So this is somebody who presents acutely with intracerebral hemorrhage on apixaban. Yeah, so there are obviously approaches to trying to reverse acute hemorrhage associated with apixaban that we tend to use in our everyday practice, such as the use of prothrombin complex concentrate, which is what we tend to use nowadays. But of course, there are specific reversal agents that are being developed, and mainly for the non-vitamin K oral antagonist direct thrombin inhibitors. They've been tested in observational studies. There are some randomized trials going on after hemorrhage for this particular patient group, but in my standard practice in the UK, we generally just use PCC for these people, pending confirmation that the specific, very expensive antidotes are more beneficial than that.
And the other question is from Dr. Naqvi. Will you start antiplatelets in a patient with excessive microbleeds due to cavernomas rather than cerebral angiopathy after TIA?
Okay, I'm not sure what excessive microbleeds means, but it's somebody's got somebody's only got
incidental finding on an MRI scan, most likely. That's what looks like.
Due to cavernomas, I think they're implying multiple cavernomas, because when we see these black spots, we tend to regard them as microbleeds in a certain age group, but maybe cavernomas in another, although you may get the distinctive imaging appearance of a cavernoma or even know about an underlying family history and genetic mutation. But bottom line is that in observational studies, there seems to be no increase in the risk of bleeding from cavernomas with the use of antiplatelet therapy. There are no randomized trials there, but there are multiple observational studies all showing the same thing, that the risk of bleeding doesn't appear to be increased. And in fact, in the meta-analysis that we did, there seemed to be an association between antiplatelet therapy and lower risk of bleeding with cavernomas. So it may be that thrombosis in the cavernoma triggers bleeding, and antiplatelet therapy could be beneficial for those people. I can't recommend treatment of cavernomas with antiplatelet therapy. We need a trial to show that, but there is reassurance from observational studies.
Yeah. Other thing, it would be difficult to diagnose TIA in that sort of patient, whether it was a tiny microbleed which has caused the symptoms rather than ischemic episode of TIA. So it would be difficult to diagnose even.
Yes, maybe, unless anatomically the symptoms localize perfectly to a cavernoma.
Yeah, I will say, obviously, we have got Rustam. We can ask a few more questions because from the training point of view, because some people have in earlier talks suggested whether the stroke trainees can have a training so that they can be involved in thrombectomy. Is there any move from British Association of Stroke Physicians that our trainees in future can be trained for thrombectomy?
So, if only the British Association of Stroke Physicians had control over this, but as you know, there are the General Medical Council and the specialist advisory committees for training have the biggest influence on what the curriculum and competencies should be for trainees. I mean, I think from a BASP point of view, all I can say is that we're really keen to see the stroke workforce grow in the UK. We're really keen to see trainees get involved with thrombectomy and grow the consultant workforce so we can deliver it to more patients. We know there's a lot of interest amongst trainees in thrombectomy, and the GMC has been considering credentialing for mechanical thrombectomy, including specialties other than interventional neuroradiology. There's no formal outcome from that process at the moment, but there have been moves to try to make sure that people with the relevant competencies can perform the procedure. At the BASP Trainees Weekend coming up soon, there are also going to be sessions on simulation training for thrombectomy, and that is happening on the last weekend of March. So any trainees who are interested in learning more could attend the BASP Trainees Weekend to find out about that. But that's the best answer I can give you at the moment. We're supportive, but it depends on the GMC.
Yeah, obviously it would be good to have a move from the association that to persuade it further for future. Anyhow, I'm sure you are doing it from that side, that it can be motivated and we can campaign that our trainees should be getting some experience in thrombectomy. Not all of them, obviously, the people who are really keen in it. So other thing there was an initiative about overseas doctor to get into a training post in UK, so that we can train them, either obviously like a medical training initiative, anything which we are doing for clinical fellows for overseas.
I mean, BASP remains supportive of anybody who is able to meet the Home Office regulations and come to the UK to train in medicine. And like you mentioned, there are schemes for overseas doctors to do that. So we embrace anybody who our laws allow to come and work in the UK to deliver stroke medicine. As a professional association, the British Association of Stroke Physicians will allow those people to join. We have an overseas membership category as well, and we're keen to see a stroke workforce that is complete rather than 40 to 50% missing, as the latest audits have shown. So we're supportive of overseas doctors coming to the UK to train.
Thank you. And last question, I will take it from the audience was the interesting one. Do you find weather association with intracranial hemorrhage as different data from different weather condition areas like India, West UK? Like in South Asia, we have more intracranial hemorrhage than in UK.
Yeah, people have looked at this, and there's this feeling that a cold snap in the weather may trigger intracerebral hemorrhage, and there are some data to support that, and maybe even changes in atmospheric pressure as well. Unfortunately, the weather's something we can't control, and although there are observational associations in some of these analyses, it may cast interesting insights on what actually leads to intracerebral hemorrhage or what may trigger it, but I'm not sure how to turn those into therapeutic advances for our patients.
So the question was the other way. They were thinking of more intracranial hemorrhage in South Asia. Might be hot weather causing more. To me, it looks like, personally, I feel might be it is uncontrolled blood pressure in those areas. That would be.
So I understand the question. Well, if you look at the Interstroke case control study, thousands of patients all around the world in low, middle and high income countries, then the latest findings in the Lancet a few years ago show that there are a large number of modifiable risk factors that are associated with intracerebral hemorrhage: diet, exercise, BMI, high blood pressure, and so on, socioeconomic deprivation. And many of those things will be different in South Asia from in other countries, and I think that they're more likely to have an influence on the cause of hemorrhage than the weather.
Thank you very much, Rustam, for coming and presenting to us and giving your precious time. And now it is a lunch break. So I would like to say, because we are doing in our own comfort zone this masterclass, so we can resume, maybe it would be a short lunch break. So can we resume timely at 1:30 after 12 minutes, if people don't mind? Because in this fashion, we'll be able to finish our masterclass on time by 5 o'clock. Our on lunchtime sponsorship talk is at 4:30, not at lunchtime. So 4:30 would be our last talk from Medtronic, which is a sponsored talk, and it will be a pre-recorded talk, which will be for 15 minutes approximately. So thank you. So I will see you in next 11 minutes time. Take care. Have a good break. Welcome, Daniel. Good afternoon.
Well, thank you, Asem. Good afternoon.
Thank you for joining promptly, and we'll be starting our after lunch session after a couple of minutes. We were a bit late in the morning session, but we have cut down our line time.
Okay, no problem.
How's the weather in Helsinki?
Actually, it's quite a lovely winter. A lot of snow. Everything is white. -20, but it's
20, yeah.
at least this morning. But -20 means a lot of sun. You know, it's very nice actually.
Good.
How is it in London?
We are in North Lincolnshire. We are based in North Lincolnshire in Grimsby at the moment. And the weather is, I think, a bit mild now. We had a snow about a week ago, but now temperature is, I think, 5, 6 this morning, which is pleasant actually.
Okay. Asem, can you see my screen, by the way?
Yeah, we can see your screen
Okay,
nicely.
Thank you.
Okay, everybody, we're going to start our post-lunch session, and I hope you had a quick grab of sandwich or something. We have cut down our line time so that we can finish masterclass on time. I'm sure you would like to finish it on time because obviously you are stuck throughout the day. But the masterclass is going so well at the moment. The speakers have done so much justice through their topics. So I'm really excited and enjoying it. So next speaker for our talk is Daniel Strbian, Associate Professor and Chief Doctor, Division of Emergency Neurology and Neurocritical Care, Department of Neurology, Helsinki University Hospital. And I always think a Helsinki model is quite good. And for last 10 years, we are thinking Helsinki is achieving door to needle time in such a nice way that I'm quite jealous about that. And I wanted to have Daniel on this talk so that we can improve our door to needle time for thrombolysis. So the main idea of asking Daniel is to share what he's done in Helsinki or how Helsinki is achieving reduced door to needle time. So up to Daniel now, kindly present on reducing door to needle time and Helsinki model. Thank you, Dan.
Thank you, and thank you very much for inviting me. So I think we have like half an hour and then maybe 10 minutes for discussion, I assume.
Yes.
Okay, thank you. So let us start. So I have nothing to disclose for the context of today's presentation. And of course that the most important question is reducing of door to needle time. But if we would like to reduce door to needle time, so of course we have to see the big picture. We have to actually have some understanding and maybe control of what is happening from onset of symptoms until the needle time. And as we can see from this graph, so basically the door to needle time is actually a small portion of the whole process. So we really need to start from the beginning if we would like to achieve some success here. And just to give you some example, this is Finland. And the area I am working in, Helsinki, is here. And this HUS, this is our primary catchment area of 1.7 million people. So now, for those of you who don't know, Finland's population is 5.5 million. The 1.7 lives here. And then the secondary regions for that we are responsible is this PH, KYM, and EK. And this would be our whole region here. And now let us zoom a little bit in. Now you see this is our primary area, and those would be the secondary regions. Altogether, this is 2.2 million people. So it's almost 40% of the whole of the Finland's population. So you can see that it's quite, and still it's not very heavily or densely populated area. But this is maybe something that you need to understand. Why are we achieving such good times, and in what way our system is organized? Here we see the Helsinki University Hospital, and then in the same metropolitan area we have Jorvi and Pejas. These are in two neighboring cities of Helsinki. And actually, this hospital is in the same part of the town where is the international airport. And altogether, this accounts for 1.1 million person or people. There are hospitals, but they are not admitting acute stroke patients. Then we have city of Porvoo, Hyvinkää, Lohja, and Raasepori. Those would have something that we call central hospitals, and they are not admitting any acute stroke patients. So which means that the whole region of 1.6, 1.7 million population, the only hospital that actually is providing acute neurological services is our hospital. And for this, of course, it needs a continuous education, continuous discussion with the emergency medical services, and everybody has to, of course, be understanding of the process, has to know the rules. But in a way, it makes it much more easier because we have the same person who is responsible for emergency medical services in Helsinki. He is in charge of the whole region, and in a way, it helps our issue. So it doesn't matter what is the time, is it office hours, out of office hours. So every single patient who has a suspicion of a stroke, she or he will be brought to our hospital. And this is maybe one part or one key of the success. And from these regions, from the secondary areas, so they would consult us through telestroke, and then we would take those patients to our hospital only if thrombectomy is required. So for thrombolysis, those cities, they take care of the patients on their own. So let's little bit before we would like to just talk about reducing of the door-to-needle time. So we have to have some rough estimation of how long delays we can expect in a system like Helsinki. And before we talk about the delays, so this is, of course, this is almost or even more than 10-year-old publication that we published in Stroke. And we try to actually estimate like how many patients we see who will receive thrombolysis within 70 minutes from stroke onset or within 90 minutes of stroke onset. And there actually was quite a big difference in the outcome. So then we call this ultra-early thrombolysis, and those patients actually benefit from the thrombolysis more than the patients who have been treated in the 90 minutes time. So it means that actually the being very fast is something that we wanted to achieve. And this is as well quite maybe known publication in which it was shown that actually every minute that we can save, it has influence on the patient's outcome. So let us start when we would like to talk about the time delays. Let us start with onset of symptoms and the delay until the first call. So in our region, we have done a study, and the median time was 40 minutes. So it means from the onset of the symptom until the call to 992. But if you have a look here, the 75th percentile is 47 minutes. So it means that basically 25% of the patients, actually the delay from the recognition of the onset until the call was actually more than almost 50 minutes. And it's not a small proportion of the patients. Of course, it means that there are some factors, and we will be talking about those factors that are influencing why in some situations the notification is made very late. Then once the phone call to 112 was done, then we have another delay from call to alarm. And this is median 2 minutes 53 seconds. 75th percentile is 4. So this is quite straightforward. So next, after alarm was done, so from alarm to on scene, it's median 7 minutes and 21 seconds with the 75th percentile of 9 minutes 45 seconds. And I will be talking later about the factors that are influencing these delays. So the next step, the emergency medical services arrives on scene and they are with the patient. So this is, in our region, it's 59 minutes, almost 1 hour, and 75th percentile would be 80 minutes. So this is quite a long time, but this of course includes as well the time that is spent on a scene. And again, I will be describing the factors that are influencing this delay a bit later. And then the patient actually crosses the door of the hospital, comes in, and then we can deliver TPA. And this was in general in Helsinki 17-18 minutes, but just for the context of this particular study that was performed, in that study it was 20-minute median, and 75th percentile, as you can see here, was 4 hours. You might be asking why this is 7 hour 47 minutes, because this study was done several years ago, but those would be the patients with a basilar artery occlusion, because in Helsinki, for those, we had a much different protocol from other centers. We have been treating those patients depending on the phenotype. Was it acute or a more like progressing 12 or 48 hours even after onset of symptoms. So that's why the 95 percentile is a bit long. So if we would like to understand what's going on after the onset of symptoms and before the first call to 112 is done, so we have been actually looking into some details. We have been studying actually the phone calls because almost all of the phone calls have been recorded. So it was sort of easy. It was actually a difficult task, but one of our younger colleagues, he went through all of the recording, and then he was able to identify some of the factors that would influence the delay from the onset of symptoms until the first call was done. So of course, as you can imagine, it would be the stroke severity and localization that will influence the delay. And then the next thing would be the dominant or non-dominant localization of the hemisphere, and then if the person was living alone or not. And here it was much more common. I think this is mostly maybe in other Western countries, that mostly it was women that have been living alone at older age. So this was as well one of the factors why the time delay between the onset of the symptoms was quite long in some cases. So the living alone and then the severity and localization of the symptom was influencing these delays. Then the call itself, of course, it's important. Who is calling? Is it a child? Is it adult? And then is there a language barrier? And is the person who is calling actually using the correct words? And we have very good experience with FAST. And if the person calling actually maybe based on the lay people education, if there is a global awareness of the stroke code. So of course, if somebody is using the correct words, then the person who is actually answering the phone call can make a better decision. So of course, it's both the lay people education and the personal education who is answering 112. And then the duration of call per se. So all of those would be influencing those delays. And in some cases, if the situation is unclear, so maybe the person who is answering the phone call, maybe he or she can give advice, okay, please follow up the situation and please call us later. So all of those like new calls are of course causing new delays. And then once the alarm was triggered, then the alarm to on-scene delay, of course, is quite understandable that it depends if we are in a rural or urban area and if the correct dispatch code was used. So are we going according to the stroke protocol or not? And if it's a stroke protocol, then what is the dispatch priority code? Is it A, B, C, D, or E? And then what is the infrastructure? Is there a typical use of helicopters or not? So, for example, in our region, we are not using helicopter transport actually very often. They are reserved for some very specific situations. So, for example, compared to Switzerland, we are not using the helicopters almost at all. If I would go, of course, we are using, but compared to Switzerland, it's very, very limited use. And then when we look at what is happening in the next phase on the scene, so of course, we know that this was almost 59 minutes, 1 hour spending on scene, plus then when the transport to the hospital. That's quite a long time, 1 hour. And that is why a lot of cities in the world have been thinking about, is there any way how we can maybe deliver the TPA already on scene, as it was, as is being done for the myocardial infarction. But for this, of course, we would need some tool to distinguish between ischemia and hemorrhagic strokes. And there are some cities in the world that they are using city ambulances, but of course, it's very much city specific. And of course, it's not a cheap solution, but this is in use in some centers in the world. Another line of research would be using of reliable ultra early biomarkers, which can tell us the patient is suffering from hemorrhage or ischemia. And but of course, this is something that we still there are not such results that we would use in the clinical practice for decision making nowadays. But there's some promising research in this area as well. So something like this would, of course, save us time or save the patient's time. Then the next thing, what we have to consider from scene to door of the hospital, again, because one thing is sort of like the dispatch code and dispatch priority code, but the next thing is the transport code and transport priority code from the scene to door. So again, we have to make sure that the correct protocol is used and the correct priority. Then what we find that is really important is that irrespective of who is calling and what time it is, there is only one and single phone number, and that is the only number that is being used for acute stroke code. So there is no other number to remember. It's only one number always, and it makes actually everything much easier. So everybody in our region with 1.7 million inhabitants, when there is an acute stroke, they will call the emergency medical services will call to the same number. The next thing, now the patient, of course, the on-scene to door time takes almost median 1 hour. So we have to make sure that everything that is important for reducing of the door to needle time in the hospital, it means that we have to make use of the transport time. So we have to make sure that we gather all relevant information about the patient, everything what is possible and available already during the transport of the patient. So before he enters the door or she enters the door of the hospital. And for this, it's very important that we receive some sort of a pre-notification. So this, for that purpose, we had like this phone number that was available and a single phone number. But nowadays, we even have a web browser-based notification tool that emergency medical service is using. And we can see in the real time that where does the ambulance come from, what is the patient, what is the patient's name, what is the history of the patient. We can see the social security number, so we can use the social security number and we can then check in our electronic medical charts everything what is known about the patient's previous diseases, what is the level of disability. We can check every old laboratory examinations, old radiological examinations, anything that was registered, so we can find, and of course the medication. So we can check everything before the patient comes, and if it's necessary, we can call to relatives. We can call to anybody who was present as a witness on scene. So in other words, if we would like to reduce door to needle time, we have to do everything else before the patient comes to the hospital. There's actually no other way, because if you start to do all of things once the patient is in the hospital. So of course, then there is no time for anything else, and then it causes the delays. So that's basically the philosophy here, is that do everything what you need to do before the patient comes to a hospital. And we have an agreement with the emergency medical services that they are controlling some simple things. There's a blood pressure, glucose level, heart rate, body temperature, and oxygen saturation. And then they will do a very simple ECG for us. And then we have an agreement that they will try to do or insert a large bore needle for contrast agent. But if they will not succeed 3 times, they let it be, and then we will notify our ER anesthesiologist, and then they will do it upon patient's arrival. So they will do it maximum 3 times. So no time is wasted then. And then, of course, when the patient is already in hospital, so then we try to be as fast as possible. We have some cases of patients that maybe we have the door-to-needle time of only 8 to 9 minutes, but those are very straightforward cases. So in general, after we have received the pre-notification, and then we know that the patient is coming to the hospital, and we know or believe that we know all single relevant information about the patient, so then we actually are waiting for the patient in the CT room. The CT room is actually located directly in the ER room. It's on the same level where the ambulances are coming, and it takes about, I would say, 15 seconds to walk from the ambulance arrival to the CT room. And we can see, if we are standing in front of the CT room, so we can see the patient actually coming from the ambulance on the way. And we make sure that the CT room is empty. So when the stroke code is sort of triggered, so we have several CTs, and one of them is always empty. And there is a nurse, there is a radiological nurse, and then there's, of course, the stroke doctor, and everybody is waiting for the patient. Then already when we are receiving the sort of like official report from the emergency medical services, we are transporting the patients on the CT table, and then the laboratory nurse will start to take the samples. In situations that in some situations we take the point of care INR, and then the nurse can take all the results, but we are not waiting all the other labs, but we are not waiting for the results. We are only waiting for the point of care INR, and the other results will come later. And then we will do chest X-ray after the bolus, and we will not do ECG prior to bolus of TPA. Usually, in many cases, we do not wait for the radiologist to be present, but the stroke doctor will sort of see the images him or herself, and will make the decision based on his own expertise. In some cases, of course, nowadays is much more common that we would need, in addition to the native CT scan, we would need angiography and perfusion imaging. Of course, it takes some more time, but actually the imaging itself is done in matter of few minutes, 2-3 minutes, but then of course the post-processing of the images is what takes some time. And in some cases, what we are doing is that when the patient comes into the CT room, so the nurse already has something that we call like the thrombolysis package, and in a very straightforward cases, the nurse is already premixing TPA while we are examining the patient, so everything is then ready. And in a typical situation, we can already, after the decision is done, we can inject or start with the bolus already while patient is on CT table. And what, of course, is helping, what is helping in reducing of the door-to-needle time is, of course, the experience of the center, and that is based on the annual volume of the center. But because I told you that in the whole region of 1.7 million people, there is no other hospital that is admitting acute strokes, it means that all the patients with the stroke codes are admitted to our hospital. So we have, of course, the volume is quite high. We are giving something like, of course, it's changing, but we are giving something like 300, 320 thrombolysis per year. And as for the thrombectomy, it's roughly about 260. So these are our numbers for this catchment area. And this is based on one of our publications. This was published actually some years ago. We sort of tried to put in chronological order, like what was done since '98. And since, as you can see, like a lot of things have been implemented in our hospital. Not really major change after maybe 2005. And so what it was started at that time, of course, there was Emeritus Professor Marco Caste who was involved, and there was a huge discussions with the emergency medical service personnel of how to organize the things. And this actually was the start maybe of the Helsinki model. Then in 2001, we started with the hospital pre-notification. There was like usage of the single phone number for all stroke coach patients. Then the same year, a bit later, based on the pre-notification, we can already order for the patient the laboratory examinations and the radiological examination. So basically all of those we can do before the patient comes to the hospital. In 2001, we need to use 4 different platforms to look at the patient's data, to look in the laboratory results, to order laboratory results, and to order and see the radiological examinations. Now we have actually one single platform, and since last November, and I have, for example, prepared a package that you just need one click with the mouse, and then it orders everything for the patient, and no more time needs to be spent for ordering of the laboratory and radiological examination. It just takes 1 second, and then it's done. So we are actually quite happy with the new system. It saves a lot of time. Then in 2001, again in the same year, we started to going in the direction that it was not necessary to wait for the radiologist. Of course, if radiologist is present, it's okay, and of course we are discussing with him, but it's not necessary. And especially in out-of-office hours, we do not have a neuroradiologist on call. So that is even more important that out-of-office hours, stroke physician is doing the interpretation alone. Then from 2002, we sort of started with the premixing of TPA, but I can tell you that this is really not very typical or common. We only really do it for some very straightforward cases that there is no doubt that there will be a thrombolysis, and of course we cannot rule out intracranial hemorrhage, but in some cases we do it, but it's not so often used. I have to tell. And then in the same year later, so we started with the delivery of TPA while the patient was still on CT table, and then after a big reconstruction of the ER room in 2003, we relocated the CT directly to the ER. Before, it was actually on different floor. And now we have 2 CTs in our ER, and we are just in the process of building a new hospital that is connected to the current one, and there will be new ER, and there will be in the emergency room, there will be 4 CTs and 1 Raptor, and there will be MRIs directly in the emergency room, and this will be finished in 2023. So of course we'll see then if our process will change at that time. Then in 2004, so we agreed that now when the CT was already in the ER, so then we have agreed with the radiology personnel and the ER personnel that all the time that the stroke code is triggered, that the CT, one of the CT is emptied, and then we are waiting for the patient in the CT. So everything else needs to be done before. And then once the patient comes to the hospital, so he is on CT table, and then we start to make NIH and then ask the questions and examine the patient. Then, since actually in the emergency room, we started do it already in 2004, and then maybe on the statewide level, it was a bit later in 2005. Since that year, we had a fully electronic patient chart, and this, of course, it's much easier to use for the for getting all relevant information about the candidate for the thrombolysis. In the same year later, we implemented usage of point-of-care INR, and this usually takes 40 seconds, and then we have the results. But I think this is quite typical in many cities in the world. And then we, of course, now it's 2020. A lot of things have changed. We have extended time windows. We have a lot of perfusion images and so on for selected population of patients. But at that time, the philosophy was that we actually maybe we do most of the decisions by looking at the non-contrast CT scans. And while we have listed all the changes that we have implemented, so we have noticed that from 98 to 2011, we've been able to reduce the needle time quite radically. Here it is 17, 18 minutes. And then at the same time, we've been able to give the thrombolysis to much more people. So we've been treating higher volume of patients with smaller or shorter delays. And this is something that became to be known as a Helsinki model. And it was shown by Update that when he was in Melbourne, in Australia, that this is something that can be actually implemented in other hospitals as well. So he can see that, for example, here in out of office, in office hours, that the door-to-needle time can be actually reduced from 55 minutes here to 25 minutes in actually only 4 months. And we know, of course, that even nowadays, in times of the extended time windows and thrombectomies and all the new options available, it's true that time is brain. And of course, if you ask me, I think that there is certain door-to-needle time that maybe cannot be reduced anymore, because then we are maybe dealing with the safety of the TPA and possible mimics. So there is, of course, some limit beyond which we cannot go, but we have achieved roughly 17-18 minutes of door-to-needle time, and it's pretty much stable for the years. Thank you.
Thank you, Daniel, for explaining what you're doing and how you're doing the great job by reducing the door-to-needle time. The questions from the audience is, one audience, Zoe Taylor, suggested that, have you looked at the costing in regards to wastage of TPA not used when it has been pre-mixed prior to patient arrival?
Excellent questions, but I really try to stress that this is really not done so often. So my answer would be that we have not been looking at the cost, but I know that it's minimal because we really do not do it so often.
Good. And other thing from the Zoe Taylor again. So within your team that meets the patient at the door, this includes stroke nurse, physician, and a lab technician.
Correct. A lab technician would be radiology or the Röntgen technician, yes. Actually, it's 4 people. It would be stroke physician, stroke nurse, laboratory nurse, and a radiology nurse.
And the stroke physician is resident on site out of hours also?
Good question again. Out of hours, it's not all the time. It's a little bit changing. Majority of the team are experienced stroke doctors, but there are some juniors as well.
Okay. No, it is excellent. And again, from the patient which are unstable, high blood pressure, controlling the blood pressure sometimes delays the door-to-needle time. How do you achieve reduced time so that you can reduce the blood pressure before you can give thrombolysis? What agent you normally use?
Yeah, that's of course a very good question, and it's what we use is labetalol. It's our first choice, and if I need to mention two other drugs, so we use enalapril and then catapressan, but the first drug of choice is labetalol or albetol. This is what we start with, and I am pretty much sure that this is done in other cities or centers as well. That we really, if you are not able to reduce the blood pressure, pretty much, you cannot like go with 20 different boluses or so on. So if you see that it's really like constantly over 200, so then it's really not safe to give the thrombolysis.
Okay, that's great. And patient who needs thrombectomy, you do CT angiogram at the same time.
Yes, and here is how we do it. So now, of course, we understand that there are like nowadays a lot of changing time windows, but basically what we would do, we would run non-contrast CT scan. We make a decision for doing the thrombolysis. After the bolus, we would make a CTA and perfusion if needed. So in a way, we save there some time. So we do it after the bolus.
Excellent. Other thing, question being asked by one of the stroke physician is, how many stroke nurses do you have in your department?
Well, I can answer you this question by email, but I'm really sorry. This would be a question for our chief nurse. I really don't know. I'm sorry.
That's obviously there are no gaps. That simple as that. So and other question from one of the delegates is Michael Keeling is, how long do you spend in a CT scanner? The patient 5-10 minutes. How much?
Yeah, if it's really just a non-contrast CT scan, so it's really the initial. Maybe the question is more like the initial evaluation of the patient prior the CT is done. So then this is really something like 4 to 5 minutes. Yeah.
Yeah. And you do NIHSS score after the CT, post CT?
No. Just after the patient arrives to the CT room.
Okay, just okay.
Prior to CT, yes.
Fair.
And a lot of things is going on at the same time. So of course the nurse asks question, the doctor is asking the questions, making the examination, NIH, and the other nurse is drawing the blood, and maybe the radiological nurse is asking some questions again. So a lot of things is going on at the same time.
That is excellent, Daniel, what you are achieving, and I'm sure would love to do it, what you're doing there. I don't know, somehow we are not able to achieve it. Some of our blockages are patient coming and we're registering the patient onto the computer system, taking blood, sending somewhere, and then CT scan. Sometimes there's no spare CT scan, so patient sometimes wait for 5-10 minutes before going to CT scan. So most of the time we can, on an average, we do it in 30 to 40 minutes. But we are not able to achieve below 20 in most of the time. So it would be love to see, but your patients are going straight to scanner or not, or you are assessing them first? No,
directly from ambulance, from the entrance of the door, directly to scanner.
Yeah, so that's what we are going to implement in our center also. So I think that would be a way forward. But how many times you see mimics when you get the call?
Yeah, this is an excellent question, because the first we would need to that some centers consider even TIA a stroke mimic. So I don't know if you have seen some publication from Hannover or so on and elsewhere. So when in our own publications, what we have seen, it was reported below 5%. I know it's really low. It can be questioned and so on, but we really we checked the system like 3 times, and we found only less than 5% of the mimics. But to tell the truth, of course, there can be cases that once the decision to make the thrombolysis was done, maybe the diagnosis is not questioned so often when the patient is already admitted to the neurological ward. So it might be it is more than 5, but definitely it's in some centers it was reported to be 15-18%. So I would say that the truth is maybe 6%, something like this.
So 6% are mimic which your department is seeing.
Yeah, what we have officially reported was even less.
Okay.
But as I'm telling you, I feel that it needs to be more. Yeah.
And how many patients which are mimics might be later on, you might have thrombolized because there's a very short period of time to decide it. So have you got any data? The patient who presenting as a stroke, but later on after thrombolysis, you found that they were mimics.
Sorry, the percentages I was just telling you, that is the answer to this question. So this is the 5% or 6%.
Thrombolysis done in 5%, which is not
Yeah.
bad. But what about the other patients which are not thrombolized, but obviously your team is involved in their care?
Yes. Okay. So roughly we can say that we are seeing 1,600 candidates for thrombolysis per year. And out of those, 300 will receive thrombolysis.
Okay, good. Excellent. So thank you, Daniel, for your presentation. I hope once the COVID crisis is over, we'll be able to see or visit your unit also to see how you're doing it, to learn from that. And again, thank you from the audience and delegates and from the organizer for presenting yourself and giving your precious time.
You're more than welcome. Thank you very much.
Yeah, Daniel.
Thank you. Bye-bye.
Okay, so without any waste, next speaker is, you have to bear with me, it's me. Can you see my screen? Lynn, can you help me? You can see it.
I can see your screen, Asim. I can see
Right,
it.
yeah, we can see. Yeah.
Okay, so presentation today for me is whether prolonged heart monitoring is a way forward to prevent recurrent stroke. So people who don't know me, I'm Dr. Ali. I'm a stroke services lead, divisional clinical director of medicine in Northern Lincolnshire and Google NHS Trust. My conflict of interest personal is to improve my own knowledge and share the knowledge. And the external conflict of interest, we got a grant from Medtronics to run the Stroke Masterclass. And whenever we run Stroke Masterclass, we keep it to basic minimum payments for the delegates or free. And also my conflict of interest is working in collaboration with Rawalpindi Medical University, which is alumni working in UK. And today Zoom is being provided by RMU alumni, and I'm president of our RMU alumni UK. So where are we based now? Just people who don't know, Grimsby or Diana Princess of Wales Hospital, we are on the north part of the England on the eastern coast. We have got two hospitals, Diana Princess of Wales Hospital and Scunthorpe General Hospital, which are 27 miles apart. And our stroke unit is in Scunthorpe General Hospital, which is hyperacute stroke unit. And Diana Princess of Wales Hospital has got a subacute stroke unit. So this is Grimsby, Cleethorpes Beach, and Grimsby is famous for its fish and chips. So people who would like to fish and chips, they should visit Grimsby. And we have got a wildlife. The seals are coming here in November time. So please do visit if you are interested in the wildlife. And again, because of the COVID, we are working together, and the COVID distancing is being followed by our seagulls also on the Cleethorpes Beach. You can see nice seagulls which are distance apart, keeping the distance. So now coming to the talk, my objectives are today to look into it, what are the types of the strokes so that we can see who would be the appropriate patient for prolonged monitoring. Recurrence of the strokes in different types of the strokes. And we'll talk about cryptogenic stroke and embolic stroke of unknown source. And then we'll talk about embolic stroke management and selection of patients for prolonged monitoring. The classification of a stroke is old, which is developed in 1993 according to the TOAST criteria. Either we have got a large artery atherosclerosis, cardioembolism, small vessel occlusion, or stroke of other determined etiology like vasculopathies, hypercoagulable states, hematological disorders, and number 5 is stroke of undetermined etiology, or what we call it cryptogenic stroke. This study is very important, which has been published last year in July 2020, Risk and Secondary Prevention of Stroke Recurrence. It is a population-based cohort study, which is done in population in South London from 1995 to 2018. They looked at the patients who been diagnosed to have a stroke and then analyzed the data. What was the outcome of those different stroke patients according to the type of the stroke? The rate of stroke recurrence at 5 years from 1995 to 99 is 18%. In 1995, stroke units start developing and there were more stroke awareness coming roughly at that time. So recurrence rate was 18%. From 2000 to 2005, the recurrence rate has been reduced to 12%. But there's no significant further improvement since then. Look like we are doing appropriate secondary prevention of our ischemic strokes, and the area which is not well looked after is atrial fibrillation, because if you see the 54% increased risk of recurrence was observed among those who had atrial fibrillation. The recurrence-free survival improved from 1995 to 2015. And from 1995, you can see it was 35%. And then it's a recurrence-free survival period improved from 2010 to 2015 to 67%. Then in this study, a cohort population study, they looked at the recurrence and the recurrence or death. If you look at the highlighted area, cardioembolism stroke, according to TOAST classification, their recurrence rate was nearly 16%, and recurrence or death is 75%. So these are the patients in which there is more recurrence and more deaths because of the pathology. If you see in the small vessel occlusion, the recurrence or death is 51%, and ischemic stroke of other causes, the death or recurrence in 10 years' time was 45%. Ischemic stroke of undetermined etiology also recurrence is 17%, which is more or less similar to cardioembolic stroke. But the mortality and recurrence is slightly better as compared to the cardioembolic strokes. It is 66.5%. There's nothing major change, obviously, from the point of view of intracranial hemorrhage. So I'm not going to discuss about the intracranial hemorrhage in this presentation. Again, then in the sub-analysis of the study from 2000 to 2018, if you looked at the cardioembolism strokes, which was diagnosed, the recurrence was 55%, again cardioembolic. So it can tell that might be recurrence is more here. Either we are not putting people appropriately on anticoagulation who has been diagnosed to have a embolic source. Are we treating our atrial fibrillation in a better way? This is a question arise here, that are we treating our atrial fibrillation or paroxysmal atrial fibrillation in a better way or not? And then the ischemic stroke of undetermined etiology, the recurrence is a variable, but in 36% of cases, still we don't know the source of the stroke, or they are still cryptogenic, but 14% of them were embolic stroke. So what is cryptogenic stroke? So cryptogenic stroke is ischemic stroke of undetermined etiology. And if you see, it is compromising 20 to 30% of ischemic stroke. And what is cryptogenic stroke? When we should be saying cryptogenic stroke, it is quite vague from that point of view also, the classification of cryptogenic stroke, because if I'm not investigating my patient appropriately, mean incomplete investigations, then obviously I would be thinking that this patient has got a cryptogenic stroke. Or if all the investigations coming back are negative, it is a cryptogenic stroke. Or if we have got a more than one reason of a stroke, then we'll be thinking it is a cryptogenic stroke, because we don't know the source of the stroke. Patient might have atherosclerotic disease, cardioembolic disease, and paroxysmal atrial fibrillation, but we are not able to say what has caused the stroke. The pie chart showing the percentage of cryptogenic stroke. But in 2014, the things people thought about cryptogenic stroke to look into it more detailed. So once the embolic stroke of unknown source was found, then we call it ESUS. And most of the cryptogenic strokes show clinical and radiographic appearance of embolic-like stroke, but it is of unknown source. So how we say these are embolic stroke of unknown source? First of all, they should be non-lacunar. And obviously, if we are doing imaging and like a CT angio or MR angio, it should be, the stenosis should be less than 50%. And there's no major risk of cardioembolic source identified on investigations. And there's no other specific cause of the stroke found. ESUS prevalence and a patient feature in a global registry. A registry was developed in 2016 after the ESUS classification. They found ESUS patient formed about 17% of the ischemic stroke. They are relatively young, below 65. They have got a minor stroke with an NIHSS score most of the time below 5, and the cardioembolic distribution on imaging. And mortality is less as compared to cardioembolic, but recurrence is more as compared to non-embolic stroke, but annual recurrence is 4.5% per year. How we say patient has ESUS, what sort of investigation we need to do? First of all, we need to make sure that it is not lacunar. Whether it is lacunar or not lacunar, we need to do imaging like MRI scan or CT scan. Then obviously we do ECG to make sure patient is not suffering from atrial fibrillation. Echo to make sure patient has got no LV thrombus, atrial myxoma, or ejection fraction is good. Arterial imaging to be done to make sure there is no dissection. And differential diagnosis also think about once you're diagnosing stroke, whether they have got a migraine or dissection or vasculitis. So that has to be excluded once we think ESUS is under question. So these sort of investigations are done before we say it is ESUS. What is the role of anticoagulation in ESUS? Because it is, we are thinking it is an embolic stroke. So the two studies were done, whether anticoagulation is better than antiplatelets. So I'm saying two trials, because these were the major trials to compare, but these two were negative trials, and these trials was phase 3 trials of anticoagulants in ESUS. So one was Navigate ESUS in 2018, in which rivaroxaban was compared with aspirin, but the study has not shown that it reduced the number of stroke. Rather, it can increase the number of intracranial bleed. So the study was stopped. There was another study which is called Respect ESUS, in which dabigatran was compared at a dose of 110 and 150 milligram with aspirin, and the outcome was not favorable to anticoagulants. So we are not able to prevent strokes with the Navigate ESUS and Respect, both with dabigatran and rivaroxaban. The number of hemorrhagic event increase with these interventions. So again, so ESUS, we don't know how to treat these sort of patients. Is it antiplatelet is the treatment of choice? But at the same time, in the ESUS studies, we have found 30% will have atrial fibrillation. So it is really important to find out there should be a structured approach to investigate ESUS, because we can't blindly put them on anticoagulation. Otherwise, it would be easier just to put them on anticoagulation. But studies were against that. So it is really important to look into it. Why ESUS patient has got an embolic stroke? but there are different etiologies or different classification which can lead to embolic stroke of unknown source. One is cardioembolic, which theoretically, I will say it is better to put them on anticoagulation, like patient with atrial fibrillation, atrial cardiopathy, or silent myocardial infarction, or any valvular heart disease. And then the paradoxical embolism, we need to find out patient is not suffering from PFO, ASD, atrial septal defect, or pulmonary arteriovenous fistula. But at the same time, patient can throw emboli from large artery, and obviously these people would be more responsive to antiplatelets. And then there are patients who have got a hypercoagulable disorder like vasculitis. They might respond better to antiplatelets then. Then characteristic of recurrent ischemic stroke after embolic stroke of undetermined source looked into further in Navigate ESA study. Once they looked into the recurrence of a stroke in those patients, they found that 156 were ESUS and 114 were non-ESUS. Obviously, the one which are non-ESUS mean they found the reason for a stroke. Out of them, 32% were cardioembolic. So atrial fibrillation was found in 27 patients with approximately 9%. So obviously, if we treat them better, the outcome would be different. And all of us, we know that atrial fibrillation can cause a massive stroke, which can increase the morbidity and mortality. And recurrence, obviously in ESUS, if you take it as a general, ESUS recurrence didn't differ significantly by subtype between the treatment groups. Atrial fibrillation is the most commonest cause of cardioembolic ischemic stroke. So paroxysmal atrial fibrillation is really important to look into it in either whether patient has got ESUS or non-ESUS. So unrecognized AF may be present in cryptogenic stroke. Asymptomatic AF is detected by prolonged monitoring, and 23% of cryptogenic stroke, if we do a monitoring to look for paroxysmal atrial fibrillation, we find out they would have a AF. But again, there are no studies done in which asymptomatic paroxysmal atrial fibrillation, we are not looked into it, whether it is more in patient with cryptogenic stroke, or is it more in patient in a high risk group, like people who are suffering from hypertension, diabetes, or other risk factors. Our center has done a survey of our practice in which we have said effective detection of paroxysmal atrial fibrillation in cerebral ischemia using prolonged ambulatory ECG monitoring. We have presented it in 2013 in European Stroke Conference. We found if we do prolonged monitoring for up to 21 days, the pickup of atrial fibrillation is approximately 25%. But we have not done research, it was a survey. So obviously that doesn't count much from the point of view of implication of the survey. And we can't implement that it is true for everybody. But again, there was another study, which is Embrace study, looked into external loop recorder, and they have found that 13% absolute difference in the detection between 30-day group and the repeat Holter group. And so it means if we look hard for stroke and paroxysmal atrial fibrillation by doing a prolonged monitoring, we can find out more cases and we can put people appropriately on anticoagulation and can prevent stroke. Then there was a Crystal AF study. Crystal AF study has done insertable cardiac monitor was inserted, which is a Reveal XT cumulative devices were looked into it to see. And they found that the number of pickup for atrial fibrillation increase as the time passing. These are implantable or insertable cardiac monitor, in which they have seen that in 36 months, if you can look at it, that in 6 months time, they have seen 19 paroxysmal atrial fibrillation as compared to normal or regular follow-ups. So as these implantable or insertable cardiac monitor can be inserted for up to 36 months, and the pickup rate was more as compared to the conventional follow-up. Again, the number of strokes were less in those group in which we have found atrial fibrillation because they were put on appropriately on anticoagulation. But it was not highly significant, but definitely it reduced the number of the strokes. So there are devices which we can utilize to look into for atrial fibrillation or paroxysmal atrial fibrillation, because we know the paroxysmal atrial fibrillation is asymptomatic. And if you look at 12-lead ECG, the yield is only 1 to 5%, Holter monitoring 2 to 4%, ambulatory telemetry, which is up to 30 days, can be up to 25%, external loop recorder similarly 5 to 20%, and implantable loop recorder are 20 to 36%. But there are advantages and disadvantages. Obviously, implantable loop recorder would be expensive, and obviously it is some sort of invasive procedure. And then the external loop recorder, obviously we need to have a appropriate number of loop recorders so we can appropriately monitor our patients. But at the moment, Royal College of Physicians guidelines and NICE guideline in stroke in UK suggesting prolonged monitoring, but it is not identifying, is it for everybody? Is it for cryptogenic only? So these more studies need to be done from that point of view. But implantable cardiac monitors to detect atrial fibrillation is approved by NICE guidelines on 2nd of September 2020. That if we are suspecting strongly that patient has got a paroxysmal atrial fibrillation, then we can insert cardiac monitor, which are invasive. So this slide is really important from my talk today. The reason of importance is here because if you look at it, all the stroke or TIE patients should have a normal, first of all, blood test to look into blood sugars and lipid profile and coagulation profile. And they should have a CT brain or MRI brain. And then obviously we need to look into it. It is not a dissection or any significant stenosis, either by doing carotid Doppler or by doing MR angio or CT angio. But when you're doing MRA or CTA, make sure that you are including arch of aorta so that you can make sure that there is no significant atheroma in the root of aorta, which might be throwing emboli and causing a stroke. Continuous heart monitoring is done in a hyperacute stroke unit in UK for 72 hours. But most of the time patient might be staying in the unit for up to 24 hours or sometime less. Transthoracic echo, we recommend it in a young strokes below 50 years of age, not everybody, but obviously if you're suspecting embolic stroke, we should be doing echo, and young stroke investigation in age below 55. If we are doing these sort of investigations, then obviously we are able to find out the cause. Either they have got a large vessel occlusion, or they are lacunar infarct by showing deep white matter changes on the MRI scan or CT scan, or cardioembolic stroke in 20% by picking up atrial fibrillation or any other source of emboli, or other unidentified pathologies. It can be dissections in the young age group. But then we are saying if we have done these investigations, we are not able to find out the cause for the stroke. Either these are cryptogenic stroke, in which we don't know the reason, or we call it ESUS, they are embolic source of unknown origin. In that sort of group, we need to do further investigation by doing a transesophageal echo. Transesophageal echo would be looked into to make sure that we should do might be for PFO, a bubble study to look for PFO, and we can make sure that the young stroke screening is being done appropriately. And our approach is that to do heart monitoring for 2 to 4 weeks with the help of, in our trust, we are using a spider flash, which we do a monitoring for 2 to 4 weeks time. And the total, but obviously it is not done timely. It is variable approach. We have got no strict criteria for that, but we are planning to develop a criteria now. When we diagnose ESUS according to the classification, if it is a non-lacunar infarct, if there is no major atheroma in the arteries, and we are not able to identify any other reason for stroke, to monitor them for 2 to 4 weeks, and then because the pickup rate is around about 20% in those groups. So we can pick it up. After that 2 to 4 weeks time, if you are not able to pick up the stroke, then we are planning to develop pathways where we can do internal cardiac monitor, and where we can monitor for 1 year and look for the cause. And the rarely, obviously, in ESUS, we have to look into it whether there's any genetic testing needed, or consider any paraneoplastic or cancer-related workup to make sure we are not missing any other diagnosis. This would be a tool. If I take home message from my point of view would be to have these investigation done before declaring this patient is suffering from cryptogenic stroke. So monitoring guidance to detect paroxysmal atrial fibrillation, obviously patient coming to TIA clinic or stroke ECG, heart monitoring in hyperacute stroke unit, Holter monitoring for 24 to 48 hours of no use. I think is better not to do it because the yield is very poor, and better to use external loop recorder for 2 to 4 weeks, and then to consider implantable loop recorder after multidisciplinary approach. Why I'm saying MDT approach? Because obviously it is not a cheap option. It does cost money from that point of view, and making sure we are selecting the right patient. So that we can start appropriate treatment if we find out patient suffering from atrial fibrillation. So summarizing my talk now, so we discussed about different types of strokes. What's the recurrence in different types of stroke according to the TOAST classification. We talked about cryptogenic stroke, and we talked about ESUS. It is important to diagnose ESUS and to further investigate, and then to consider prolonged monitoring in patient in which we are thinking they are embolized. So, and thank you very much. And I'm open to the questions. I've not looked at my question at the moment, but if anybody has got a question, please, I'm going to read it and see if there's any particular question. So just bear with me. So question is done by Dr. Koch. Do you do prolonged cardiac monitoring in cases with stenotic culprit artery, which could be embolic from AF? Yes, very good question. I will say if it is a large vessel occlusion and there is no atheroma in any other arteries, it is important to do prolonged monitoring in that sort of situation, because the bigger clot from the heart might have blocked that large vessel. So it is important to do a prolonged cardiac monitoring where you are not able to see atherosclerotic disease in other blood vessels. So yes, it is important, Dr. Koch. And Dr. Abdul Gabar has asked, do these investigations also apply to patients who only show ischemic changes on image without clinical stroke? I will not recommend the changes to do a prolonged monitoring on everybody, because if you do an MRI scan, anybody above the age of 60, you might be able to see a lot of small vessel changes. Until there is a history of a TIAs or stroke, I will not say that routinely on an MRI scan, if you see ischemic changes, to look hard for paroxysmal atrial fibrillation. And okay, there's a Dr. Khan has said that if we ask for prolonged monitoring, the cardio department gives you a very tough time. What would you suggest from that point of view? So yes, obviously you have to convince it. Your consultant need to speak to the cardiology department. Yes, I'm against 24-hour and 48-hour Holter. Many of the trusts are doing 24-hour or 48 hours of Holter monitoring. From that side, I will say it is waste of time, because first of all, there's a waiting time, and then there's a technician time, and the yield is only 3%. So it's better to do a prolonged monitoring if you're really looking hard for atrial fibrillation. The reason I'm saying in HASU, you're monitoring it anyhow for roughly for 24 to 48 hours. If you're lucky, if the bed is there and you are monitoring up to 72 hours, if you're not able to pick it up there, unlikely you will pick it up within 24 or 48 hours Holter monitoring. So So best would be to external loop recorder would be important if you're suspecting patient has got a paroxysmal atrial fibrillation or patient has got an embolic stroke on imaging. So I hope I'm keeping with the time. Yes, and that is fine. So without any delay, the main thing is in this session or theme is to look into it embolic stroke. And this will take nicely to me to invite my next speaker, Dr. Khalid Javaid, who is a stroke physician in Royal Wolverhampton Hospital. And I've invited him to talk about PFO because this would be another etiology which would be thinking hard, we should be considering hard, or we should be investigating hard in each such patient. And Dr. Javed is going to talk us what's the role of PFO and a stroke and evidence into practice. Khalid, up to you.
Good afternoon. Asim, can you hear me?
Yeah, we can hear you, Khalid.
And you can see me as well, hopefully.
Yeah.
Okay, let me just get the technology right. Okay. Right. Okay. So I'm Dr. Khalid Javaid. I'm working as a stroke consultant in New Cross Hospital, as Ali has said, who is a good friend of mine. Just put up the finished. We would have admitted at least 96 stroke. So it is quite a big problem. And the problem is that 25% of the stroke happen in the people of working age. And that's what we are here to talk about. And the average age of stroke has decreased recently. So this is important to note that at least 1/4 of the people who had a stroke, they are of working age group, which obviously affect their well-being and their bread and butter. And also the average age has reduced. Presumably, probably we have started to work better on our conventional risk factors. It remains the biggest killer in the UK and across the world. And every 13 minutes in the UK, somebody is dying of the stroke, which amounts at least 30 people would have died by the time you have finished this seminar. Coming back to the talk, the PFO, I think everybody knows that it is a component of fetal circulation, closes in 70% of the time, but fails to close in 30% of the occasion. And it should therefore be considered as a normal variant and not somebody could be classifying that it is a congenital heart defect. The importance in our specialty is that it is associated with the stroke, what we called as a cryptogenic stroke, and Asim have very nicely already defined and what the cryptogenic stroke is. If you start doing an echo on people, especially transthoracic echo with bubble, or if you are doing a TOE, you will find foramen ovale, which is the normal variant rather than a defect. In at least 1/4 of the people you will do the echo on. One of the common mistake people do is that they think that this is a defect, and hence the reason that it is separate from the atrial septal defect. And the atrial septal defect is the hole in the septum primum, which probably is on the right side of your screen, while foramen ovale, which we are discussing today, is the defect in the septum secundum. So this is important to note. And hence the shunt which happens in atrial septal defect, it is a continuous one. There is always a shunt happening from the left to the right, while in foramen ovale, the shunt only happens from right to the left when the pressure increases in the right atrium. For example, somebody is sniffing, coughing, or having some sort of a Valsalva maneuver. And hence it is important that you take a good history, especially in those young patients who had a stroke. They may have some sort of an exertion just before the stroke has happened, and that may be able to help you to investigate these patients. The frequency, obviously, patent foramen ovale is quite common, at least in 1/4 of the population, while atrial septal defect is less common. One of the other anatomical variation which we need to understand with atrial patent foramen ovale is the atrial septal aneurysm. And I think this is also very important to note on the echo, that it should be 15 millimeter of total septal tissue, not one just couple of millimeters of septal tissue, or during the beat, it has to go 10 millimeter into either atrium. If that is the case, then it will be called as atrial septal aneurysm, while in the other cases, it can be defined as a hypermobile atrial septal rather than atrial septal aneurysm. If you got both PFO and ASA, then you probably can see that this patient may be having underlying PFO, which may have caused this stroke. Very important. Historically, this has been diagnosed at least 250 years ago, when this German pathologist did an autopsy on a young woman who died of the stroke and found foramen ovale, which obviously he has written that he could pass 3 fingers with ease, which means it was quite a big patent foramen ovale, which may have been the causative factor to cause this stroke. And remember, this was described almost 250 years ago. How big the problem is? Obviously, PFO itself on its own is not a big problem, but when it is combined with the stroke, you can say that it probably is a problem. If we take it that there are 100,000 stroke in UK, then 80% would be the one who are in more than 60 years old, and that 1/5 of them would be in the less than 60 years old. Out of those 20%, we may be able to find a cause in 70% of the cause, and the rest remains as what we described as cryptogenic stroke, out of which 50% will have a PFO and 50% will not have a PFO. But that does not mean that the PFO in these cases would be the causative or underlying etiological factor. This is just the presence of PFO. So if we take all hospitals in the UK who are accepting type 1 A&E admission, there will be 16 cases per hospital per year. That is just the mere presence of PFO. It does not mean that they are the stroke due to the PFO. So problem is not that of a big of a problem, but certainly is a problem. I do not think that I need to go into the detail to define what the cryptogenic stroke is. Asim has already done the hard work of it. So I think I just skip that. It is very important to diagnose the PFO. How do you diagnose it? Obviously, transthoracic echo with bubble contrast and transcranial Doppler can also be used as a, I'm not sure how many people would be using transcranial Doppler. Still, it is not one of the very common investigations, which is done in the UK, but it shows great sensitivity, but lower specificity versus transthoracic echo for the detection of PFO. However, remains gold standard is the transesophageal echo rather than transthoracic echo with bubble contrast. But transthoracic echo with bubble contrast is quite useful because I think it is quite easily available. The advantage of transcranial Doppler is that it increases patient comfort and it can give you a semi-quantitative assessment of the shunt size, which is also very important in delineating those people in which we are going to refer them for the closure of the PFO. Bubble study, as you know, is usually done at rest, but it is important that it should also be assessed during the phases of Valsalva maneuver. What is important for us is the timing of the bubble, because it can then tell us the difference between whether the bubble which appears in the atrium is due to the intracardiac shunting or pulmonary shunting. There is no such agreed classification of right to left shunting, but I think the important thing is it is very mild or grade 1 if it's less than 5 bubble across from the right atrium into the left atrium. Anything between 5 to 25 would be graded as grade 2, grade 3 and 4 would be obviously more bubble, and grade 4 would be the biggest, in which whole of the opacification of entire chamber means the left atrium is opacified with these bubbles. Transcranial Doppler, again, you put agitated line in there, and you are doing quantification of the left, from the right to left shunt, and it is considered to be positive if it is only one bubble appears in your atrium. It is negative if there is absolutely no micro bubble. If there are 1 to 10, you call it as a low grade, and if it is more than 10 micro bubbles, then medium, and obviously if there is a curtain effect, which is on the bottom screen on your left side, will be called as a severe or a high grade shunt. The meta-analysis showed that TOA bubble study had a sensitivity of 89% with the specificity of 91%, while transcranial Doppler either is more sensitive but is less specific. The other important thing for the PFO and the cause of stroke is you need to know the characteristics of the patent foramen Werring. As mere presence, as I said earlier, does not mean that that is the causative factor. The size of the PFO is important, although that may not tell you all of the story. Together with the PFO, increased septal mobility is also very important to note. So PFO size is considered to be small if it is less than 2 millimeter, medium between 2 and 4, and if it is more than 4, then it is considered to be a large PFO. There are many observational studies, and all of them has given a little bit more confusion rather than the clarity about the PFO. Someone has looked at the presence of PFO. Someone may have not even characterized the characteristic feature of PFO, but in the largest study of PFO size, they think the size is important, but what also was important is the secondary features of the PFO, which would be the presence of eustachian valve or carry network, which is obviously the remnant of your valves of the sinus venosus of the fetal life. So PFO characteristic, the important thing to note is the presence of eustachian valve and the carry network, or PFO being presenting as a longest tunnel. They are much more associated with the stroke than just the mere presence of PFO. The devices which has been used historically, on the right on your top is the Kids Mill cardiac umbrella size, which was used back in 1975, although it was not used, I take it, for stroke. But then since then, people have developed, have more and more devices. And currently the one which two are is the cardioform septal occluder, which is this one. And then is the Amplatzer PFO occluder, which is the steel mesh network. Both are connected in the middle by a thin spine, and the radiographic appearances appear on the top and bottom of the screen. So these are the two devices which are currently being used for the PFO closure. Now, so far, up till now, we could divide the closure of the PFO, the trials of the closure of the PFO, in broadly in two things. One era is between up to 2014, 2015, which consists of closure 1, PC, and RESPECT trial. And then another period starts from 2017 to 2018, in which there are another 3 studies were done, which led to the change of guidelines to an extent that we now refer patient for the PFO closure. RESPECT extent was the mere data collection of the RESPECT trial, which was done in 2013. So in fact, there was only 6 studies which are up to date now have been done on the PFO closure. So the first trial was the closure 1, which was actually started in 2008 and concluded in 2012. And the device that was used was the Starflex septal occluder device. And the preliminary and the primary endpoint, actually important to note, in the first 3 studies, the primary endpoint was the TIA as well as the stroke, while in the next 3 studies, which were carried out from 2014 to 2017, the TIA was not considered to be the endpoint, and that may have led to the difference how the endpoint was reached. On this study, it was concluded that there is no statistical significance between the two groups who were randomized to the closure and to the best medical treatment. And in fact, they thought that there may be a 6% cases AF was detected, and this actually caused a little bit of an alarm for the trials which were carried from then on. The second trial was the PC trial, which included 414 patients. Again, the primary endpoint was achieved: 7 patients in the closure group, 11 patients in the medical group. And again, it was quite non-significant, rather negative trials. So impact of these two trials was so negative that people stopped doing any other trial on these, thinking that the best medical and the closure does not make any difference, and hence put the people off having more trial. Same happens with the RESPECT trial, although it recruited 980 patients, followed them up for 2.6 years. And again, what they actually found that the rate of AF was not very significant increase, which probably was a little bit promising, but it still did not reach to the statistical significance, and it also failed to convince the people that they need to change any treatment guidelines or to change their clinical practice. So after a gap of 4 years, another trial came in, closed trial, which recruited 663 patients and followed up for 5 years, which probably was the longest of the trial which have been done so far. They used both of these devices, and the criteria they used was just not the presence of PFO, but the high risk PFO. For example, if it is a large one, if it is an atrial septal aneurysm, or somebody who may have a PFO with the eustachian tube, they were included in these trials. And the results were actually quite remarkable, that there was a significant decrease in the recurrent event. In fact, it was 0% versus the antiplatelet group, which was a 6% event rate. And this was the first trial in 2017, which showed that there is some merit in closing the PFO. Number needed to treat was counted to be 20 patients. And in the medically treated group, there was no significant difference in the recurrent stroke, whether you treat them with antiplatelet or anticoagulant therapy. So the device group came out on the top with nil, with 0% endpoint. Then there was a reduced, which uses the different device, which was the cardioform septal occluder. It was quite a sizable study, and they followed it up for 3.2 years. Again, there was a significant decrease in the PFO closure group versus the medical, and the p-value was quite significant. And the number needed to treat over 2 years was 28 patients. The third and the final trial, which was in the modern era, was carried out. And this was, again, it uses the Amplifier PFO occluder. And this was done in Korea. This recruited about 120 patients and followed for 2.8 years. And this was of so, and once again, they recruited those patients who have an atrial septal aneurysm, hypermobile septum, or big PFO size, which appears to be the factor which may have effect on the outcome. Once again, the decrease in the recurrent ischemic stroke was 0% versus medical therapy, and number needed to treat was 10 patients. So the impact of this trial was so much that it was stopped prematurely, and people have started to thinking that we should be closing the PFO. Once all these trials came in, FDA went back to the people who did a RESPECT trial, and they said, you now need to get your data for more than 5 years. So 980 patients, which were initially recruited in the RESPECT trial, they followed it up for 5.9 years. And once they followed up in 5.9 years, and the subgroup analysis in which they separated the PFO with the PFO having atrial septal aneurysm. They found the difference was quite marked. And number needed to treat, they calculated was 42 patients. So the results of the RESPECT extend, which was a data collection for 5 years from the RESPECT, and all these 3 new trials of close, reduce, and defense PFO shown the superiority for the PFO closure as opposed to the best medical treatment. And then they came up with the idea that we should not be calling them as a cryptogenic stroke, which was the term used before this trial. And in fact, we should be reclassifying them as a PFO-mediated stroke. So this is the slide. I think people may find it difficult to understand, which is, I think there are quite a bit of data in it. So I tried to simplify it to this and then to this. So RESPECT trial, which was done, all these trials which were concluded in 2017 and 18, and you could see the number needed to treat fell sharply. The reason for that is the selection of the patient. The device group and the risk of stroke was quite marked between the 2 arms, which led to the conclusion that there is a merit of closing the PFO in a carefully selected population of young stroke patient. Again, the meta-analysis of cryptogenic stroke randomized trial versus the medical therapy, and it favors the PFO closure almost double of them than if we are going to treat them with the medical therapy alone. In the trials, however, there was no significant difference in the adverse event between the PFO closure and the medical therapy. So that was up to the trial. So PFO-mediated paradoxical embolus stroke, if you are thinking that what may be the, you need to look at the cortical location of the infarcts, may have a stroke in multiple vascular territories, or you may find the infarct of different ages, but in the same vascular territory, or you may have excluded all the causes, which I think Asim has already identified in his talk, or there is indirect evidence of stroke and there is absence of conventional risk factors. Remember, lacunar infarcts are not generally associated with embolic events. So once we decide that this is a cryptogenic or PFO-mediated stroke, how we are going to categorize it? A practical assessment tool is to determine the probability whether the patient which is under your care, that PFO may be responsible for the cryptogenic stroke. You may have to do some sort of objective evidence, and the objective evidence came in the form of ROPE score, which is the risk of paradoxical embolus. And you could see that the conventional risk, absence of conventional risk factor will give you 1 point each. And the age, as you grow older and older, the points which you give reduced by, and in fact, if you look at the 50 to 59 group, which is the group we usually think is a cryptogenic group, or less than that, you have got more point if your patient is younger. So the risk, the risk of PFO attributable stroke is that if your ROPE score is high, for example, if it is 7, 8, or 9, the risk of that PFO causing that stroke successively increasing as your ROPE score increases. So for example, if your score is 7, the risk of stroke caused by that PFO is 72%. And as your score go higher, the probability of PFO-mediated stroke goes higher. This is again just a slide to tell you that you needed to exclude all these, and point to note from Asim's slide is the paroxysmal atrial fibrillation. It is best to do the Holter monitoring at least 4 weeks, because the yield for the 4 weeks is much greater than the yield which you get it with intermittent Holter monitoring for 3 days or 5 days. One important point to note all these when people were get excited about this randomized trial was, but nobody looked at it, that what is the outcome evaluation and benefits, which was the procedural risk. Because obviously, if you are going to close the PFO, there is always a per post and per procedural risk or post procedural risk. So once these have been taken into account, both the observational studies and the randomized control agreed that there is a very low risk of recurrent stroke under the medical treatment, 1%. And what is even more important, that the stroke which is associated with the PFO are usually very non-disabling. The stroke which are associated with PFO are usually very non-disabling, and minor stroke, they usually are not very disabling stroke. But it does not mean a disabling stroke will not happen. Disabling stroke due to the PFO are relatively unknown. When we compare this data from the real world, we found that the adverse outcome was 7% rather than 1 or 2% in the randomized control trial. The reason for that is probably in randomized control trial, the population is carefully selected. Probably most of the people who are doing the procedure are the most experienced one. But in the real world data, we found that the adverse outcome was 7% as opposed to the 1%. And hence, the Society of this Cardiovascular Angiographic Intervention proposed that the procedure should only be performed by an experienced physician's cardiologist who may have a very much experience in closing these septums. And the conclusion, the take-home message is that the PFO represent a potential source of cerebral embolism only in a subgroup of cryptogenic stroke patients. Mere presence is insufficient to prove the causality. Mere presence does not mean anything. It does not mean that this is the PFO which may have caused the stroke. We needed to investigate the PFO itself to see whether that PFO is the underlying risk factor for that particular stroke. And PFO is commonly identified in cryptogenic stroke patients, so it is very crucial to select the patient which will gain the most benefit from the intervention, as mere presence. And if we start referring all these people who have got the PFO, but that it is difficult to implicate that that may be responsible for the stroke, and we refer these patients for the closure, you will see that the patient have started coming back with the recurrent stroke because that PFO may not be the underlying risk factor for that stroke. But together with the MDT approach and the high rope score with the echocardiographic findings of, for example, the presence of eustachian valve or cardiac network or long tunnel or big defect are the one, along with the high risk stroke, along with MDT approach, will give you some idea that which are the patients who needed to be sent for the closure of the PFO. After all these randomized control trials, all guidelines turn out that we needed to close the PFO, but only in the eligible patients. And the first step to do is to have some sort of an algorithm to establish that there is a high possibility that this cryptogenic stroke is caused by the PFO. There is a recent publication, I think in BMJ in 2018-2019, regarding that who will be the people who should be referred for the PFO, or people who may have a PFO and a stroke. So the patient who are open to all options mean antiplatelet, anticoagulation, and closure of PFO. This is the expert panel that they made it a weak recommendation for PFO closure plus antiplatelet rather than anticoagulant therapy. One thing, however, was very clear, that in patient in whom anticoagulation is contraindicated or declined, they made it a very strong recommendation of PFO closure plus antiplatelet therapy. And those people in which the closure is contraindicated or patient have declined for the closure of PFO, they made it a weak recommendation that we should be using anticoagulant therapy rather than antiplatelet therapy. But again, that is a weak recommendation. So it means anticoagulant therapy probably slightly more superior than antiplatelet therapy in those people in which the closure is contraindicated. Clinical commissioning policy in NHS England, as the people who are working in UK, they know that all these cases are discussed as case to case by your local cardiology team, and sometimes they are turned down because the local commissioner will not support such decisions of PFO closure, and they still carried on with the best medical treatment. However, recently clinical commissioning policy has changed, and they have come up with, actually quite surprising, they have come up with rather a loose term that the people have to have a stroke with clinical and imaging evidence. Obviously, that can be fulfilled very easily. Modified Rankin scale of 3, and presence of PFO with clinical significant shunt and atrial aneurysm. So it means they are talking about the PFO, which is morphologically much more acceptable to cause the stroke. Absence of significant atrial fibrillation, which warrant anticoagulation. So it has to be, it means we have to do a prolonged monitoring, because as you know, many of the cryptogenic stroke, so-called, may turn out to be secondary to atrial fibrillation. And if we find atrial fibrillation, they needed anticoagulation rather than the closure of the PFO. Again, they advise it has to be an MDT decision, and the patient, they have to be under 60 years. Same goes about the American Academy of Neurology. NICE still have not very much updated their guideline, but they still favor the safety of the PFO to prevent the recurrent cerebral embolic events. But they are also talking about the serious complications which may happen while you are doing the procedure, and they are infrequent. Evidence on its efficacy is adequate now, so this procedure may be used with normal arrangement, provided the clinical governance, consent, and audit. So I just give the final verdict that as of now, instead we continue to argue endlessly about whether we should close the PFO. I think we should continue to discuss that who should we get the PFO clear. Thank you. I'm happy to take any questions.
Thank you, Dr. Javaid. So obviously we are at now 3:15. So there's a break. People can take a cup of tea, but we will carry on with the question and answers session now. But people who want to grab a cup of tea, please do so. And the question, Dr. Javaid, first from me is, if somebody, these studies were done with a medical therapy, closure with medical therapy. Any study with a closure with anticoagulation is being done or not?
No, it's because I think the guidelines, and nobody is using that. If people qualify for anticoagulation, they are being referred for closure. So there is no study that whether anticoagulation is better than closure. No study is done in which there is anticoagulation has been sort of a turnout to be inferior than the closure.
Yeah, thank you. So I've got a question.
Although there are studies which have got 3 arms, one is the PFO closure, one is the anticoagulant, one is the antiplatelet. Anticoagulant turned out to be slightly superior to antiplatelet, provided those people have got some indication for anticoagulation. But they have not turned out, a PFO closure has not turned out to be superior than anticoagulation. Obviously, anticoagulation lifelong itself has got many risks in it.
Thank you, Javaid. Now, question from the audience is Christina. First question. I have 2 questions. Young patient with previous PFO closure admitted with recurrent embolic strokes, had cardiac investigation, showed sinus tachy. Is this enough to diagnose subclinical AF? Do we need to investigate further? Another patient admitted with recurrent stroke, the loop recorder did not pick up AF despite being implanted for 2 years. Thank you. This is the question. So the first question is obviously PFO closure, and then patient has got still has got a stroke, embolic stroke, and the patient has got a tachy, sinus tachy. So is it enough evidence?
So I'll take the first question first. The first question is, I have got a feeling that this patient probably was not worked up very well, as it is very nicely seen on the rope score, that a rope score also needed to be calculated. So the reason for that PFO closure is that may have some sort of underlying pathology which may have led to the recurrence of stroke, which most commonly is the paroxysmal atrial fibrillation. So, and the second part of the question is sinus tachycardia is enough to diagnose that may be atrial fibrillation? The short answer is no. However, you have to have an atrial burden on your atrial burden mean atrial ectopics rather than atrial tachycardia. So you have to have a irregular rhythm, irregular ectopics, and the burden of ectopics is so much that you may not have been able to find an atrial fibrillation, but atrial ectopic heavy burden is can lead to atrial fibrillation. And obviously prolonged monitoring may let you to diagnose atrial fibrillation. So atrial tachycardia on its own is not an indication for anticoagulation and is not a prerequisite, and it is not a sign for impending atrial fibrillation.
Thank you.
So the second question was?
Same. So you have already answered it. That was it. So the other question Dr. Abbas has asked, how likely to miss PFO on transthoracic echo? I think that's a question.
I think transthoracic echo, the small or the moderate size of PFO can be easily missed. And remember, the transthoracic echo is very operator dependent, patients dependent, patient position, probe position. So it is very easy to miss transthoracic echo. However, if your PFO is at least moderate to severe, it probably can be diagnosed. But again, you have to put a color Doppler to it. And although color Doppler is not as sensitive as bubble contrast, but if you have got a strong feeling, I would suggest a transthoracic echo coupled with bubble contrast probably is the easiest and does not take at all much time, can be done on the bedside, take a couple more minutes. If you are referring these people and you strongly believe that the PFO may be the underlying disease, do not refer just for transthoracic echo, refer transthoracic echo with bubble contrast.
Thank you. Other question is, if how much is the risk of AF post-closure? The question is, after closure, what is the risk of AF?
Oh, right. Okay. So I think all the randomized control trial have put it to 2%, while in the real world data, they think it is slightly high. Again, the atrial fibrillation, which is due to the procedure, they are very transient, and most of them resolve within first 45 days. So if your atrial fibrillation is procedure driven, you are allowed to take these people off anticoagulation. So most of these people had a transient AF, and most of them recovered within first 45 days.
And a question from Dr. Zahoor, any recommendation for using DOACs rather than warfarin in patient who had a device closure of PFO and had PAF also?
Okay, so I don't think so. The device itself is an indication for anticoagulation. When it comes to the atrial fibrillation, you can use any of them because it is not the device which is asking you to give warfarin or the DOACs. It is the atrial fibrillation, and you need to treat it atrial fibrillation as you normally treat atrial fibrillation even without the device. So there is no difference between warfarin. So you need to make your own decision on that. There is no specific guidelines.
So question from Dr. Koch is, in patient with a high ROP score and PFO on transthoracic echo, do you still proceed with TOE to show ASA feature?
So transthoracic echo, I take it, it usually is a bubble contrast. But again, as I said, that on transthoracic echo, the morphology of right atrium is not that visible. You really need to do a TOE, and doing a TOE will prevent you referring inappropriate patient to the cardiologist, because it will also tells you, and if you got a long tunnel, if you got a carry network, if you got a eustachian tube, and if you got an aneurysm, you probably are doing a right referral to the patient. So answer to the question is, it is best practice to do a TOE and the ROPE score. Although transthoracic echo with bubble contrast probably will give you the idea of how big the defect is, but it probably not give you the other morphological features of the PF.
Okay, thank you, Dr. Javaid. Last question before we go to next. Obviously, people are having a cup of tea, hopefully, in between. So Dr. Koch has asked, is ultrasound of lower limb to look at venous thrombosis bears any weight?
I mean, normally at the moment, this is not the policy that anybody with the PFO, you should be doing, uh, you should be looking for any thrombus either in the pelvis or in the lower limb. That is not the current practice. But if you think that this patient, by the virtue of its clinical feature, has got a TBT or a malignancy or any condition which may predispose them to the venous thromboembolism, I think it is best to do it, because these people will benefit from anticoagulation rather than PFO closure. But in a normal young patient with no clinical features at the moment, we are not asking them to do a CT scan of the pelvis or a Doppler of the lower limb to see whether they will qualify for anticoagulation.
Thank you, Dr. Javaid. Thank you. So we'll close the question answer from the audience now for your talk. So without any delay, obviously, because we want to finish on time, so we'd like to invite our next speaker, Professor David Werring. Professor David Werring is working in clinical neurology in UCL Institute of Neurology, honorary consultant and neurologist, National Hospital for Neurology and Neurosurgery, Queen Square, University College Hospital, NHS Foundation Trust. Thank you, David, for coming and giving your precious time to us. And how can we forget COVID? Talk today, when the COVID is all around us. David is going to talk on COVID-19 and stroke. Is there any relationship? So that's all we know now from David now. David, up to you.
Thank you very much indeed, Asem. And thank you for the kind invitation. I'm just sharing my screen with you all. So I hope you can all see this well.
Yep.
And thank you for setting me this challenging topic of COVID-19 and stroke. Is there any relationship? For those who don't know me, I'm a neurologist at UCL Queen Square Institute of Neurology. So thank you again for the organisers for inviting me today. So this is the talk structure. I'm going to firstly talk about the evidence that we have for relationships between COVID-19 and ischemic stroke. This will be largely to do with work that we've done in the UK that I hope will be relevant to people attending this conference. Then I'll say a little bit about COVID-19 and intracerebral hemorrhage, much less data here, but I'll try and summarize the studies that we have. Briefly think about potential mechanisms. And then, of course, the big challenge here is how do we treat people with COVID-19 and stroke? Should there be any difference in the way we approach these people compared to people with stroke that is not happening in the context of COVID? And then I'll try and sum up. So first of all, then let's talk about COVID-19 and ischemic stroke. So I want to take you back to April 2020. This was the beginning of the first wave of the pandemic in the UK. Seems a very long time ago now. And these are daily new cases that you can see on the screen here. And I've put an arrow here. This was when UCL in London, we started to see people who'd had a history of COVID-19 and were coming in with ischemic strokes. And we noticed some unusual characteristics. And my colleague, Dr. Arvind Chandratheva, was the first of us to really begin to piece together a pattern of unusual strokes occurring. And anyone who's interested, he wrote an article for this magazine, The Conversation, which describes in a sort of narrative story what we were seeing. But what happened was during these 2 weeks, we began to see an unusual pattern. And we realized that in London, we were ahead of the curve in terms of the first wave of the pandemic. We were seeing COVID earlier than other parts of the country. And we thought, well, we better report these observations just in case they're going to be helpful to other people in the country who may be seeing this phenomenon with a lag after we saw it. So we wrote up these cases very, very quickly and published a paper on April the 28th. And just a couple of days later, a very similar report emerged from Mount Sinai Health System in New York. That was published on April the 30th. So why did we think this was interesting? Well, what we were seeing was people who'd had COVID, typically a week or two earlier, and they were coming in sometimes with multiple large vessel occlusions, sometimes with single large vessel occlusions. And this first patient here, you can see here there's a thrombus in the left vertebral artery. We have a peak of territory infarct, but they also concurrently, rapidly after this, developed a posterior cerebral artery territory infarct. This gentleman also had pulmonary embolism, and we put him on anticoagulants. And this second stroke occurred despite anticoagulation. And immediately you can recognize, well, this is odd, isn't it, for ischemic stroke? We don't normally see multiple large vessel occlusions. We don't normally see concurrent early PE. And we don't normally see ischemic stroke occurring in a large vessel despite therapeutic anticoagulation. And then some of the other cases you can see here is one with a PCA infarct, but also a pica territory infarct. This one has an occlusion of, you can see this large vessel occlusion here in the PCA, this striated capsular infarct. And just moving on, we've got an M1 occlusion, sorry about that. And then here we have a basilar occlusion. You can see the thrombus magnified up here, but also a PCA occlusion. So we weren't really sure whether this was anything that was associated with COVID necessarily, but we wrote them up, and what we described was the age was quite a broad range between 50 and 85. Most of the people had had COVID about a week to 3 weeks prior to their stroke presentation. What we did think was unusual was the D dimers here. So the first case was literally off the laboratory scale of 80,000 or more. And the others, you can see they've all got high D dimers. So in micrograms per liter, this should be below around 400. So these are very high. They also had evidence of inflammation with a high CRP in most of the patients. And 5 out of the 6 had a lupus anticoagulant. So of course, it's a very low level of evidence. It's just 6 cases. But remember, we were seeing these in a 2-week period, one after the other. So we thought, well, this is definitely worthy of reporting. And to summarize then, what we'd seen were evidence of hypercoagulability, high levels of inflammation in the majority, large artery occlusions, 3 of whom had multiple occlusions, which we all know this is pretty unusual for conventional ischemic stroke. 2 of them had recurrence despite anticoagulation. 2 had concurrent DVT and pulmonary embolism, and 5 had antiphospholipid antibodies. But the question arises, is this anything to do with COVID, or is it just coincidence? Because obviously once you start looking for something, you start to see things, see patterns. But these were consecutive patients seen during a 2-week period. So the second thing I wanted to mention, and you'll all be familiar with this, is during the first wave of the pandemic between April and May, we all seemed to be seeing less people with stroke attending our units. And Richard Perry immediately sort of set to work at looking at this pattern and seeing why was this happening. And it looked as though what was happening was that during the first wave peak, we were seeing less severe strokes, and we're seeing more severe strokes. In other words, the less severe end of the spectrum, you can see February, March here, much, much higher than when we were in the first wave of the pandemic, and seeing these more severe strokes. So there was a shift in the spectrum of strokes toward more severe strokes during this first wave. And this seemed to be because less severe strokes were simply not attending our service. And I believe this has really been corroborated by a lot of research around the world that less severe strokes were attending. So why am I mentioning this? Well, if we're interested in looking at COVID and the relationship between COVID and ischemic stroke, if we simply looked at admissions during the pandemic first wave, and we compared them to historical controls of strokes without COVID, we're going to immediately get an erroneous conclusion that COVID strokes are more severe. And this may be nothing to do with COVID. It may simply be to do with the pattern of strokes attending our hospitals. So really the methodological point here is that a contemporaneous case control study is absolutely essential. So there were many, many studies published very quickly where people said, well, this is what we saw during COVID and this is what we saw during a historical control period, maybe from a year before. And this is not a reliable way to look at this question, because there is going to be a change in the spectrum of stroke during COVID that may be nothing to do with COVID itself. So Richard Perry and a number of investigators, notably Craig Smith, Christine Roth, many others here, maybe some people are on the seminar today, at 13 hospitals around the UK, Richard and others rapidly set up this collaboration called CETICOS to investigate using a contemporaneous case control design what were the features of COVID-19 associated ischemic and hemorrhagic stroke compared to contemporaneous controls of strokes without COVID. And the centres did an absolutely brilliant job of entering patients into this study during really difficult times when research was very hard, because lots of staff were being redeployed into COVID wards. But the teams did an absolutely superb effort, and we'd like to really thank the collaborators for helping with this. And many of them are named here on the paper. So what did we find? Well, we looked at 86 cases of COVID-19 associated stroke compared to 1,384 controls who did not have any evidence of COVID during their hospital stay. And what we saw was that the cases of COVID-19 stroke seemed to more often be of Asian ethnicity compared to others. There seemed to be a higher severity of stroke on the NIHSS scale. The length of stay was longer, and this may have been related to more severe strokes during COVID. We had an MRS of 4 on discharge in the COVID-19 stroke group compared to 3 in the control group. And rather worryingly, the rate of mortality, the death rate was 20% in those with COVID-19 stroke compared to about 10% for controls in hospital during the same period. You can also see that there was a rather low rate of stroke recurrence during the admission. So just showing these things graphically, we can see here the proportions of different ethnicities with an excess of those of Asian ethnicity in the COVID-19 case group compared to the non-COVID control stroke group. Here we can see the stroke severity spectrum, and you can see very clearly that in the control group, there are a peak here of less severe stroke severity, and in the case group of COVID stroke, we see a higher severity peak here. So clearly something happening with the spectrum. And remember, this is contemporaneous control, so we know that it's not an artifact of the people attending our services. We can also see here the worst functional outcome and the increased mortality associated with COVID-19. But of course, do we know whether this mortality is independently related to COVID, or are there other confounding factors? And it looked like even if you correct for other known predictors of early mortality in stroke, such as intracerebral hemorrhage and age, we see that COVID-19 still seems to double the risk of death in this cohort study. We also confirmed this evidence of hypercoagulability that we'd seen and others had seen in small case series. What was interesting was the D-dimer spread was greater in the cases, but there was a peak at a very high D-dimer level in the cases compared to these controls. And each one of these arrows is somebody who was anticoagulated for venous thromboembolism. And if you do a statistical test with log transformed D-dimer, you do see that there is on average a higher D-dimer level in the cases compared to the controls. We also found that there was a similar proportion of people with any large vessel occlusion, but there was a higher proportion of people with COVID-19 associated ischemic stroke who had multiple large vessel occlusions. So this again seemed to be bearing out the data that had come from very small case series before this. And again, we've looked at contemporaneous controls. Now, interesting negative finding was that there didn't seem to be an effect on the age spectrum in people with COVID-19 and stroke compared to those controls without COVID. And this indicates that it's not really just a phenomenon in young people. Lots of papers have been published arguing that COVID causes stroke in younger people. And while there may be strokes in younger people that we can see in the COVID group, on average, there doesn't seem to be a different spectrum in those with COVID compared to those without. So COVID seems to be not specifically shifting the age of people having strokes. And then finally, looking at this binary logistic regression, this just looks at the independent predictors of COVID status in this study. And if we do this multivariable model, we see that the Asian ethnicity, the multiple large vessel occlusions, and pre-morbid MRS were all independently associated with COVID-19, even when you adjust for other factors in this multivariable model. And another notable negative finding that I want to mention is that the spectrum of mechanisms didn't seem to be that different in those with COVID compared to without COVID. So you see a similar spectrum of large vessel atherothromboembolism, cardiac embolism, and small vessel occlusion. And this again goes against some of the other studies that have argued that there are specific mechanisms, for example, more cryptogenic strokes or coagulability associated strokes. So what is this data telling us? Well, it seems to be consistent with the idea that COVID might provoke ischemic stroke through thrombotic and inflammatory mechanisms, but through both large artery occlusion via cardiac and atherothrombotic mechanisms, but also small vessel occlusion. In other words, it seems to perhaps increase the vulnerability to stroke in people who already have risk factors for these existing conventional stroke mechanisms. So you may be asking, well, how much of a problem is this? How often does COVID actually be associated with incident ischemic stroke? Well, this is a nice meta-analysis from Hugh Marcus's lab in Cambridge, who found a pool incidence from all the cohort studies that they identified of 1.4% of ischemic stroke in the context of COVID-19 in hospital. So it's a very small minority of people with COVID that seem to suffer ischemic stroke. This meta-analysis also seems to confirm the very high risk of mortality, the high risk of large vessel occlusion, but on the positive side, we don't seem to see lower rates of intravenous thrombolysis or endovascular treatment. And this seems to have been borne out from SNAP data within the UK, which seems to show that teams are really doing a fantastic job of maintaining both intravenous thrombolysis and thrombectomy in the face of the COVID-19 pandemic challenge. So that was the data I wanted to mention on ischemic stroke. Now I'm briefly going to mention intracerebral hemorrhage in the context of COVID. Now the challenge here, of course, is that most of the studies that have been published are very small case reports or case series, and it's very difficult to understand patterns from such small studies. So Rama Beiruti and others in our team decided to do a systematic review and pooled analysis, where we looked at all the case reports and case series of intracerebral hemorrhage in the context of COVID-19, and also all the aggregate level data that we could find. And we pulled these in an individual patient data meta-analysis in those where there was individual patient data. And then we also combined these with aggregate level data from other studies that only reported aggregate level data. So if we first quickly look at the individual patient population, this was 98 people with intracerebral hemorrhage with a history of COVID, and this is hospital cohorts. what we can see is that the age looks pretty young at 60 compared to conventional cerebral hemorrhage. Pretty low rate of hypertension, 53%. What is really striking is 67% were lobar. This is many more than you will have heard from Rustam's talk earlier of lobar hemorrhage in conventional intracerebral hemorrhage studies. Often there was multifocality, so multiple synchronous hemorrhages in different bits of the brain. This again is very rare in usual practice. It's about 5%. So this was much, much higher. We see a relatively high rate of coagulopathy, and this is often due to anticoagulation to a therapeutic level. About 55% were on anticoagulation therapeutic. Round about 2 weeks since COVID infection, the onset of symptoms, so a bit similar to the ischemic stroke that I told you about. And what's really interesting is that the vast majority of these hemorrhages occurred in severe COVID-19. So these are not the sort of people that we generally are going to be seeing on our stroke units. They're people who are in ITU on organ support in these reports. A very high rate of ECMO, extracorporeal membrane oxygenation, which is obviously a feature of severe respiratory disease. And as you can imagine from these figures, a really high mortality of 54%, which in hospital mortality, that's even higher than conventional brain hemorrhage. And then just to look at the pooled analysis, very similar results, very high rate of lobar location, very high rate, 75% of therapeutic anticoagulation, and 20% being multifocal, and a hint that may be less often female than the conventional hemorrhage. If we look at those who were on anticoagulants compared to those who weren't, the lobar location, the multifocality and the coagulopathy are more common in people who were taking anticoagulation at the time of their hemorrhage. So how do we put all this together? Well, it seems that maybe intracerebral hemorrhage is related to a coagulopathy, often due to therapeutic anticoagulation, and perhaps a delayed diffuse bleeding-prone endotheliopathy. This would be one hypothesis, at least, that would be consistent with those observations. And how often is intracerebral hemorrhage found in people with COVID? Well, it looks like about 0.38% if we do a pooled incidence. And this is clearly a lot lower than the incidence of ischemic stroke, which is probably what we'd expect. Here are some examples of the very severe intracerebral hemorrhage that has been reported, demonstrating here a large lobar hemorrhage and here synchronous multi-lobar hemorrhages. And here are some examples of devastating hemorrhage with fluid level, which goes with a coagulopathy, in people who were on ECMO treatment. So just thinking about the underlying mechanisms of both ischemic stroke and intracerebral hemorrhage in COVID. So I'm taking a very much a clinical viewpoint, but if we look at the mechanistic observations, we know that there is a receptor binding domain of the ACE, of the SARS-CoV-2 virus spike protein, which binds to the ACE2 receptor, which is abundantly expressed in endothelium. And this may be an explanation for why multi-system involvement can be seen in COVID, as we know, and why there can be a diffuse abnormality of coagulation and inflammation leading to venous thromboembolism. And this is a figure from the International Journal of Stroke Review, from Hugh Marcus Review and a Nature Medicine Review, indicating here the hypercoagulable state with raised D-dimer, fibrinogen, a hyperinflammatory state with raised CRP and other cytokines, and evidence of endothelial dysfunction, which may be driving the hypercoagulable state. And this has been termed thromboinflammation. And a key component here is the endothelial damage associated with thromboinflammation. So this idea of a diffuse endotheliopathy with hypercoagulability and high inflammation would be one hypothesis that could explain some of the associations that we're seeing. So now briefly then, I just want to turn to treatment considerations. How can we use these observations to guide the way we treat these patients. And unfortunately, what I'm going to say is largely evidence-free. We really haven't got much to guide us on this, but I'll try and say something vaguely useful. So the first thing is, as we've heard, we've got at least some evidence of the pooled baseline risks of people in hospital with COVID. We know that there's a risk of ischemic stroke of around 1.5%. We know that there's a risk of intracerebral hemorrhage, maybe about 0.4%, but really overwhelming both of these risks is the extraordinarily high risk of venous thromboembolism, which is 17% overall, but you can see quite a bit of heterogeneity from this systematic review recently published in Chest. But I think we can take this on board and say, well, our stroke patients, like other people in hospital with COVID, are likely to be at very high risk of venous thromboembolism, although I actually don't have really good UK data on this in an actual UK cohort, but it seems reasonable to extrapolate these data to say these people are at very high risk of venous thromboembolism. So vigilant attention to that's going to be very important. And then the stroke recurrence rate is only 2.5% in hospital for ischemic stroke compared to about 1% for those without COVID. And I mentioned that because that's going to make it really hard for us to do randomized trials of this. And we did actually try and set one up, but it wasn't funded. And one of the reasons was that it was considered that we just wouldn't have enough patients to be able to do this trial. And that's probably true. So let's then briefly consider 3 clinical settings. First of all, COVID-19 without ischemic stroke. So this would be prevention largely of ischemic stroke and venous thromboembolism. Then COVID-19 and ischemic stroke without VTE. So that's the sort of patients we normally will be seeing on stroke units. And then those who have COVID-19 and ischemic stroke, but with VTE. And unfortunately, this is also getting pretty common now in people with COVID who often have VTE. And we'll look at prophylactic and therapeutic anticoagulation and antiplatelet therapy. So COVID-19 without ischemic stroke. As I've mentioned, there's a really high risk of VTE. The guidelines are telling us that it's reasonable to measure D-dimer for prognostic significance, although I don't really think we've got really much idea of how this should guide our treatment. Prophylactic low molecular weight heparin is recommended routinely for the vast majority of patients. And that probably also goes for our stroke patients. The role of therapeutic anticoagulation is uncertain. I'll show a little bit of data in a moment. And other antithrombotic agents are largely untested, although there are about 75 trials from which we will be getting data in the coming months. And aspirin, of course, is now included in the really important recovery trial in the UK. So we're looking forward to data from that. So all the guidelines are going to recommend VTE prophylaxis in people with COVID-19 in the hospital. But an interim analysis of these 3 randomized controlled trials was really interesting. It looked at therapeutic compared to standard prophylaxis. So that's largely with standard dose with sometimes mechanical measures. What we can see is there seems to be a big difference between moderately severe COVID and severe COVID requiring organ support and ITU care. And with the severe state, there's evidence of less organ support-free days in the first 3 weeks, making it likely that this could be hazardous. These are an interim analysis, but I understand the trial has stopped for futility in the severe COVID group. We will get full publication on this, but at the moment, it looks like therapeutic anticoagulation may be hazardous in really severe COVID. So what about in our stroke patients without evidence of venous thromboembolism? So we should be treating conventionally as for ischemic stroke. We've got no reason to withhold TPA or mechanical thrombectomy. Antiplatelets should be given as per standard care, and we should be considering early anticoagulation for people with atrial fibrillation in the first 2 weeks. Of course, we should be randomizing people into trials like Optimas for this question. Routine VTE prophylaxis is absolutely critical. So IPCs are recommended in all our guidelines, but in this high-risk group, one should consider prophylactic low molecular weight heparin, although there is not evidence on this specifically for stroke, but there's strong guidance that we should be using this in COVID patients in hospital. It's reasonable to measure the D-dimer and the lupus anticoagulant, although we've absolutely no idea how this should guide our treatment. Now, in our service, factors that we would consider to support early therapeutic anticoagulation would be evidence of a really severe hypercoagulable state. Having said that, we don't really know how it should guide us. If we see D-dimer in the thousands, it's something we're going to think about, particularly if we see multiple large vessel occlusions that are not explained by another mechanism. If we see free-floating thrombus in an extracranial or intracranial vessel, if we see a cardiac thrombus, and if we see recurrent large vessel occlusion occurring despite prophylactic anticoagulation. These sort of things would push us towards considering early anticoagulation, although it's an evidence-free zone, unfortunately. This is one patient who presented in their 80s with a left hemisphere syndrome of dysphasia. They have a left MCA infarct in a cortical branch, and we see they were given TPA, a standard practice. Unfortunately, they sustained hemorrhagic transformation and got a little bit worse clinically, but we saw this big free-floating thrombus in the left carotid, internal carotid. Difficult decision with all this hemorrhage in the infarct, but we decided with a multidisciplinary approach with hematology and with our radiologists and our other clinicians in the team, we anticoagulated the patient with split-dose low molecular weight heparin, and the thrombus had disappeared. And luckily, we got away with this. There was no worsening of the intracranial hemorrhage. I saw a similar patient on a ward round this morning who'd had TPA, had a hemorrhage into an ACA infarct, and had a left ventricular thrombus, and also concurrent pulmonary embolism in the context of COVID. So clearly we had really very little choice but to think about anticoagulation despite this hemorrhagic risk. And these very difficult treatment dilemmas seem to be the norm for people with COVID and ischemic stroke, unfortunately. So if you've got VTE present, it seems reasonable to consider therapeutic anticoagulation because these are life-threatening complications, the venous thromboembolism, but the bleeding risk needs to be acceptable. And how do we determine that? Well, if somebody's got PH type 2, severe space-occupying bleeding into an infarct, we'd probably delay anticoagulation if we thought that was reasonable with the VTE. We might rescan for resolution, we might use intermediate dose, or we might monitor with 10A levels. These things are very difficult. I'm afraid I don't have any easy answers. If there's active or serious bleeding elsewhere, we might delay and treat the bleeding source, or we might adjust the dose. And if somebody's got an incidentally detected PE, we'd usually consider prophylactic or intermediate dose. So say they've got a segmental PE that's detected on the CTA when they come in with their stroke, we might use a lower dose rather than full dose therapeutic low molecular weight heparin. But these decisions are so difficult. We need randomized trials. I don't think we're going to get a trial in COVID ischemic stroke for the reasons that I've alluded to, that it's pretty rare, that the recurrence rate's low, VTE is often present, and we're not going to have equipoise for therapeutic anticoagulation. And finally, people with COVID are obviously in an awful lot of other trials at the time they may be having a stroke. And I don't know of any specific stroke trials in COVID. We've got no idea on how to treat people if we do anticoagulate them with COVID ischemic stroke and VTE or without VTE. In our practice, we monitor the D-dimers in the outpatient department, and we monitor the lupus anticoagulant. And we have an MDT to discuss when or if to stop treatment, but I don't have answers. This is an algorithm, and this is completely evidence-free, but it's just to outline what I've just said, really, those basic principles of treatment. And it's, again, a big disclaimer, completely not based on very good quality evidence. So I'm going to sum up and say that I do think COVID-19 is associated with a rather distinct phenotype and natural history in some ways in terms of ischemic stroke. Ischemic strokes with COVID are more severe, there's higher mortality, there's a worse outcome. They more often have large vessel occlusions, more likely to have Asian ethnicity, but I don't think there's any difference in overall age or stroke mechanisms. And there may be evidence of a hypercoagulable or hyperinflammatory state, but you don't always see this in all of the patients. Intracranial hemorrhage, and the thing to note is that this is nearly always in severe COVID, so not the sort of people we see on our stroke units, but when it does happen, it's often lobar, multiple, and often associated with anticoagulation. So it does seem a bit different to conventional intracranial hemorrhage. But I think we've got to have a big caveat here. We haven't got good case control studies in the way that we did have for ischemic stroke. The role of specific antithrombotic therapies remains to be determined. I've given you some sort of principles one might work on. I'm sure you've all been working on your own pathways for this. And in the meantime, it's important not to forget standard evidence-based stroke care. Most importantly, people with stroke need to get to hospital. They need access to thrombectomy. They need access to TPA. And we need meticulous VTE prevention. But we do need much more research on the mechanisms, optimal treatments, and I could add to this, we need data on longer term outcomes. And Richard Perry and others are going to look at this in a Stroke Association funded COVID-19 stroke study building on Ceticos platform. So I'd like to thank a lot of people, particularly Richard and the Ceticos collaborators around the country, all of my colleagues in the stroke service, particularly Arvind and Rob, Azra, the stroke research team at UCH, and all the CRN research teams around the country that were so brilliant at recruiting people to Ceticos. And I'd like to thank you all for listening to my talk, and very happy to help with any questions if I've got any answers. Thank you very much indeed, and I'll stop there.
Thank you, David, for presenting a topic which is new to all of us, new territory, and we don't know, it's evidence-free at the moment, but you have presented it in such a way that it has given some sort of a guidance. Question to you from me is, obviously it is a hypercoagulable state. Are we thinking there's an element of vasculitis in it, or is there any CT angio or MR angio has shown different angiograms or any vasculitic picture in those sort of patients or not?
Thanks, Asem. So that's a really good question. I don't think it's likely to be very common from the data that we have, because mostly you're not seeing multiple large vessel irregularities suggesting a medium vessel caliber vasculitis. Having said that, there are a few reports, and I believe there have been some reports with black blood and vessel wall imaging that have described a vasculitis in COVID, and it does bind to the endothelium. So I wouldn't say that it can't happen, but I don't think we've got evidence that it's very common. But that's a very valid concern, and of course could completely change our treatment. But I don't think it's common, Asem. What I do think is common is probably a more diffuse small vessel endotheliitis, which is largely in people with severe COVID on the ITU. So they often get a leukoencephalopathy and cerebral microbleeds, which would be rather in favor of a diffuse endotheliopathy, but there's only limited pathological data to validate that hypothesis.
Fair enough. Other question related to that. Was there an evidence of myocarditis in those sort of patient, whether echo has been done in those sort of patients for further investigation in any centers, whether we compared, whether there was more element of myocarditis?
I'll be honest with you, I don't know the answer to that, because I only really work in the stroke and neurology domain, but maybe others on the team on the call may know, but I don't know about endocarditis, myocarditis, I'm afraid, Asem.
Fair enough. So the question from our audience is there any evidence of using anticoagulation in acute ischemic stroke with COVID after mechanical thrombectomy to prevent reocclusion at the risk of hemorrhagic transformation?
Yeah, so you do read reports, and I've heard from our interventional colleagues that it can be very difficult to get the clot out in COVID related large vessel occlusions. And I don't have specific data, but my belief is that outcomes from thrombectomy with COVID may not be quite as good as they are with non-COVID, and this could be to do with hypercoagulability. So there may well be a rationale for using early anticoagulation after mechanical thrombectomy to prevent reocclusion, but then you've got this big risk of reperfusion and hemorrhage. So I don't know any evidence on this, but I haven't really, I haven't seen any good evidence on that, I'm afraid.
So other question was Dr. Pervez has asked, is there any particular areas which are involved more in COVID patient as compared to control?
Does that mean different territories of the brain, I presume?
Yep.
I don't know that we certainly haven't yet looked at that systematically in the CETICOS data set. And I don't know the answer to that from other studies. Anecdotally, from our first series, there are a lot of posterior circulation strokes, but that's a really good question. We should definitely have a look at that. I don't know the answer. So I'm not doing very well here, am I? On this
No,
question?
you're doing well. Obviously, it is for all of us. It is something new. It's a forum to discuss something. So we are not missing anything.
Yeah, that's a wonderful question. Now I shall certainly see if we can get evidence on that.
So the other question is, should we be giving the same low molecular weight happen in COVID pneumonia patient with stroke, or is this very individual?
Well, we've got data from those randomized controlled trials of people with COVID pneumonia on the ITUs and the non-ITU patients, suggesting that for those with moderately severe COVID, therapeutic anticoagulation may well be beneficial with less organ support-free days. But in severe COVID on organ support at baseline, so the much more severe ones, anticoagulation may not be so beneficial. And I don't believe they've looked specifically at those with an ischemic stroke, if there were any in those studies. So what, I forgot what the question was now. COVID pneumonia, I think there certainly is a role for anticoagulation, definitely prophylactic and possibly therapeutic.
Thank you. Other question is, for how long we are going to give anticoagulation if we start somebody on anticoagulation and D-dimer is more than 1,000? So for how long we should carry on with this anticoagulation?
Yeah, well, in our service, I know Arvind Chandrathiva leads a lot of our follow-up clinics for this. What we do is we monitor the D-dimer, and when it comes down into the normal range, which it seems to do in a lot of these patients, it's a temporary phenomenon, it comes down, then if there are no ongoing definite indications for anticoagulation, we would consider stopping the anticoagulation at that point. And the lupus anticoagulant, again, this seems to be a transient phenomenon in some of the patients, but not all. And we all know that this can be a non-specific reaction to a viral infection. So often the lupus anticoagulant, if that disappears, then we'd also consider stopping. So basically, if they've normalized, the patient's well, and there's no other clear anticoagulation indication, then it would seem reasonable to consider stopping it. And this has been done in some of our patients, and they've done okay.
So a similar question, if we are thinking it is a COVID-related stroke and in a young patient, and because of a severe COVID, for how long we are going to give antiplatelets?
Well, that's a slightly different one. I think in those patients, if there is any more conventional stroke risk factor, and often that's the case with COVID, because as you know, people who've got diabetes, hypertension, they're at most risk of getting COVID. So often there will be other risk factors, and I would continue antiplatelets long term, as we do for all people with ischemic stroke. If there's absolutely no vascular risk factors, then I think you could have a conversation with the patient, but I'd be minded to continue that long term, at least for the first year or so, and then review it.
So thank you, David. It has generated a lot of questions in the question and answer box. Because of the time, is it possible if we can stay for another 5-10 minutes to answer those questions in a chat box, in a question and answer box? So that would be
Yes,
great.
please. I'll do my best.
Thank you very much for coming and giving your precious time to us again. And you have always been very supportive for this masterclass.
Yeah, no, it's a great masterclass. Thank you, Asem.
Thank you, David. Thank you. So without any delay, I would like to invite Dr. Gail Meadows. She is the principal clinical psychologist in Department of Psychology and Medicine in Northern Lincolnshire in Gould NHS Trust. Gail is going to talk about cognitive rehabilitation after stroke. We have talked about a lot of acute things, but obviously we have not talked about much about therapy. But this is a time to learn for as a doctors, for me also, that what do you do? How you improve patient with a cognitive impairment after the stroke? So Gail, please present.
Okay. Can you hear me okay?
Yeah, we can hear you.
Okay, right, I'll just pull up my screen. Started. Okay. So thank you for asking me to speak, Dr. Ali. What I thought I would try to do was, well, first of all, I don't have any conflicts of interest to declare. What I'm going to try and do is give a bit of a whistle-stop tour for cognitive rehabilitation. So I'm going to start by giving an overview of it, where it came from, how it's developed, then going over briefly the process that would go through to generate a cognitive rehabilitation program, think about any slight differences there might be when dealing with somebody who has had a stroke, and then to go over some of the many challenges that we face in providing a cognitive rehabilitation program. And then I've picked out some key bits of research that we can go over at the end around the kind of expected outcomes you can have for cognitive rehabilitation and where we need to go in the future. So firstly, the thing that I always think when I'm meeting somebody for the first time for rehabilitation is whether I'm looking at an input, a processing, or an output problem. Because at its core, I think that cognitive rehabilitation always comes back to that. Do we have a sensory problem? Is this more of a communication problem? Or is it actually an expression that is the issue? So the history of cognitive rehabilitation as a sort of cognitive neuroscience has been developing for the last 100 to 150 years or so. And it really is based on models of illness, not wellness. And I think that is at the core of a lot of our problems. So we started off with localization case studies back in the early 1800s with famous cases like Phineas Gage. And then you also have Broca and Wernicke's area, which are coming out at that time. And then over all of this 100 and 150 years or so, you have the onset of modern brain imaging. We have access to functional MRIs now, which can show us a brain in action. And I think, unfortunately, we still don't really understand the brain very well. It seems like the more we learn, the more complex it is and far more interconnected it is as well. What is very clear is that every injury is completely unique to that person. And therefore, every intervention, every cognitive rehabilitation intervention that you deliver has to be completely tailored to that individual. So this is the first big challenge we have with cognitive rehabilitation, is that I can't just pull a manual off a shelf and say, well, this is what I'm going to do to rehabilitate memory every single time. I need to consider who that person is, what injury they've had, what their life was like before, what situation they're in now, and then adapt the models that we have, which have developed over this time, to try and think about how we're going to hopefully restore some of the lost abilities that that person may be experiencing. So rehabilitation as a practice really started to pick up after World War II. We had lots of veterans returning home with either closed head or penetrating head injuries. And the main focus at the time was on vocational performance and getting people back to work. And as it's progressed, the introduction of more general functioning and thinking about activities of daily living has been incorporated into rehabilitation, cognitive rehabilitation as a whole. And Luria was a big proponent of specialist rehab units. So we have places like Oliver Zangwill Centre, and obviously we've got the Brain Injury Rehabilitation Trust now. The idea that you couldn't just see the person in different specialisms, you needed to see them as a whole. So you needed this NDT approach in order to rehabilitate the brain properly. And more recently, there's been a lot of interesting research around neuroplasticity and the impact and implications that could have for rehabilitation programs. So neuroplasticity, you're probably quite familiar with, the idea that cells that fire together, wire together. You know, if we can have repetitive behavior and stimulation of certain synapses, then hopefully those neural networks will reorganize themselves. And this is linked to ideas of synaptogenesis. And And for me as a psychologist, where this comes into play is that there's a lot of research around the involvement of mood on neuroplasticity. People who are experiencing depression have reduced dendrite expansion. So if you're looking to try and restore or reorganize a person after they've had any kind of brain injury and they're depressed, you're going to be really fighting an uphill battle. So I think the more we learn about this and how this is related to mood and how we can help to create a brain environment that is more geared towards supporting neuroplasticity, then I think we'll see improvements in cognitive rehabilitation outcomes as well. So moving into cognitive rehabilitation and thinking about what you want to do with the person, you need to consider if you're restoring or compensating for those lost skills. And often what I find is that I actually end up switching between these approaches. You might start with trying to do some repetitive exercises and training to re-establish lost skills. And then when that doesn't work, then you might shift to, well, how do we compensate and account for your short-term memory difficulties instead of trying to re-establish your short-term memory ability. A consideration I always have when looking at this is maximizing a person's previous skills, especially preserved skills. And part of this again comes back to mood. We want somebody to feel engaged in their rehabilitation. And if they're repetitively failing in your rehabilitation with them, then obviously that's going to be quite demotivating. So starting off with their relatively preserved skill set where there is more likely going to be some restoration often gets you people engaged in the rehabilitation more quickly, and then you can move on to the compensation, as hopefully you'll have protected against some of the negative impact from mood against the impact of cognitive impairment. So in creating a cognitive rehab plan, you need to think about the injury, where it is in the brain, when it happened, how severe it is, the kind of treatment that somebody may have had, medical treatment. We'll also complete clinical interviews with the patient and with their family as well. Very important, especially if you have any kind of frontal lobe involvement, as sometimes people don't have the necessary insight and awareness to their difficulties to give you an accurate picture of what is going on. So the perspective from their family is very useful there. And then wherever appropriate, we will complete cognitive assessments. So you can have anything as simple as a screening, like with the MOCA and the Oxford Cognitive Scale. And then you can go to more formalized battery assessments. And there's two approaches. You either have hypothesis testing, where you would basically follow your results, or you could just do set battery testing instead. Again, I tend to switch between the two when it's always based on the person who's sitting in front of me and the pattern of impairments that they might be reporting. Failing that, if cognitive assessment is not possible because of the severity of the cognitive impairment, then I will use observation. I'll go and do joint assessments with colleagues in physio or OT, or when the person's in their home environment. So thinking about stroke more specifically, you need to consider whether it is ischemic or hemorrhagic, and if there's been hemorrhagic transformation as well, as the evidence does tend to suggest that people who've had a hemorrhagic stroke tend to have more profound and longer lasting cognitive impairments than people with ischemic injuries. Also need to think about the kind of setting that I'm seeing somebody in, whether they're in an acute setting, rehab or community. If it's more acute, then are they medically stable to actually engage in rehab? Often people will be far more focused on being able to eat and drink and sit up and walk, which is perfectly understandable, and don't really want to engage with me in cognitive testing. Then of course, there's also personality changes that can occur, and the mood implications as well that you need to consider when you're looking at cognitive rehabilitation in stroke populations. And then there are also the comorbid health problems that many people with stroke will have, as was mentioned before, you know, diabetes, cardiovascular risks, which can also have caused some cognitive impairments beforehand. So you might actually have some vulnerability there some decline that was happening prior to the stroke, which has obviously caused quite a large change to their cognitive functioning. And all of this will impact on their general rehab progress. So there aren't many recommendations when it comes to cognitive rehabilitation, I'm afraid, because the research for cognitive rehabilitation is not that great. And as I've already said, because everybody's injury is individual, it's hard to offer recommendations. The only recommendations there are regarding cognitive functioning are that people should be screened, which they are in our trust. They are screened within the first 6 weeks of stroke. And then they are given education, both themselves and their family members as well. And we do work with family when we can't work directly with the patient. There are other factors which impact on cognition. This is a short list of them. And as you can see, there's quite a few there. There's lots of things we need to consider that could be impacting on somebody's cognition, not just the fact that they've had a stroke. And all of this comes together to present some challenges for cognitive rehabilitation. So the main ones that I've picked out are mood. So mood in and of itself can impact on a person's attention, their memory, their language production. So you have a stroke and mood together, then cognitive rehabilitation is more challenging because you have to try and understand which part is stroke, which part is mood. And then if somebody is depressed and feeling demotivated, then do you begin with the cognitive rehabilitation, or do you actually offer them psychotherapy to alleviate the depression in order to engage in rehabilitation? As I've already said, self-awareness is important. If somebody doesn't believe that they have a problem, then they're not going to sit down with you and do a memory rehabilitation program. Cross-culture assessment is extremely challenging. A lot of the cognitive assessments we have are incredibly westernized, and they're also based on a westernized education system where people are repetitively tested throughout their education career. So you go outside to so many other cultures, and sometimes the tests are just not applicable at all. We don't have many tests that have been translated. The translation doesn't always work either, and the norms aren't there. They're nowhere near as strong as they are for English native speakers. The setting that rehabilitation occurs in is difficult. Ideally, we'd want it to be in a quiet, non-distracting environment, but if you have to do it in hospital, then you have to do it in hospital. Okay, I'm going to move on because I know I'm running out of time. So the research that I picked out around the outcomes from cognitive rehab, unfortunately, is not that encouraging. A Cochrane review by Danair in 2016 found that although there were improvements in people's memory following cognitive rehab, these effects weren't long-term, but they did highlight that there was poor quality of research and really low participant numbers. Then, and I'm really not sure how to pronounce this name, I think it's Lutcher, I'm not sure, sorry. Also did a review on rehab for attention deficits. And again, they found that there was improvement with the rehab, but the long-term impact was unclear. And again, poor quality research and poor reporting. And what I found interesting was that they excluded the use of practices like yoga, meditation, relaxation, as they didn't consider it to be cognitive rehabilitation, which in my clinical experience, I find quite shocking. And their conclusion and my own is that we really need better research and more inclusive reviews. Because I had a case example of a lady who I saw about 4 years ago, and when she was referred to us, she was 18 months post anterior communicating artery hemorrhage, and was in a wheelchair, she couldn't move and had really poor attention, extremely dysexecutive. Provided an intervention that focused on meditation, and 9 months later she was going home, completely independent, didn't require any support at home. She was talking again, she was walking. fully independent. And that was really surprising to me because in cognitive rehabilitation, we always talk about the first 6 months, best time to get your recovery, best time to get your improvements. But obviously it can occur up to 2 years. So seeing somebody at 18 months post injury, I wasn't really that hopeful. And that got me really interested. And I found all of this research about the impact of meditation, mindfulness, yoga on rehabilitation, and how it improves cognition. So it's something that I always integrate into my work now. And I think part of it is because it helps to create a brain state that is promoting neuroplasticity. You're encouraging the triggering of the parasympathetic nervous system, which then improves the functionality of the frontal lobe. And we need the frontal lobe in order to improve people's attention, memory, and awareness of their difficulties. So when they're in that kind of mind state, they get better outcomes from the rehabilitation. And that was certainly what the staff always told me about this particular lady, that if they didn't complete the mindfulness exercise before the rehabilitation, the outcomes from that session were significantly poorer. So some reflections. There's a cognition working group from the Stroke Recovery and Rehabilitation Roundtable from 2019 also highlighted that there is insufficient evidence for a consensus on specific approaches to cognitive rehabilitation. In my opinion, I feel that we really need to be more holistic in our interventions, that we really need to integrate the mind-body when we are providing cognitive rehabilitation, because the impact of mood on cognition and the impact of cognition on mood are really hard to pull apart. So actually, I think the future would be to look at rehabilitation programs that just inherently combine these two. That was my whistle-stop tour. Thank you. And are there any questions?
Thank you, Gail. I can understand it. Obviously, evidence point of view, from therapist's point of view, it's very difficult to prove, because these are not like a science that you can straight away say studies have proven. It's very difficult to conduct studies in that sort of topic. But we, from our experience, own experience, we can see patients obviously definitely improve as compared to if we don't do any therapy from cognitive point of view. So definitely I will say it is, but unfortunately to conduct these sort of studies is very difficult.
It's extremely.
Because it's more sometimes subjective. There's no definite tools to prove it.
No, it's really difficult to prove it, and obviously you can't really have a placebo effect. The most that you can do is sort of treatment as usual, and that can vary quite widely. And then if somebody's already receiving cognitive rehabilitation as treatment as usual, then it's hard to differentiate the two as well. And I think then another problem with the research is that it's the generalizability of cognitive rehabilitation is extremely hard to prove and encourage as well. So yeah, it's problematic.
Yeah. Well, open to delegates now. The first question to you is, first of all, somebody has said that you have named some theory with depression affecting brain injury recovery. What was the name of the theory?
Name of the theory.
But yeah, it's okay. We obviously we will send a link if I don't know what exactly the question is, but we'll send all the attendees a list, or sorry, link, so that you can see the recorded webinar. So it would be okay. So you'll be able to catch up if you have missed anything from us or slides, you'll be able to pick it up. So next question, how do you assess cognition in the presence of significant aphasia? Any validated scales you can recommend?
Yeah, that's that's not easy, that one. If there's receptive aphasia, then no, there isn't really any kind of formalized. If it's expressive, then you can use the Ray complex figure. That's been suggested as a suitable alternative to things like the MOCA. Anything that's more visual based, you can use as long as they don't need a verbal response. And there are actually quite a lot of non-verbal tests out there, but the Ray complex figure would be the screening test that I would go to if it was purely an expressive problem. Receptive, I'd have to go back to observing them.
There's another question from Grace Cooper. How do you find uptake of mindfulness, etc.? In my experience, people don't want to engage as they feel silly.
Yeah, my experience too, I'm afraid. I think the thing that's really helped me to get people on board is to explain the neurophysiology behind it, that actually this can help to create a calmer mind. And when your mind is calmer, then it's in a better place to engage with your wider rehabilitation. And you can show that quite quickly. You can do a very short 6-minute breathing exercise and do that with somebody before they do their rehabilitation session. And then when they see that actually it improves their concentration, they have better outcomes from that, and you can get that causal link quite quickly, then people tend to think, well, okay, I can get on board with this a bit more. So it does take a bit of trial and error with them, and having a really good therapeutic rapport is important as well, that they trust that this could work and they're going to give it a go for you.
Obviously, if they don't trust, it will not work then.
No.
Next question is Ali Samak. On your experience, does cognitive therapy improve physical function like limb weakness?
I've seen it do, yeah, definitely. There's somebody who I've been working with recently, actually, who had quite significant attention problems. And so I used to do dual sessions with the physiotherapist where I would help to refocus them through the session. And after about 3 months of doing this, they were starting to actually progress with their walking. So they had just been trying to get them to stand and were struggling. So and the attention was also noted as an improvement by other professions, that they were engaging with their soul a lot more. So yes, it definitely does. When you see the cognitive improvement, you will see physical improvement as well.
Last question from delegates is from Jezreel. Is there any suggestion of what type of cognitive behavior therapy suitable for stroke in patients develop depression during hospital admission who are not gaining benefits from medication such as SSRI, which is antidepressive medication, or mirtazapine?
Again, it really has to be down to the person that you're sitting in front of. Reactive depression after stroke is really expected, because obviously it's quite a sudden onset and has quite profound effects on the person's mind and body. If they were in an acute setting, I typically wouldn't engage somebody in a therapy unless they were reporting suicidal ideation or risks such as that, because it's the wrong environment, it's the wrong time. To engage in psychotherapy properly, you really need somebody to feel more settled and safe. And I think the best hospital in the world after you've had a stroke can't necessarily help somebody to feel that way. And also, obviously, privacy is always quite an element for psychotherapy. So I think maybe offering them the chance to talk, a gentle counselling approach tends to be the best sort of holding method for people in the acute setting, and making sure that if they are exhibiting distress and depression or anxiety, then to get them referred to your local psychology department so that they can be picked up when they're in the community.
Thank you, Gail, for such a nice presentation and giving your time to our stroke masterclass. Well done. And so now we're coming to our sponsored talk now. Sponsored talk is by Dr. Indira Natarajan. So this is a pre-recorded talk from Medtronic sponsored talk. And I will share my screen and I will try to run the video now. So just bear with me at the moment.
Hi, welcome to my presentation. My name is Dr. Indira Natarajan. I'm based in the Royal Stroke University guidelines telling us and how we're going to change practice in our own center. Before I go on to that, I just want to tell you about why AF detection matters. It's a very, very important area of stroke medicine. Every 15 seconds, someone suffers an AF-related stroke. And there's been a lot of campaign and work that's been going on in the background, where there has been a significant work being done by particularly the Atrial Fibrillation Association in conjunction with a variety of stakeholders across the country. And the mantra is detect, protect, correct, and perfect. And if you've not heard it, detect means we have to try and detect AF by a simple pulse check, protect patients with AF from having a stroke by using anticoagulation, not aspirin, correct an irregular rhythm with access to proper treatment, and perfect the patient care pathway. Right. Before I just go on into my talk, I just want to give you an etiology of stroke overview. The majority of the strokes that come through our doors are atherosclerotic strokes. Around 20% are carotid artery disease and 20 to 25% are atrial fibrillation. I think this is an underestimate because at present we only see patients who got confirmed atrial fibrillation having strokes. There is a big cohort of patients who had a cardiomyopathic stroke, possibly secondary to AF, but we do not know. But this is the current sort of figures. So in terms of the patient population coming to any stroke units in the country, there's always a 30% population where we do not know the etiology for stroke. We see that they have had a large risk of occlusion. They have not got any evidence of atherosclerotic disease of the carotids, the extracranial and intracranial vessels look pristine, and we do not know what the source of the cardiomyopathic stroke is. And we do know from imaging and from the clinical presentation that it's an embolic stroke. Sometimes we pick up atrial fibrillation, that's around 20 to 25% of the population, but rest of the time we do not know the cause, although we think it's cardiomyopathic. And the guidelines clearly states that we cannot start patients on anticoagulation unless you've got a documented evidence of atrial fibrillation on a 12-lead ECG or continuous ECG recorded monitoring. Right, why is AF stroke very, very important? Because if somebody's got atrial fibrillation, they have a five-fold increase in ischemic strokes. They are likely to be fatal, very fatal, and I'll explain why they're going to be fatal. And the risk of reducing these strokes are very, very easy. If you put these patients on anticoagulation, there is a 67 to 75% chance that these patients can be protected from having a catastrophic stroke. So this is a stroke that is easily preventable, provided we get the diagnosis, we got the recording, we start them on anticoagulation. But unfortunately, I don't think we are doing this. Right, this is a small scale to explain that once you had a stroke, the exit from the stroke unit would be dependent on what your scales are. So if somebody is going to recover from stroke, all throughout the world we use a scale called the modified Rankin score, and it ranges from 0 to 6, 0 being normal, 6 being dead. So 3, 4, and 5 indicates that the patient has become dependent, 1 and 2 is independent. So if you look at the dependent arm, 3 means you have to possibly use an 8 to walk, 4 is wheelchair bound, 5 is hospitalized or institutionalized. So when you have an AF stroke, and if you come into the hospital, if you're not in the right place at the right time, the chances of somebody ending up to severe, moderately severe to severe disability is very, very high, and a big chunk of patients would also possibly die. So AF strokes are catastrophic, and I'll explain that why. Because we're all born with a small outpouching in the atrium called the atrial appendage. When the atrium is fibrillating, there is turbulence of blood in the atrium, particularly in the atrial appendage. The clot forms here and then goes into the systemic circulation. And once they go into the systemic circulation, this is the coronal section of the brain. This is the internal carotid artery. These are the big vessels that come out of the arch of the aorta through the common carotids. And the clot that's formed in the left atrial appendage gets blocked in either the internal carotid artery or the origin of the middle cerebral artery. So the whole surface of the brain, or 2/3 of the brain, gets stroked out. And that is the reason why when you have a cardiomyopathic stroke secondary to atrial fibrillation, your Rankin is possibly going to 4 or 5 unless you reach the hospital within an hour and a half, where you have facilities for thrombolysis and thrombectomy. Possibly then you can move from a dependent arm to the independent arm. But if you're delayed and if you have an AF stroke, you're going to be more or less dependent with the Rankin 4 or 5, either wheelchair bound or institutionalized. Atherosclerotic strokes occurs the small vessels of the ventricular striate branches. So the patients with the atherosclerotic ventricular striate branch strokes have a better outcome, you can move them easily from the dependent to the independent arm. Right. In practice, when I see a patient who's had a stroke, and when I think they have a large stroke with a dense weakness, with the higher motor function affected, with homonymous hemianopia, and when I look at the ECG, and the moment I look at a scan like that, my heart sinks, because I've seen that there is a thrombus called the hyperdense MCA sign. They have a large vessel occlusion, and we've clearly seen that the ECG shows AF, and I very well know that this patient is profoundly disabled. Unless this patient is in hospital within the window for thrombolysis or thrombectomy, the outcomes going to be poor. This patient did have thrombolysis, but you can see that we've not clearly shifted the clot, and despite thrombolysis in 24 hours, this person developed malignant MCA syndrome, where 2/3 of the brain was damaged. The only way this person can sustain survival is opening up a flap of brain called hemicraniectomy, and this is a sort of a very worse outcome. And that is the reason why AF strokes are catastrophic. And if you look at them, the overall 1-year mortality is very high. 60% die, 36% become dependent, only 4 of them become independent unless until you're in a good center. So overall, AF strokes, catastrophic outcome. The irony is these strokes are preventable. If you identify these patients, put them on the anticoagulation, there's a 65 to 75% chance that you can prevent these strokes. And there's a big drive with NHS RightCare, where you can clearly see atrial fibrillation is big on the agenda. It clearly says that the 30% of the patients are undiagnosed, or even if they're diagnosed, they are half untreated or poorly controlled. Anticoagulation shows that a significant number of strokes can be prevented, but we're still not doing that. And if you have an AF stroke, the outcomes are going to be significantly bad. Right. What about the prevalence? What we think the prevalence at present is 2.5%. And if you have an area where the monitoring is very poor, it's very underrepresented for a 1% prevalence. But I anticipate that the true prevalence is around 3.5 to 4% mark. So if you screen a lot of patients in the community by checking the pulse or doing an ECG when you have an irregular rhythm, they're going to pick up more AF. But at present, the prevalence is underestimated. Right. So what is the meaning of a cryptogenic stroke? Cryptogenic stroke, when a patient comes into hospital, has had a large territory stroke. When I say large territory stroke, one of the big vessels is occluded, either the ICA or the MCA, but we do not know where the source of the clot has come from. So we do a CT and MRI. We know that there's not a lacunar stroke, because lacunar strokes are caused by the ventriculostriate branches of the MCA, which are branch strokes. We look at the carotids. The carotids are not critically stenosed. We do a 12-lead ECG, which is a sinus rhythm, and we do not have any other evidence of arteritis dissection or vasospasm, and sometimes we see multiple cryptogenic strokes. If they fit into this category where you've done all the imaging and you're very certain that there's an embolic stroke from elsewhere, then it's more or less a cryptogenic stroke. So what's the pathway that we need to approach? If you know that it's a lacunar ischemic stroke secondary to small vessel disease and atherosclerotic stroke, you just do standard workup, look at the risk factors, control the diabetes, hypertension, vascular risk factors like hypercholesterolemia, lifestyle modification, put them on antiplatelets, and make sure that all the secondary prevention is covered. Somebody's got a documented history of AF on ECG when they've had a cardioembolic stroke, then you then commence them on anticoagulation on discharge. The starting time of the anticoagulation depends on other type of stroke or the severity of the brain damage. Again, this is a group where we are going to focus that people who have had multiple foci of infarction or watershed territory infarction or cerebral infarcts. We do a standard stroke workup. We've done MRI. We've done an imaging of the carotid, intracranial, extracranial vessels. We do not identify a source of the stroke. We do an echocardiogram. We don't find there is any clot. Then we do a 24-hour monitoring. Still, we do not find any evidence of paroxysmal AF, and all these tests are negative. Then we're going into the territory of cryptogenic stroke or TIA. These are the patients where we are debating about how long we should monitor. Over the course of the years, we do not do any significant level of monitoring. We were only doing 24-hour tapes. At the push, we can do probably 48 hours, 72 hours, or 5 days. But most of the hospitals across the United Kingdom, the practice varies. In our center, we can probably do 24 hours to 48 hours. But clearly, that is not enough. And there was a lot of anecdotal evidence saying that we do not know how long we have to monitor to pick up fibrillation, and that there was level 2B evidence saying that probably prolonged cardiac monitoring is beneficial, but it was very, very uncertain. But September 2020, NICE have published the guidelines on implantable cardiac monitors to detect atrial fibrillation after cryptogenic stroke. And in their recommendation, they have said the Reveal Link device, which is a monitoring device, is recommended as an option to help to detect atrial fibrillation after cryptogenic stroke, including transient ischemic attacks, if non-invasive ECG monitoring has been done and cardiac arrhythmic cause of a stroke is still suspected. So they clearly say if you do a 12-lead ECG, probably do 24 hours or 48 hours. If you're not diagnosed and you strongly suspect that person has an embolic stroke affecting a large blood vessel in the brain, then it is an indication to probably monitor them for a prolonged period of time. Okay. The evidence that the NICE looked at was a crystal AF study, which really was an international multi-center RCT, where they controlled controls where they were just standard clinical care practice, probably the 24 days, to look for paroxysmal AF, and the pickup rate at the end of 36 months was 3%. Whereas with the Reveal Link device, every 6 months there was a significant spike, but at around 36 months, there was a 30% increase in detection of paroxysmal AF. And that clearly indicates that the more we monitor, the higher the chances of picking up patients with AF. And this study concluded that 84 days is the median time to AF detection in cryptogenic stroke patients. And 88% of these patients who had AF would have been missed if only monitored for 30 days. So that clearly indicates that if you only monitor for 24 or 48 hours, probably we are going to miss 95 to 98% of patients who would have eventually had PAF or paroxysmal AF, where we would have missed the opportunity of anticoagulating them and preventing them from future strokes. So planning a cryptogenic pathway, how do you do that? At present, in our own hospital, we are trying to find out who will champion the effort. How are we going to define cryptogenic stroke? How are we going to have a protocol? Once a patient is deemed cryptogenic, what is a multidisciplinary pathway? We are looking at our infrastructure to see whether we're going to open the doors and floodgates for our cardiac department. And we know what the infrastructure is. Our band 7 nurses are skilled now to do the bring in the patient anticoagulated straight away. And we're going to monitor how many AFs are going to be picked up by this way over a period of 6 to 12 months, and how we're going to find the pathway. So clearly, there is a role for a prolonged cardiac monitoring as evidence, and the recent NICE guidelines has been out. You have to decide whether the patient is going to benefit from anticoagulation once you've made a diagnosis of blood vessel occlusion, which is possibly thinking of cardiopulmonary source. If no, then do not subject them to a Reveal prolonged device. If yes, either you can do this as an inpatient or an outpatient. Earlier the better. And once you had a clear inclusion and exclusion criteria, where the inclusion criteria where I said where you image the vessels, you 24-hour tape, you've done an echo, and they have a CHA2DS score of more than 2, but they've not had an AF on a 12-lead ECG. Those are the group of patients where you need to refer the patient for an implantable cardiac monitoring device. And if you at any stage feel that they are not going to be a candidate for anticoagulation or for left atrial appendage occlusion, then there is no point in referring. So in summary, what I just want to emphasize is it is very important that AFs pick up a lot of patients where we know are cryptogenic, where we think there's a large risk of occlusion, which is secondary to cardiombolism, but we do not know where the source is. If there's a high index suspicion that they're going to have paroxysmal AF, prolonged monitoring is the key, and the guidelines are supporting us. And in our own hospitals, we are going to try and get a cryptogenic stroke pathway in alliance with all the stakeholders, and we're going to move forward. I hope that's given an overview of identifying patients with paroxysmal AF who had a large risk of occlusion, where we think we've not picked up on their standard clinical assessment and screening. Many thanks.
Thank you for Medtronic for offering this pre-recorded talk. Sorry, there was some sort of a noise in the background, might be because I have to keep my mic open. I'm sitting in my office, might be the porters are taking trolleys outside my office, that was making a little bit of noise. So, but this whole webinar would be recorded, and we'll share the link with everybody who is registered with us. So we'll be able to make sure that you should be able to see the recording of this webinar. So without any delay, I would like to ask you, number one, first of all, thank you to everybody for attending this webinar. And thank you to my speakers who has made it a wonderful day, put a lot of effort in presenting their presentations. And my team, Lynn Young, Sarah Bagley, Shabana, they have worked hard, especially Lynn and Sarah. They worked really hard to make it successful. And we would like that, and to first of all, thank you to Medtronic also and Rawalpindi Medical University alumni. We'll be doing more of a teaching program in future because of the COVID. We'll be thinking it, most of the might be this year and next year might be most of the webinars or conferences would be live. Would like to know from you whether you would be interested to hear from us if there's any further training days happen either in stroke medicine or acute medicine. Good to know from you whether you think it is useful to be part of this. And please, if you don't want that we should communicate with you, please mention it in your email so that we should not disturb you. But people who are interested in would be happy to email them so that we make sure that you should get the invite so that you can register if you are free at that time. And so in a nutshell, I will say your CPD's point would be given to you once we'll receive your feedback. So please feel free, and in next 24 to 48 hours, if you can fill up your feedback, would be happy by next week you'll be able to get your CPD certificates. And unfortunately, we are not able to interact, so I don't know whether you like it or not. It is unusual circumstances. Otherwise, I would like to hear from you and people. It is a bit strange that you're sitting in your office alone, talking to more than 200 people. Roughly more than, I think 260 delegates has attended the presentation today. And I'm quite impressed with the attendance and the colleagues who have attended throughout the day. So I hope you will take some useful messages home, and looking forward to have you again in future master classes. Thank you. Take care. Bye-bye. Look after yourself. Bye-bye.
Thanks very much. Bye-bye.
Bye-bye.
Thank you, Asem. That's great. Thank you.